ये देखिए ये वाला भी ये लगा है। ये स्टेबल रहता है ये, लेकिन ना एक 5 मिनट के बाद ना हल्का सा ना ये हल्का सा कलर बार दिखा के भाग जाएगा, पता नहीं चलेगा तो। ये स्टेबल है ना? स्टेबल है ना? फिर जरा मैं माइक में बात कर रहा हूँ, जरा बात कर, जरा माइक ला बेटा जरा। अरे कैसे उधर?
Yes, sir.
Okay, when do we start? Because it's already 9 o'clock.
Yeah, actually, we were about to even start. Kirtane sir will join in 5 minutes.
Hello,
So,
good morning.
good morning,
Hello.
ma'am.
Good morning. Good morning, Dr. Janki. Can you hear?
Good morning, Dr.
So
Nupur,
we were
madam.
planning-
Yes, sir.
So we were planning to introduce madam.
Okay, when do we start? Because it's already 9 o'clock.
Yeah, actually, we were about to
Around 9:15.
even start.
But I'm ready
Kirtane
whenever
sir
you
will
like.
join in 5 minutes.
Hello,
So,
good morning.
good morning, ma'am.
Good morning. Good morning. I'm ready whenever you
Good
guys
morning,
want to go ahead. Yeah.
Good morning, Dr. Nupur, madam.
Sir, so we were planning to introduce madam.
Okay, when do we start? Because it's already 9 o'clock.
So, sir, by the time can we start the introduction, please?
Immediately we join in 5 minutes. Hello. Good morning. Good morning.
Good morning.
Good morning.
So it is my honor to introduce a beautiful lady today, Dr. Nupur Kapoor Nerurkar, consultant laryngeologist and head Bombay Hospital Voice and Swallow Center, DNV coordinator for ENT and laryngology, fellowship director, is instrumental in teaching in prestigious Sion Hospital for around 12 years, 18 years as a laryngologist at Bombay Hospital, Har Govind Fellowship Award for laryngology training in USA, Area of interest for her are laser surgery, neurolaryngology, phone microsurgery, ADST, LEMG, professional voice, office procedures and dysphagia, and etc. She is a past president of Association of Phonosurgeons of India in 2013 to from 2013 to 16. She has established the Bombay Hospital Voice and Swallowing Department, first and only Indian laryngologist to become a fellow of the American Laryngological Association and the American Bronchoesophageological Association, chief editor of textbook of laryngology and author of Atlas of Phonomicrosurgery. She is gold medalist in junior and has junior consultant award and first prize in Jaiswal video session AOI Hyderabad in 2005. She has got third prize as in senior consultant award category AOI Bhubaneswar 2007. She has David Howard Prize by the British Laryngology Association, Malaysia 2012, founder and board member of International Association of Trans Voice Surgeons. I request Dr. Vijay to introduce and invite the panelists, please.
Yeah, thank you, Dr. Archana. So I take honor to invite today's chair, Dr. Drubajyoti Mukhopadhyay. Welcome, sir. Please be on the dais. Dr. Amit Bhandari. Welcome, sir. Please be on the dais. And Dr. Rupak Kumar Goswami. Welcome, sir. Please be on the dais. So we have Dr. Drubajyoti Mukhopadhyay, who is a faculty DNB Oncosurgery, Saroj Gupta Cancer Center and Research Institute, Kolkata. Presently honorary visiting surgeon and in charge, Department of ENT, Saroj Gupta Cancer Center and Research Institute, Kolkata, Aurobindo Seva Kendra, Kolkata, and Tapan Sinha Memorial Metro Railway Hospital, Kolkata. Welcome, Dr. Mukhopadhyay. Now we have Dr. Amit Bhandari with us as a chair. Dr. Bhandari is the MS from JLN Medical College, Rajasthan, Senior Residency Department of ENT, SMS Medical College and Hospital, Jaipur. He has been awarded by Dr. K.R. Lodha Gold Medal for Postgraduate Quiz Competition in Rajasthan Conference of Otolaryngology 2006, held at Jaipur. The Best Temporal Bone Dissection Award at Madras ENT Research Foundation, Chennai, July 2010. Young Achiever of Rajasthan, awarded by Rajasthan State Branch AOI 2017. So welcome, Dr. Bhandari. And we have Dr. Rupak Goswami with us, who is the HOD DSP Hospital, Durgapur. He has presented his papers in different national as well as international conferences. His special interest in rhinology and otological surgeries, and Secretary Ethics Committee, National Board of Examination. So we welcome Dr. Goswami, and we welcome all three chairs for today's session, who will be done by Dr. Nupur Kapoor Nerulkar. So over to you, ma'am.
I request Kirtane sir, because sir feels he want to talk about Nupur madam, Janki sir, and the program.
I just requested Nupur. She was ready at dot 9 o'clock to start, but I said people were working very hard till late last night, and so they're all here, and I think by 9:15, and she's going to show you right from intubation and induction of the patient to the procedure. So we'll wait till 9:15. Give her a few minutes. Nupur, is that okay?
Yes, sure, absolutely. Whatever suits the program.
Okay.
Sure.
I think you should ask.
Morning, Professor Kirtane, sir.
Hi, Janki. How are you?
Sir, with your blessings, I'm fine, sir.
Are you feeling better?
Slightly better, sir.
No, you better be much better, because we are waiting to watch you operate today. The auditorium is just eager to see your skills, and so you take something just now and get quickly better.
Thank you so much, sir.
All right. Well, I'm sorry to say that your son is more handsome than you are.
The handsomeness should be inside the skull. That is more important.
That I'm sure genetically it will be there, not to worry. He looks like a movie star. So that you don't make him do what you did all that.
No.
Movies and all. Okay. All of you know that, right? That he's acted in movies. He's got his own band. This ENT is just sad, by the way.
So, if I may just share an anecdote.
Go ahead.
Madam,
we were
Nupur, madam, I think your voice is a little feeble. Can you
Muffled?
ask somebody to increase your
Yeah,
voice?
I think she needs to consult a good voice surgeon. Yes.
No, no. The audio visual.
Can I be heard clearly now, or it's
A
still
little
muffled?
louder, please, Nupur, and the anecdote.
Can
Yes,
you make
we're
it-
waiting for that.
Can you make it louder from our end?
You can keep the mic closer to your mouth, madam, because it's you're wearing a very.
It's yeah, it is. Is it better now?
Now
Janki?
it's better.
No, it's
Much
better.
Better?
Much better. Yeah. Yeah.
I was just going to share the anecdote, Janki, when you invited us very graciously, Jaikumar and me, to your hospital, and I had not met you then ever. And we were coming to your hospital, and we were told that he'll meet you in 5 minutes. He's out shooting. And I thought, oh my God, he's a hunter also. That's amazing. And they said, no, he's a movie star and he's shooting for his movie. So that was my first introduction to you. And it got more fascinating every day. So it's very interesting.
Madam, really, I extend my thanks. When I was not known at all, I invited you, and you were so nice to come out to Trichy to demonstrate. I still remember some cases you demonstrated, still ringing in my ears and
It's
eyes.
a pleasure.
Fantastic surgeon, madam, you are.
Thank you. It's a
India
pleasure.
is proud to have a laryngologist like you.
Thank you so much, Janki. Thank you.
Nupur, while we've got 1 minute to start,
Yes, sir.
would you just like to tell them about your upcoming workshop in November?
Absolutely.
Go ahead.
So on the 3rd, 4th, and 5th of November, we have the 17th workshop on phonosurgery. It's a very special one this year, though it's a 17th one, because the first day is dedicated to the International Association of Trans Voice Surgeons. So this was an association formed last year in Berlin. I'm very honored to be a part of it, the only Indian. 13 of us formed it. So the first day is going to be based not only on pitch increasing surgery, but pitch decreasing surgery and the other topics associated with voice for trans voice people and also for people who need to decrease their pitch. So we have a plethora of international faculty, about 15 people coming in person to Bombay Hospital. And the first day would be that. And the second and third day is going to be incredibly interesting too, with live surgery, airway, swallowing and voice lectures, panel. There's going to be porcine cadaver dissection. There's going to be instructional courses with the CO2 laser, with the blue laser. There's going to be some very interesting talk with a 4D demonstration of stroboscopy, and there's going to be a stroboscopy workshop. So it's really going to be an academic bonanza. Anyone who's interested, please do check the website, which is www.phonosurgeryworkshops.com. And you will get the online link for registration, etc. I look forward to seeing a lot of you there.
Phonosurgery or phonosurgeries?
No S, sir.
No, yes. Phonosurgery.
Workshops.com.
Workshop.
I think you see it, a little thing I think Deepak has put up on the slide. Maybe you can see it down there.
Yes.
Phonosurgeryworkshops.com.
Workshops.com.
Yes.
That will be a tremendous update on your knowledge on voice, because you'll see surgeries, you'll see what you do routinely being put over there on the screen and the cutting edge technology of what is very new. So both aspects, what you can take back home to your practice, and you also know what is happening in the world of phonosurgery. So it will be a golden opportunity for those interested in voice to join there. Yeah.
Yes.
Okay, Nupur, I think we are ready to go.
To start?
Over to you. Yeah, please.
Okay, thank you. So just at the outset, I want to thank Sun Pharma for this amazing academic initiative and second season. I feel like I'm part of Big Boss now with season 2 and with Janki involved. I also want to thank Dr. Janki for keeping me involved. It's very kind of him. But very importantly, I want to thank Dr. M.V. Kirtane, our teacher and mentor, because A lot of us who are operating today, Dr. Sangeeta Varti did the most amazing cochlear implant yesterday. And a lot of us who are operating and getting an opportunity to show our surgeries are on this platform because of Dr. Kirtane. I really mean it when I say that he has given an opportunity to innumerable students of his. And that's something which only a very amazing teacher can do, to teach you and give you an opportunity to let you grow. So thank you so much, sir, from the bottom of my heart. And thank you, Janki, and thank you, San. So we are going to start. Last time, a little bit of the feedback was that we'd like to see from the initial beginning. And that is a very good suggestion, because in microlaryngeal surgery, what happens in intubation can play a huge role as to what happens as far as your laryngeal exposure is concerned. So we have a very cooperative and nice patient with us today who's given permission to be part of this workshop. So we are going to start with the intubation first. Then I'll take you through the various tubes which can be used, the instruments, the PowerPoint, and then the actual surgery. So the patient's been waiting for a while on the table. So we will start with the intubation. We have the head of Department of Anesthesia, Dr. Pradnya Kulkarni here, who's come Sunday morning to help us with this case. So we are going to start with the intubation of the patient. As you can see, the patient does not have any, can you focus here please now, not the PowerPoint? Can we put the PowerPoint off for now? Or at least put it in PIP. The patient does not have any retronathia. आप मुंह खोलेंगे?
Sorry to interrupt. Please make it full screen.
Can you please make the patient full? Thank you. मुंह
Yeah, now we
खोलेंगे
can
एकदम?
see. Now we can see.
So the
That's
mouth
fine.
opening is good. Malampatti is grade 1. मुंह बंद कर लीजिए. There is no retronathia. There are no loose teeth. One can even check the angle. Okay. Is my audio heard okay?
Yeah, absolutely okay, ma'am.
Yeah, okay. So one can even do an upper lip bite test or a 332 test. These are all tests one can do for assessment of intubation. We are not expecting a difficult intubation in this particular patient. Ma'am, over to you. So typically what we do when we are inducing our patients is I'm standing right there on the right-hand side of the patient. Ma'am is at the head end, and we will give oxygenation to the patient for about a couple of minutes for sure. If we expect a difficult intubation, then maybe 5 minutes of pre-oxygenation is a very good idea. And what we keep over here is a gauze piece with jelly. So can we keep it over here, please? And that is just for the tip of the tube. I'm going to separately show you all the tubes, but give me also a 5.5 laser safe tube in my hand right now, please. Yeah. Just open that and give it to me.
That's flexometallic tube.
Yes, exactly. I'm going to show it to you right now as we are oxygenating the patient. So this is known as a Mallinckrodt laser safe tube. Since a lot of the surgeries I do are with a laser, we tend to intubate the patient with a laser safe tube, regardless of whether we are going to be doing a laser case or not. Most of the time it is a laser case. I would like you to is pe focus karna. Can you see that there are actually 2 cuffs
Yes, ma'am.
to
We
this
can see.
tube? You can see that. And that the tube is made up of stainless steel. But it is still flexible. So it's a flexo metallic tube.
Ma'am, this is a reusable tube? This is a reusable tube?
Yes, the company, like most companies, will say use once, but we are using this at least 3 times.
Okay, okay.
So the cost comes to about 3,500 per use, which is not humongous, right? And it's extremely safe tube. Now, what you see here are 2 cuffs, a blue color cuff and a white color cuff. The blue cuff basically suggests that this is filling up the proximal cuff over here. And so if the pressure dips over here, you know that you may have ruptured your cuff, and it gives you a warning, and it's typically got a little bit of methylene blue, so you can get a discoloration in the field. After the first use, sometimes the methylene blue disappears. It's up to you whether you want to inject that. Now this, what I have in my hand, is a 5.5 number tube. This is what we are using for adult male patients. एक स्टिलेट दिखाना मेरे को. For females, we use a 5-number tube. In case we have a slightly difficult laryngeal exposure, then we do railroading. And we all know what railroading means. We'll put a little bit of lignocaine jelly at the tip of the stillet and of the cuff, and we will railroad the tube over the stillet so that the anesthetist can put just the stillet in, and then we'll feed over the tube. Now, if even the anesthetist has even no visualization of the arytenoids, then we can do an awake intubation where we use a flexible laryngoscope, and I have that trolley right here, just the intubating flexible bronchoscope actually. And instead of taking this stillet, we are railroading this tube over the flexible bronchoscope, intubating bronchoscope. So that is done awake while the patient is sort of awake, completely breathing. You will put the channel of the scope into the vocal folds and then feed the tube over it. So these are the various techniques we can employ for intubation.
Madam, in which cases do you do awake in this?
Awake
Yeah,
intubation is
yeah,
done for
intubation,
cases where you cannot even see the arytenoids. So then the anesthetist is not able to even put a stillet in. So then we'll do an awake intubation. Right now, I'd like to just show you the intubation attempt which is being made, and ma'am will tell me how is the larynx. Larynx is good. Now, since I've put the stillet in anyway, I'm not taking it out. I'm leaving the stillet in. You see the stillet going in. When she's confident it's gone through, we feed the tube. I take the stillet out, and the tube will always be taken to the left-hand side. Regardless of whether the lesion is on the right side or the left side, we take the tube to the left-hand side of the patient because I'm introducing the scope from the right-hand side of the patient. It does not come in the way at all because it lies in the posterior larynx where the airway is, in the interarytenoid area. Now, as you can notice over here, what we are putting in the cuff is not air, but it is cold water or cold saline. The reason being because we're doing a laser case. In case the cuff gets hit by the laser beam, we don't want a laser fire. So we've got the dampening solution of the saline. Then the second laser precaution which we take is we will cover the eyes with moist gauze pieces. So first, of course, we'll put the micropore because we don't want the water to enter the eyes. And then we'll have the moist gauze pieces, which will cover the eyes of the patient. So can I have the moist gauze pieces? Coming a little bit to the position of the patient, moist.
Ma'am, can I request
Can I
something?
just show this? Yes, ma'am.
Ma'am, for awake intubation, there are certain prerequisites like spray and all. Can you please explain, because most of them must not be aware?
Sure, absolutely. Can I just show that I'm putting moist gauze pieces over here? And I will definitely come to your question. I just want to mention about head rip. I want to mention about the position of the patient. So typically what has been described, thoda zoom out kariye, aap thoda piche le jaiye, is a Boyce's position, okay? So a Boyce's position is typically going to be a flexion of the head on the neck and an extension of the atlanto-occipital joint. But what I like to use, and that's what I'm showing you, is a neutral position. So here right now, there is no shoulder. There never is a shoulder under the patient in MLS, but there is no head ring either. This is just a neutral position. This is a position I always like to start with. And if required, only then I move on to a Boyce's. And even if that is not good for me, I can sometimes do a flexion position, which has been described also by Dr. Steven Zeitels. So after having put the moist gauze pieces on the eye, I'm covering up the head. And the other thing which we keep ready, over here you see, can you see over here? Idhar zoom karenge. This is just a gamgee here. This is kept on the neck of the patient right from the beginning. And this you see over here, this is a tape. It's made into a braid or a plait by my OT technicians because it just helps for a better anterior compression of the larynx when needed. So when we need to use this anterior compression, how we do it is we have this braid tied to the side of the patient's table, as you can see here. That one tie is done already. Then we have the braid here, and if compression is needed, then the compression is given over the cricothyroid membrane. You see the thyroid notch of the patient here. We don't give the compression on the thyroid or on the cricoid, but on the cricothyroid membrane for two reasons. One is cricothyroid is a membrane, it's forgiving, it's not going to fracture. And that is what causes a very good laryngeal drop along with a good amount of relaxed general anesthesia. So under visualization, we give this pressure, and that is when my assistant would tie the other side. So we'll show it and demonstrate it to you. Now, as the question was that if we are going to be doing an awake intubation, what are you going to do as far as the anesthesia is concerned? Not only would we give anesthesia, but we'll decongest the nostril a little bit with some kind of a decongestion. We'll give the 10% lignocaine spray from the nose and from the mouth. We give that spray about 2 to 3 times. And sometimes we even do a lignocaine viscous gargle for the patient. What is very important also is to just counsel, because the patient is completely awake, to counsel the patient as to what we are doing and that he or she is not in any kind of a danger. And that is when we do the intubation, and we do not do it from the mouth. We do it, we do not do it from the nose. We do it from the mouth. So show me that oral airway jo rakha hai. So it's very important not to have your scope get damaged. So what we do is we put a mouthpiece, just bring it in here, please. Have the patient hold it in between his teeth, because that time the patient is awake, of course. And you can you just move so I can see? Thank you so much. Yes. We don't want the patient to bite it. So we put this in, and through the lumen is where we do our scopy and intubation. No, we're not doing it now. The patient is induced. I'm going to now ask them to put on the PowerPoint of the patient. Maybe just show you a small PowerPoint of the case we're doing. You can take this out. And before we go on to the PowerPoint, I'll show you the Mayo's attachment also. Okay. Oh, PowerPoint pe hai. We're showing you the short PowerPoint of the patient. Tab tak aap Mayo's laga do. Now, this is a 38-year-old male patient who's a businessman. He's got a change in voice since about 2 months. He's taken steroids. He's taken voice rest. I think he's also taken some therapy. I think his major concern is malignancy, because he knows he's been using tobacco. But the lesion he has, he's been told it's 99% polyp with a small contact lesion. However, it's not really improved. And we know polyps don't very often improve. So we're doing an excision for that. His MPT is 10 seconds, and maybe we can move forward and show this. These are the still images of the stroboscopy done, which you see that there's a polyp on the right striking zone with a tiny contact lesion on the left side. And there is still a little bit of hemorrhage on the right side in this image. Can we move on to the next, which is the stroboscopy video? Can we play that, please? Yeah.
First leg में right leg. Laam shots. नाकातून कसं करतो आपण? परत एकदा. परत एकदा.
Can you play it again? You please notice the aperiodicity of the mucosal waves, the supraglottic squeeze. If we can play it again one more time.
First leg में right leg. लांब श्वास नाकातून कसं करतो आपण
What is aperiodicity?
परत एकदा परत एकदा
Starts vibrating in the cycle earlier than the other. I call it like dancing waves. This happens whenever there are lesions. You want good symmetry, ideally. We can see that polypoidal lesion in the striking zone. We know that most of these lesions, like polyps, nodules, cysts, which are phonotraumatic, do take place in the striking zone. What is the striking zone? Mid-membranous, or if you're considering the even cartilaginous vocal fold, then anterior 1/3. Do we have a CVA next, computerized voice analysis? Okay, this is the voice of the patient. Yes, please play it. The E showing the MPT of 10 seconds. We do a voice recording of every patient and we keep it stored in our voice bank. Just very useful sometimes in some patients, whether you want to assess for study purposes or otherwise. Can we have the next slide, please? This is the computerized voice analysis. Again, more useful if you're doing studies rather than anything else. Here you can see the jitter, shimmer, the Surzer ratio, and any etc. Next, please. Is there anything else? Okay. So we'll come back onto this. We can put off that PPT, please. And can we have a big, yes. Just want to show you, thoda zoom out karenge. Zoom out. Ye dikhana hai. This, what you see, is the Mayo's trolley, which has been sort of tweaked a little bit so that the side arm can fit onto the side of the table on both the sides. So what happens is the chest piece can be kept on this Mayo's trolley so that whenever we have to move the table up and down, the whole system moves up and down. Secondly, the pressure of the chest piece is on the Mayo's, and this Mayo's is not in communication with the chest of the patient. So there's no direct pressure on the chest of the patient. And thirdly, when we use a Mayo's, which is slightly higher than the chest, the extension is actually a little bit better. So these are the three advantages of using a system like this. Finally, you can also put, please cover, some basic instruments on the Mayo's if you want, besides a chest piece, like for example, a suction, or, so that's just like an added benefit. Any questions till now? I'm going to now actually ask you to show over here. I'm going to show you the instruments before I start the actual surgery as to how we set up our zoom out. Yeah, how we set up this is our basic instrument tray. Let me know if you're not seeing what I'm showing you. We've already discussed the Mallinckrodt tube in detail, so we're not going to discuss that again. We don't typically keep that on the trolley. These tubes used to be available, but Zomed has stopped making them. These were laser safe tubes, which are much thinner, only single cuff, but much thinner. So in some difficult laryngeal exposure cases, they were very useful, because it gave you that little fighting extra millimeter of space. And finally, for the pediatric age group, you get small children sometimes with papilloma, even 2-3 months old. We don't have the Mallinckrodt tube available. So if you're going to be using a laser, then we still resort to a red rubber tube. You may or may not want to cover it up with some silver foil. Again, of course, single cuff. Coming to the arrangement of our trolley, basically, what we have is saline adrenaline 1 in 10,000 solution, which we're using for infiltration. The infiltration is performed by a bayonet-shaped infiltration needle, as you can see over here. This is about 22 to 24 centimeters in length. And the tip here, you can see this is very thin. It's about 27 number. The idea is to just poke underneath the epithelium to cause a subepithelial infiltration of this 1 in 10,000 saline adrenaline. Multiple advantages of doing a subepithelial infiltration. Hemostasis is one of them. When you're using a laser, you create an artificial Rinke space, which works like a buffer. In malignancy cases, it helps you in demarcating the depth as well as the margins.
Donut sign.
Again, yes.
Ma'am, donut sign.
What size?
Ma'am, donut sign that you usually teach like after.
Oh, the donuts. Okay. The Meduvada donut sign. Okay. Can I show that to you when we are doing the infiltration? It may be easier.
Absolutely.
Thank you. So another bayonet-shaped instrument is our microflap suction. Again, this is a very thin suction. Sometimes you can have a velvetized suction where the suction opening is on the side rather than on the tip. Now, what you see over here, these are the two instruments one really can work with very well. Can you zoom on this? These are our Boucher forceps or the heart-shaped forceps. I'll just open one of them. So I'm sure most of you are very familiar with it, but in case somebody is not, can you see the heart-shaped opening?
Yes,
Can you
yes,
see that
ma'am, we
there's a
can see.
lumen within it? So
Right,
this
ma'am.
lumen is very useful because it doesn't morselize the tissue. At the same time, it gives you a very good grip. And
That's
you
right,
can
ma'am.
have right-sided, left-sided, upward and straight heart-shaped or Boucher forceps. And the earlier on our instruments used to be 1 millimeter tip. And now we have moved, they used to be 3 millimeters. And now we've moved on to 1 millimeter tip, much smaller. So because we are doing a lot of phonomicrosurgery. Besides that, we've got over here regular straight crocodile forceps, which you need for putting the patties in and out or the cotton ball. And then I like this handle very much, on which you have the flap elevator attached. So as you can see, this handle is again shaped so that you have a very good thumb rest. Can you see my thumb rest here? This is the thumb rest. And this has got a micro flap elevator, which we can rotate by 360 degrees. This micro flap elevator is an instrument, which is again extremely useful because it is blunt. So when you're doing cyst surgery in particular, it's very good in elevating the flaps because it doesn't burst the cyst or rupture it suddenly. So that it's very useful for that. Then you have, of course, your right and left crocodile forceps over here. I use less and less of this because I use more and more of the heart-shaped forceps. If we are not going to be using the laser, then having the very sharp scissors, right, left, straight, it's very important. We also have a system in a hospital where we have scissors which are used for 3 times and then actually thrown away and we get new ones because the sharpness is very important. Can you zoom over here now, please? So as you see over here, we have a 10 millimeter 0-degree telescope. Why we have it is to take a preoperative photo of the patient before surgery and after surgery. We are typically not giving the CDs of the surgery because very often that creates more issues and questions, but we give the photos as a proof. Papilloma has been removed because it can recur. Keratosis has been removed because if it recurs, you have shown the patient that you did remove it all. And now we come to this scope, which is our like bread and butter scope. This is your Klein-Sasser laryngoscope. The Klein-Sasser laryngoscope is the best scope to use, especially when your anesthetist has told you that the laryngeal exposure is reasonably good. What I want to just mention is the size. In our Indian population, do not use a large. Typically, it is the adult medium size, which is more than sufficient. Of course, some larynxes which are very big, you can go to a large. Some which are small, you may have to go to smaller. But ideally, you're using medium size. So if you're going to buy a laryngoscope in your private practice, that's the size you want to buy. And then finally, if you buy this one instrument, the scope, I have no shares, unfortunately, in their company or anything, but if you buy this Dido laryngoscope, you really will not have a situation where you could not expose the larynx, I think. It's a real go-to laryngoscope for the difficult laryngeal exposure. What you can see in this Dido laryngoscope is that actually the lumen first becomes little narrow and then you get a gentle flange. The problem with many of the anterior commissure scopes is they get very sort of over-ambitious with that flange. And when you have a very over-ambitious angle to the flange, that itself becomes a problem. So this is just beautiful. And again, this is a medium-sized Dido laryngoscope, very useful for the difficult laryngeal exposure. Since we do a lot of laser work, we use laser suction. So this goes into the channel like this on this side. You know, for the plumes, as you mentioned, this is for the plumes of the laser suction. And then on the trolley, you'll also find that there will be a tooth guard. Okay, more important for the upper teeth. This is a very useful instrument for the light. You can attach it. This light clip can be attached to any scope as such, and it provides a brilliant illumination. So you just put your light cable over here. And of course, over here on the trolley, we also have our chest piece and our patty. So this is our basic trolley. Just zoom out and show the basic trolley. This is how we would set up the trolley for every MLS case. But there is a second trolley kept if needed. This is the second trolley, which usually we don't need, but if it is a very difficult laryngeal exposure, then what you can do, one of the options is use a 30-degree telescope, which you see over here. And by the side of it, we have created many, many years ago, along with a company in Mumbai, these flexible tip instruments. So as you can see, the flexible tip instruments can be bent. Can you see that? They can be bent.
Yes,
So
ma'am.
you
Yes,
use
yes.
it
Very
along
nice.
with the telescope, which is, so it's very frustrating to put a telescope in 30-degree and be able to see the lesion, and then your instrument can't reach it. So it's very useful to have these flexible tip instruments. So that is one way out, especially if it's a polyp or a tumor which you just want to take a biopsy of. With a cyst, it would be a marsupialization, so that's not an ideal situation, but at least you can do it. And then we also keep insulated suctions, insulated crocodile forceps. These are useful when you do surgeries like Kashima cordotomy, where you may get bleeding when you reach the inner perichondrium of the thyroid cartilage, or when you're doing a malignancy, TLMC cordectomy, then they are useful along with the cautery. Sometimes the false vocal fold is prolapsing and you cannot see the lesion very well, or sometimes you want to see into the subglottis, then this instrument, which is the vocal fold separator, is useful. So this can be also part of your armamentarium of instruments. And then over here, we have an instrument which we use more for malignancy. It's a grasper. When you have a large tumor, it's a very nice grasper to hold the tissue, obviously not for phono microsurgery. And sometimes when we are operating, we realize we need to throw in a suture. Like you do a ring case edema and you want to suture the flaps together. Then what we do is we take a 6-0 Vicryl. It can be 3/8 tip or 1/4 tip, and we will have this needle holder. So it's like a crocodile only at the tip, but you see there's a lock and ratchet system over here. So, it holds the needle very nicely in place. You can take a suture and then you slide that suture down with the knot slider. So which is just like basically a claw, and I'm sure you all are very familiar with it, maybe in nasal surgery also. So we have the knot slider. You can take the knot outside the scope and then slide that knot down. So that's for suturing. And these are just various other scopes which won't come so much into play. I mean, this is more for supraglottic malignancy, the VIDA. This is what an adult large laryngoscope looks like. See how huge it is. This is much too huge for our delicate Indian population. So this is the if needed trolley. And then, of course, we've got the flexible intubating bronchoscope on another third trolley, which we don't need today. So I'm going to actually start with the microlaryngoscopy in case there are questions about the instruments. Happy to take them now.
Thank you so much, ma'am, for this elaborative information. It reminded me of my ENT examination. We were scared about the examiners asking such instruments to us, many of which we normally don't see. There are certain questions, ma'am. I'd like to take.
Can you make them louder, please? Can you make them louder?
Sure, ma'am. Can you hear me now?
इधर से excuse me, एक मिनट उनको आने दो. आप इधर दिखाना है थोड़ा सा स्कोप भी करते हुए. हाँ. What? Yes, please go ahead with the question.
Yeah. So, ma'am, the question is why you have chosen awake intubation. Dr. Annapurna Rao wanted to understand.
I haven't chosen awake intubation. Ritesh, can I have the stool, please? I have not chosen awake intubation. We did not when we say awake intubation, that is when you put a flexible laryngoscope and you're railroading the tube over it. I was just describing how it can be done in a patient in whom even seeing the arytenoids is impossible with the anesthetist laryngoscope. In this patient, we did a regular intubation. And in fact, when the anesthetist intubates is the best time you know how your scopy is kind of going to proceed. Because the anesthetist is going to tell you what is the Cormack-Lehan grade of the larynx and are you going to face a problem.
So, can I add something from my side, being an
Please.
anesthetist, ma'am?
Please.
Actually, the worst scare for the anesthetist is you cannot intubate and you cannot ventilate. Okay, so when you have certain cases where you are not sure about whether you can intubate, it is always safe to have a awake intubation.
Yes, absolutely.
Multiple things we can do prior to intubation, anxiolytics prior to surgery, like day before or 2 hours prior, then the spray as madam has explained. And then in awake intubation, you will not induce the patient in sedation, and with the local spray and other prior procedures, you can intubate the patient with patient's cooperation. So
yes, you won't paralyze the
land
patient
up into the
trouble.
Not able to intubate situation. So here, madam were telling about awake intubation because they were prepared for the awake intubation. But when anesthetist madam could see that the situation is good for intubation, they went ahead with the induction and did the intubation. Ma'am, the second question is the flexometallic tube. Why we particularly choose that?
Because I plan to use a laser. This is a good opportunity for me to even show you that. Since I'm going to use a laser, I have to use a laser safe tube. And the safest tube in the market is a flexometallic tube with a double cuff, because stainless steel is laser safe. This is now the...
Ma'am, 2 more questions can I take?
Yes, absolutely.
How do you handle cases with restricted mouth opening?
If it is possible to intubate the patient, then I go in with a smaller size scope. If it is impossible to do it, then I would do it as an office procedure, because we can put a flexible laryngoscope or bronchoscope, and through the side channel, we can put forceps or we can put a fiber laser. Now, let me, since your question has taken me there, let me show you the laser system. This is a laser system which we are using, which is a CO2 laser system. And you see over here, there is one arm, which is the articulating arm, which is a free beam, which has to be used with the microscope, with a micro manipulator. But it also has a channel over here through which a fiber laser can be used. Now, CO2 is also available in fiber laser. So then that fiber can go through the side channel of the flexible scope, and we can take care of a patient who's got zero mouth opening or restricted mouth opening. Today, I'm going to be using the free beam laser, which is attached with the micro manipulator. Turn karo. I mean, since your question led me there, let me finish showing the micro manipulator before we go into the surgery bit. This is the micro manipulator. And what I'm holding, and what you see over here, this is the joystick. When I move the joystick, my laser beam will be moving, and I can turn the joystick by 360 degrees. You will see all that happening inside when we are operating. That is just to tell you the laser settings, and we are going to use no nitrous oxide. Ma'am, nitrous oxide is off, and we are going to have an oxygen supply, which is maximum 25%. The rest is atmospheric air. What was your other last question, please?
Ma'am, the question has 2 parts. Many times putting the ML scope becomes very difficult, and we can barely see the posterior part.
I'm going to take that question as I do the ML scopy, if you don't mind. I'm going to address it. So I'm just showing you here that we make this kind of pocket and system, and we attach it here to the head end of the patient, because I find it very useful to put my suction in this pocket so that every time the assistant doesn't have to give it to me, and I just put it in the pocket. I'm sitting right here and I take it out, put it in. Similarly, I take the laser suction, which I need for my cases. Sometimes you need to take it out. So I can put it in and take it out from here. Now, I just want to address the question about doing the ML scopy and difficult laryngeal exposure as I'm doing the scopy. That was the idea. So just to tell you, this is a tooth guard, which is going to protect the upper teeth. We typically are not using, the assistant will hold the chin down. Typically, we don't use 2 tooth guards unless we find that there are some loose teeth which we want to address and protect in the lower alveolus. Now I want to show that this is the, ye dikhayenge, please. I'm using a regular medium-sized adult clients as a laryngoscope. And you see the light clip over here, the one which I had already shown you. We attach the light cable over there. And you know the whole setup the way it is. Now let me show you how we approach the scopy, and that time I'll also talk to you about difficult laryngeal exposure. Can I have the light on, please? आपको थोड़ा उधर जाके ये दिखाना होगा जो मैं कर रही है, and वो light आगे लाना. Just bear with us a little bit. The camera is shifting so that I can get my light. Now what I'm doing is, I've put a tooth guard. My assistant is holding the lower lip and chin down for me. Can you see me? I'm introducing my laryngoscope. ये दिखाएंगे ये जब मेरा जो हाथ में है ये.
It is not proper.
I have used my index finger to get the tongue out of the way. I'm introducing the laryngoscope first at 90. Sir, आप ये दिखाइए ये. हाँ इधर से लाने दो. आप पीछे से आओ, पीछे से
दिखाने से I think that is a better option.
हाँ जी, ये आप इधर लाओ. खाली गए पैर जवर. सर उसका संभालना. हाँ लाओ प्लीज. इधर आओ मिस्टर, इधर आओ. आता मला दिसत नाही मॉनिटरवर, त्यांना काय दिसते. हाँ बस टर्न करिए ना. Why is getting confused? Just turn करिए ना आप. Sorry guys, I have no idea what you're seeing because now my monitor is blocked. British मेरे को बताओ उनको दिख रहा है मैं क्या करें. आप थोड़ा नीचे जाओ तो मेरे को दिखेगा.
Nupur, I think we can see you from the side, so it's okay. Go ahead.
Okay, fine. So I've got my scope in at 90 degrees. Then I go, yeah, you can leave. Then my assistant can let go the minute I'm in the oral cavity. Now what I'm seeing is I'm following the tongue, going to the base of the tongue. I'm going to the base of the tongue over here. There are different ways in which you can expose the larynx. One of the nicest ways is to go to the right pyriform. I've already discussed with you that the tube is on the left-hand side, right? So I go to the right pyriform and I see that the tube is just at the left-hand side of me. मेरे को टेलीस्कोप देंगे 0 डिग्री जस्ट इतना दिखाने को प्लीज. हाँ कैमरा इस पे लगाएंगे. Just give me a minute because typically we don't show these things. I just thought from the beginning we're doing, just attach it.
That's a great idea, ma'am. That's a great idea.
Yeah?
We can really see inside.
Yeah, I could have used the VLS to do that, but the VLS tip keeps fogging. Here, put this on. Savlon here, please. थोड़ा ऊपर करेंगे. Okay, so just to show as to how tube light बंद करना. Can you see the pyriform on the right side?
Ma'am, we need to change the camera.
Can we
Change to
PIP?
endoscopy. Change to
endoscopy
endoscopy.
camera, ma'am.
Give me big picture endoscope. PIP outside picture, please. Big picture of the endoscope.
Yeah, we doing that. No, don't
Yeah,
worry. We got
perfect.
that. We got that.
PIP.
It's good,
So
ma'am.
you
Yes,
see the pyriform over here, right?
right,
You
right,
see the
right, right.
arytenoid here, and you see my laser flexometallic tube on the.
Excellent, excellent, ma'am.
Yeah.
Excellent.
Now what I'm doing is just show my PIP. Show my PIP also. Me.
Yeah, we
Me
are
and
seeing
We can see
PIP.
the PIP also, ma'am. We can see the
Oh,
PIP.
you can? Oh, good, good.
Yeah,
So
yeah.
just see my
Right.
hand. See my hand motion.
Yes, yes,
Just
ma'am.
I'm moving it a little bit to the left. Now what I see is the posterior part of the vocal folds. Can you see
Yes,
that?
ma'am. Yes, ma'am. Yes, ma'am. We
Can
can
you
see.
see that now? Now put the chest
Yeah,
piece
yeah,
in.
yeah.
Yeah.
Yes,
When
ma'am.
I see this much is when, can you see the chest piece going in? Turn, quickly put it in.
Yeah, we can see it. Go ahead.
Yes. Now can you lock it? Can you see that it's locked in position, the scope now? Actually, will you hold this, please? The scope. Just hold it exactly the way it is.
Yeah.
Now what I do is I'm giving extension and you see what's happening to the larynx over here. Okay. Now, as we give the extension, we are getting a better and better exposure of the larynx over here.
Okay.
And now, supposing I was to give cricothyroid pressure, can you see the lesion now?
Yes,
Yes,
yes, we
madam.
can see. Right.
So, all this used, one after the other in a stepway fashion, will allow you to get a laryngeal exposure. Ye tube light band karna. Now, supposing supposing this was not happening, I could not visualize it, I would use a didolaryngoscope and do the steps exactly the same way.
Right,
But
ma'am.
supposing even with the didolaryngoscope, I had a picture like this, then the first thing which I would do is just get the extension off, is turn it to the other side. I would, I would bring my scope out like this.
Okay.
So usual position of the scope is level of false vocal folds. Now I have come
That's
way
right.
out. Now hold this, Aishwarya. Hold the
Right.
scope. When you come out, there's a danger of the epiglottis falling, but that is the position where you will get a much better depression of the larynx with the continued general anesthesia with a complete relaxation. So continuous pressure here with the scope a little withdrawn. Our tendency is to go further in to get the anterior commissure. So that's
Okay.
not what one wants to do. Can I have the light clip again? Take this out. So now I'm going to be switching over to the microscope picture. I'll just reconfirm my scope position again. If there are any questions now, because there was that question about the difficult laryngeal exposure, how we would address it. Can we put the chest piece in again, please? Have I addressed that question, or is there any other follow-up question on that?
Nupur, can you hear me? Dr. Kesani here.
Yes, sir.
The cuff, which is below the vocal cords, do you like
Yes.
it at a distance from the vocal cords if it's too close, too far?
Yes, it should be around 1 to 2 centimeters from the vocal fold, because if it is just below the vocal fold bandage, then it's going to, first of all, abut against the vocal fold. Secondly, the chances of rupturing it with a laser beam become higher. Sorry? Bando? Bas, bando. If it goes 5-6 centimeters from the vocal fold, then it will start feeding only the right main bronchus. So you'll have a problem over there. Especially one has to be very careful when you have a double cuff tube, because the length of the cuffs is more, because there are 2 cuffs. So it's important for the anesthetist to confirm the ventilation on the left side also.
This is after. Yeah.
Can you see that I've put some moist gauze pieces over the face of the patient? This is all
That's
part of our laser safety protocol.
Ma'am,
Yeah.
can I ask you one question? There was one question from the audience. Like,
Yes.
is there any change in patient position in case of patient having a short and fat neck?
Yes, absolutely. Like I said in the beginning, this you saw is a neutral position.
That's right,
If
ma'am.
this is a short and fat neck and difficult laryngeal exposure, we can move towards a Boyce's position,
Boyce
first
position.
of all, where you are putting a little bit of a head ring
Head
underneath
ring.
the head. No shoulder, okay? No shoulder. And if it is extremely difficult even to intubate, one can try a flexion position. This has been described by Dr. Zeitels. I mentioned that towards the beginning. These are the various things we can do, and it can be done even, your bed has got a head support which can be taken up, down. Some of the OT beds do. So then you can use that. to your advantage.
Nupur,
So
madam.
now what we do is we take a yes.
Nupur, madam.
Why you're in?
Yes.
If I'm not getting this double cuffed laser endotracheal
Yes.
tube, can I
Yes.
use the endotracheal tube covered with aluminum foil?
It would be safest to use a red rubber tube covered with aluminum foil and not a Portex tube.
Yeah, not a Fortex.
Yes. Yes. Yes.
Thank-
Yes. And we do that in children.
Yes,
White
ma'am.
balance placed, because in the pediatric age group we are not able to get these tubes.
Yeah,
I'm
yeah,
just showing you the image, how we take even for our patients,
yeah. Okay. ma'am.
because we give them preoperative and postoperative images. So 0-degree telescope, 10 millimeter gives the best image. So I hope you all are also able to see what I am seeing.
Yes, ma'am, we
Little
can see very
bit
clearly,
low.
but a little bit of focusing I
Little
will.
bit, yeah, I'll just,
Yes, ma'am.
is it okay?
Yeah, fantastic.
Yeah, okay, take a photo, please. I take 2-3 images typically. Just, I also
Get-
check that the photo, please. And we will, under the microscope, even palpate, and one must always palpate to look out for mucosal bridges and sulci,
Right, ma'am.
Photo, please. And you may think that, these small things, how do they matter? But, not only for a regular person, but if it's a professional voice user, singer, all these things do matter. If you have a small sulcus, you have a mucosal bridge, it may be giving character to your voice. It doesn't mean you have to take it out, but the knowledge is important. We'll switch over to a microscope now. Of course, it's going to be at 400. Mind your head, Aisha. Focal length of 400. And also remember, if you're using a laser, the laser has its own, wo light nikalo udhar se. The laser has its own focal length, which also has to be switched to 400 so that you get a crisp red line in case you're using a scanning system. Just one word, इसका ये balance करो, head बहुत heavy है. नहीं, camera बाद में लगेगा, पहले balance करो. I just want to mention that I'm using this laser, which I already showed you, but it's got its specifications on it, and you have two options. One is fiber laser, one is a free beam laser. We are using the free beam laser, CO2 laser, 10,600 nanometer. It is an invisible light. So in order to see where you're burning, a Henny beam, helium neon beam is attached, which is red in color. That's called a Henny beam. You may want to use it in scan or no scan or fiber. We typically like to use it in scan mode. Scan mode means that the beam is going to scan the surface which you see very, very fast. Therefore, you can use very high wattage or power. When we're using a laser, it's not only the wattage which matters. Here, typically, it's 10 watts in the system. But what also matters is what is the spot size or the length size. For here, it is 1 millimeter. Because your power is getting divided into the shape size. And then the third component which matters is your time on and your time off. When we have all these three factors in play, the power, the spot size, and the time on, it is known as the fluence of the laser system. So the fluence is very often decided by the laser machine. And then you have your aiming beam irradiance, which you can decide that has no bearing on the amount of charring which will be created. And the laser should always be with this pink light of standby. When you're ready, you put it on the ready system. We have a foot pedal over here. And it is when you press the foot pedal and the system is on ready that the laser will come on. And the foot pedal also, you can decide to put it on repeat mode or continuous mode. So this is for the laser specifications. And now I will put a camera in and move on to the microscopic view. Just give me 1 minute for that.
Madam, can this lesion be done with microflap technique also instead of laser?
Absolutely. Absolutely. Absolutely 100%. So now, first of all, when we say microflap, even a laser is able to do microflap. But maybe you are asking me about cold steel, right?
Yeah, cold steel.
Yes,
Not everyone
absolutely. We can do a very efficient job with cold steel also. In fact, it is advisable to use, chashma nikal de, to use cold steel unless you have a very precise laser. If you do not have a laser with a scanning system, it is much, much better to use cold steel, because if you're going to use a laser which is going to cause thermal damage, you're going to do a disservice to the patient. It is only when you're
Yes, sir.
doing very vascular lesions or malignancy work or things like amyloidosis that I feel a laser is especially useful. Otherwise, there's so much in phonomicrosurgery one can achieve just with the cold steel.
Thank you,
Now,
ma'am.
why then am I using a laser? I am using a laser because since I do 40% of my work is malignancy and I've been using the laser now for 17 years, I have become dependent and very comfortable with it. So it's a tool. It's a tool which gives you, it's like a hemostatic scalpel. And once you get used to it and its advantages, it's of great benefit for you as well as the patient. So you can imagine you're holding, right now I'm holding a 24 centimeter forceps. But if I start developing a little bit of tremor like this, then if I'm using this, 6 centimeter joystick, if I'm using this joystick, then there's going to be no tremor. So, it's just a question of precision, but it does not mean that if you don't have the laser, you can't do a lesion like this. Of course, and you can do it as efficiently.
Ma'am, the neuropathy you have given in subglottic neuropathy, is it moistened with xylocaine?
Saline. No, just saline. Just cold saline. Yeah, not saline adrenaline.
Okay,
it is more to protect the cuff, because there's no laser safe tube made in the world where the cuff is laser safe. That is the danger point, the cuff. So we have to cover that up and with a moist patty. Now, what exactly you all are seeing the microscopic picture, right?
Yes. Ma'am,
Yes.
just I think it will be wise to ask right now one of the delegates, Dr. Surekha Ganesh, he was asking any role of coblator, laryngeal wand coblator in these cases, or there is not much of a role. Your take on it, ma'am.
Yes, thank you. This particular case, I would not use a coblator at all. Currently, the wands they have, both the wands they have, are too thick for precise work with the coblation. So your cold steel instruments, show me the sickle knife, your sickle knife, microflap elevator, hardship forceps would do a much better job than a coblation system. Coblation is extremely useful, let's say if you're doing a Kashima cordotomy, because it's got the coag mode in it also, and we know that bleeding takes place pretty briskly when you reach the inner perichondrium. Or if you're doing papilloma work, you may want to go with the coblation system. Or let's say you've got a hemangioma and then I use the coblation system. So there are very definite indications. The company tells me that they are coming out with a new wand, which is going to be very thin and very precise. So I await that. But in this particular case, a lesion such as this, I would not use or advise the coblation, either cold steel or a scanning system of laser. The other way you can approach this patient is if you have a hemoangiolytic laser, like a blue laser or a KTP laser, because their wavelength is like 445 nanometer and 485 nanometer, 532 nanometer. These are the blue, yellow, and green lasers, which are the hemoangiolytic lasers. Then you have, for a slightly vascular small polyp like this, the option of going as an office procedure and buzzing the polyp. What happens is the epithelium remains intact and the vascularity sort of gets regressed or dissolved. You may have to do 2 to 3 sittings. That could be another approach if you don't want to take the patient under GA. If the patient is a singer, you want to stay as conservative as possible. I hope that answers the question. I'm going to do now what I discussed, which is a palpation. Let me just palpate the lesion. Okay, I'm palpating this lesion over here. I want to know, is it soft, firm, hard? There's a small polyp, baby polyp here, mother polyp here. Then I will evert the lesion. I want to see the undersurface, okay? And then I want to see the contact lesion area. Can you see tiny varix, small contact lesion? Then I want to just swing my flap elevator and try to insinuate it in any slit which may be present to see, is there any mucosal bridge or is there any sulcus? I want to do the same thing on the left vocal fold also. I want
So
to see
this,
the undersurface. I want to look over. Can you see over here? Like the contact lesion is seen and the varix is
yes,
seen?
yes, ma'am. Yes, ma'am.
Yeah. And there are no mucosal bridges in this patient.
That's
And
right.
there are no sulci.
So, ma'am, you do it with the flap elevator.
I'm doing this with a flap elevator. This is
Okay,
the
okay.
same, show me that flap elevator. This is the same flap elevator which we use when we do cyst excision. It is one of the best instruments I've come across. Over here, I'm just showing it to you. It looks like an iris repositor in a way, but it's a flap elevator. This particular one is made by Stores. And because the tip, you can see it is totally blunt. It allows for, not puncturing a lesion of like the cyst.
But
Now
there is
we'll
a
come
variety also. I mean, the tip is a little curved like that.
curved tip, yes, and a blunt.
Yes,
Now we'll do an infiltration with the 27 number needle as I discussed, and I showed you the bayonet shaped needle. And we want the tip to just go underneath the epithelium, just underneath the epithelium. You get a little give way and then you infiltrate. Now, when I infiltrate, can you see the whole lesion come up?
yes, ma'am.
Yes,
It's
so
a
we know
mineralization of the lesion, yes.
that this is a subepithelial infiltration technique, small cotton ball. So we know that this lesion is not involving the ligament or muscle,
That's right.
right? Now,
Right.
if a lesion was attached to the ligament or the muscle, then what would happen is that the infiltrate would fill up all around, but the lesion would stay down.
That's
That is known as the donut sign, or we can call it the Medu Vada sign in India,
Right.
if we want. Okay. So this seems to be a superficial lesion as we expected. We are going to target first the right side. So now I'm going to be putting the laser on, and the specifications which I use is 10 watts, 1 millimeter in length, 1 number depth. 1 number depth means 250 microns only. The time on is 0.03 seconds. The time off is 0.3 seconds, which you saw the monitor. Now, just let me know whether you see the red beam. Please let me know if you're able to see the red
Yeah, we can,
beam.
we
Yeah,
can
Very
see
clear.
the illuminant pointer beam. We can see the
Yeah.
pointer beam, ma'am.
it
A little diffuse. That's
it's a little exactly agree with you. So is it
yeah,
looking better?
better.
Now,
Better,
can you see there's a flicker on it? That
Yes, ma'am.
flicker is the scan. It is scanning. It is scanning the surface.
Right,
Okay.
ma'am. Yes,
Now
yes,
I'm
yes.
putting the laser suction in. In the Dido, it goes into the channel, but in a Klein Sasser, you will actually see a little black on the left-hand side of your screen. Your vision
Yes,
will not
yes.
be perfect. That is our laser suction. Okay.
There's smoke
Now-
evacuation.
Okay. Now that I've infiltrated, I check with madam again, nitrous off, oxygen, 25% of oxygen being used, laser system on.
Yes.
Everyone's wearing spectacles today. To be honest, a lot of audiovisual people are not. That's not ideal, but everyone should wear spectacles, and we will go with our laser beam. Now, if you want, in the beginning, you can just check the laser beam on the patty itself. So I'm
Ma'am,
checking it on the patty.
to wait for some few minutes for the adrenaline to walk, or you just straightway.
No. You want to be pretty immediate. It is very fast for the whole adrenaline to kind of dissipate. See, the Rinke space is a huge space, It can't stay in a one localized area. So you don't need to wait.
Okay,
Okay.
ma'am.
I'm
Okay,
just checking did you see the beam hit on the cotton
Yes,
ball?
yes.
Just to
Yes, ma'am.
see that where I have targeted is where it is.
Churning. Where is the beam?
Yeah. Okay.
Yeah,
So
that's
now I'm going to do.
Perfect.
Now I'm going to do the surgery called a mini microflap, okay, as described by Professor Satterlaw. What
Yeah.
does that mean? That means that we are taking the incision. What I'm
Right.
doing is the incision. I'm taking it bang at the lateral edge of the lesion.
And with very minimal charring.
If-
Excellent laser.
With minimal charring. So now, but is the focus good?
Yeah,
नहीं, अच्छा
Yeah,
नहीं है ना? ठीक है?
Little more focus
Is
in
the
mid.
focus okay for you?
Yeah, we can say
Yeah,
nice.
good. If I was to make an incision here, that would be called a lateral microflap.
That's right,
If
ma'am.
I was to make the incision over here, that would be called a medial microflap. And when we make an incision here, this is called a mini microflap.
Mini microflap.
Why was this described? Lateral microflap was described because some lesions distort the anatomy so much in terms of the depth of the layers that if you start from laterally where the anatomy is normal, then it makes it clearer when you get towards the lesion.
Absolutely.
But with Dr. Stephen Gray's research published in OCNA, we realize that there are these anchoring fibrils which are coming from the basement membrane of the epithelium into the SLP. And you have collagen 3 and 7 fibers sort of intertwining with each other like a wicker basket. And it is this beautiful architecture which is actually keeping the epithelium attached to the ligament and at the same time allowing for the mucosal
waves.
But when you elevate epithelium, even if you reposit the whole epithelium back like you can in a cyst surgery, that architecture is lost forever. Therefore, Professor Sataloff himself, who had described lateral medial microflap, then suggested the mini microflap, keeping that in mind. Cotton ball small. I'm sure many of us are aware of it, but I just thought for the sake of the students and residents attending, I'll mention this.
Yes, ma'am. Yes, ma'am.
Okay, so squeeze karke dena. So we are going to complete what we call our laser small incision. It's called a laser cordotomy. Fancy name, but just a small incision being made laterally. Give me a small cotton ball squeeze karke. Now what you can do is every now and then I like to use cotton balls for dissection. I find it extremely useful. So especially in cyst work, can I have a smaller cotton ball, Darshana? One is that it allows for a very good elevation. Second is any amount of tiny charring, etc. cleans off. But then what happens, what we realize is sometimes these cotton balls keep a few fibrils get left behind, you know, and that can cause a carbon granuloma, hardship to the right. So what we do now is we give a laryngeal wash. I've been planning to write about it for the longest time. We give a laryngeal wash always after surgery. Now, this is the heart-shaped forceps which we mentioned earlier, the Boucher forceps, absolutely right. And so we are holding the lesion. You can see the ligament over here, right?
Yes,
this is the ligament over here. And what we want to do is we want to excise the lesion.
Medial to the ligament.
Yes. And at the same time, we want to be able to keep a cover of epithelium if possible.
Yes.
Now, we don't have to preserve all the epithelium.
With the subglottic aspect
of... like a little bit what covers the medial vibrating edge would be ideal. This epithelium we want to preserve.
Right, ma'am.
So we will cut the lesion but preserve as much as we can of that epithelium.
Beautiful.
This goes for histopath.
Beauty it is to watch. True.
Thank you so much. Small cotton ball, please. Now, some of you may want to know what about contact lesions? When should we sort of address them or when should we leave them alone? When I take a patient under general anesthesia, unless I feel I'm going to damage the other vocal fold by addressing the contact lesion, unless I feel that, or unless I feel I've gone to the anterior commissure on one side, so other lesion is also very much near the anterior commissure, I always sort of tackle it, especially with the laser. Now you see a blood vessel here. Do you see this blood vessel? Yeah. So very often with the polyps, I like to take care of the feeding blood vessel with the laser.
Madam, you had talked about the laryngeal wash. To what solution?
Excuse me? Sorry?
Laryngeal wash.
Laryngeal wash.
You want to know about the laryngeal wash?
Wash.
Yeah, how is it given?
Yes, I will give it. Wait, first I want to just, if you don't mind, just talk about the contact lesion. Yeah?
Yeah.
Make the beam 0.5 millimeter. The beam, cotton ball, the beam can be made smaller, bigger in length. I
Ma'am,
just
if there is
want
any
to,
kind of, I mean, say if the lesion on the contact lesion is less than 2 millimeter, 3 millimeter, do you want to handle it, address it, or you just leave it like that?
yes,
To-
that's exactly,
What is the cutoff?
that's exactly what I'm discussing now. I'm just finishing up on the right side first, okay? Can you see that I've made my beam much smaller?
Yes, ma'am. Yes, ma'am.
I've
Yes.
made the length of the beam 0.5 millimeter now. Initially, I was operating with 1 millimeter. Now I'm taking a cotton ball and I'm just everting over here, okay?
Yes,
Can
ma'am.
you see the vocal fold under surface? Yes. Can you see the varix over there?
Yes, ma'am, we can see. That's right.
Yeah. I'm just going to be laserizing all the varix.
Okay, ma'am.
Now, if I don't have a laser, I will just leave it alone.
Okay, okay.
Because to try and excise a varix or a blood vessel is one of the most difficult things. And then you can land up with a subepithelial hemorrhage, laryngeal wash. So I would very much want to then leave it alone. It's only because I have this system that I'm doing this. So it doesn't, you have to think of what you have and what you want to do. The question about laryngeal wash, just to show you, just the same way as you have an infiltration needle, bayonet shape. I don't know whether we can show. Can you show me the outside camera? Can you show the outside camera? What this is the. Can you see it? Can you see it's can you imagine a microflap suction which is just like a bayonet shaped? Okay.
Yes.
It's thin. Yeah. Okay. So I just attach onto a 20 cc syringe, bayonet shaped suction. And with that, I'm basically doing a laryngeal wash and I have another suction. And what I do is I wash that area. Can you see that now what is happening?
Yes, yes. Like
and I have a patty. I have a patty in the subglottis. And when we do the wash, we make sure that we do a good suctioning. So the patient is not aspirating water, etc. And that takes care of all the cotton fibrils, char, etc. that may have sort of been left behind as a residue because of surgery. Cotton.
Madam, are there any possibilities of any post-operative synechias in such patients? Even if you don't do the opposite side, are there any chances of post-operative
this one is
synechia?
important.
Is the question that is there a chance of synechia in a case like this, even if you don't do the opposite side?
Yeah, yes, madam.
Okay, I'll see.
By that you mean like an anterior glottic web?
Yes, yes, ma'am.
Yes. Okay. So no, there is. Well, I will never say 100% because who can say, but I would never expect it because I want to show you over here what is the anterior commissure. Anterior commissure is 3 millimeters of the most anterior part of the vocal fold. Okay, put the laser AccuBlade, make the length 3 millimeters. Now, one of the great advantages of this AccuBlade system, iska length 10 millimeter karo, iska 10 millimeter, is that we have this AccuBlade which can be used as a beautiful scale. Okay.
Okay.
So since you asked the question, I have made. Can you see the red line?
Yes,
I have made the length of this 3 millimeters right now.
So
and I am still behind the 3 millimeters.
Right.
Okay.
Right,
So we have in fact not touched the anterior commissure at all.
Absolutely.
So even if I do work bilaterally over here also, by other side also is beyond 3 millimeters. So the chance of a web forming, therefore, I say is no. Now, there are certain situations where you do have to operate on the anterior commissure. It may be papillomas, it may be a malignancy, like a type 6 cordectomy is or malignancy of the anterior commissure. Or papillomas, what are you going to do? What you can do with papillomas and the anterior commissure is, you can operate all the way up to the anterior commissure on the right side. And don't touch on the left side. I'm just giving you an example. Stage it for 6 weeks later.
6 weeks, yes.
6 weeks. And this patient, don't give them any voice rest. When you give voice rest to a patient, stasis of secretions take place and the synechiae have an increased tendency to develop. Have the patient talk. In fact, we give them abduction exercises. And I also like to give that particular group of patients steam. So that is something you can do when you do have to operate on the anterior commissure. Then you can go back in, let's say, if you feel a sinecure is developing, despite you taking care of doing only one side and having the patient talk, you can go in 7 to 10 days later and just take a patty and clean the slough. That will go a very long way in preventing sinecure formation.
Good, good,
Okay,
good.
thank you, ma'am.
Crocodile forceps. Now what we'll do is we will take the subglottic patty out and we will give a 10% lignocaine spray. Laser on standby, please. 10% lignocaine spray. Some people like to give a spray. I prefer to do that. Some people like to take 4% lignocaine and put a patty in the pyriform. Basically,
That's
you're
right.
just sort of neutralizing the superior laryngeal nerve. Give the spray.
That's right.
And we don't want a laryngospasm to develop post-extubation. In
Yes, ma'am.
these MLS cases, we'll take a 0 degree, we'll take a photo once. We'll just take one photo and then we'll give the spray, post-op photo. In all these cases of MLS, it's very, very important to have the patient completely awake prior to extubation. Then the chances of a laryngospasm or desaturation is very less. And the group of patients who are in maximum risk, can I have my spectacles, are the patients who have sleep apnea. So do take that history beforehand. The
Right, ma'am.
patients who have sleep apnea, they get very anxious, nervous. So it's very important not only to have them completely awake, but also to have next to the OT bed, photo please. This is a post-op photo which we are taking with the 0 degree telescope to give to the patient. One more photo, please.
Right, ma'am. Excellent, excellent.
Now give the lignocaine spray while they can see it.
Madam, when shall you start this voice therapy in this patient? Immediately?
This is the spray happening over here, lignocaine spray.
Yes,
And sir, I just come to your question. Just want to mention in the sleep apnea patients, have the shifting trolley next to you where the patient can actually be made to sit up. Because when you make the patient sit up, the sleep apnea group, they get much better, in a sitting up position rather than a lying down position. Yes, please. Sorry, what was the question about speech therapy?
When
we start the voice,
start the voice therapy in such patients, speech therapy.
After
Okay.
7.
Telescope do fir se. Sir, can I just answer your question after 1 minute? I want to just show. Ritesh is taking out the pressure. I just want to show once again the with and without pressure sort of situation. Yes, please release the pressure. Here. So a C change. So therefore the pressure of great use. Okay. Now what I do for the post-op management of the patients, any lesion which is not of the anterior commissure, I ask the patient, I believe in giving the patient 7 days of voice rest. Now there's a dichotomy of opinion in this. There are table upar lena, there is a group of people who believe in only 3 days of voice rest, and they've shown studies where the healing, sort of the primary healing which matters is within 3 days, table upar. I prefer 7 days of voice rest in all these patients for 2 reasons. One is I feel that it gives more of a chance for the primary healing, table upar lena. And the second more important also factor is, thank you, Bas, that the patient, the mind circuitry gets a break. And the idea is that you forget all your bad habits or wrong habits or compensatory habits, and then you start afresh. So for these 2 reasons, and we Indians are very talkative. So if you tell the patient you can talk in confidential voice for 5 minutes an hour, most of them will talk for 25 minutes an hour. So for those reasons, I do believe in giving 7 days of voice rest. After which, I like to have the patient start the voice therapy after can I have a suction? Done a laryngoscopy. So the patient comes on the 7th day. I do a simple laryngoscopy, see that there's nothing unusual, no subepithelial hemorrhage or carbon granuloma forming, etc. My therapist is with me. If she's not with me, then I record it. And then we start the therapy immediately on that day. We start with relaxation voice therapy for about 2 weeks. And after 2 to 3 weeks, we start on the strengthening voice therapy. Part of the relaxation voice therapy is the lax walks technique, which works very well, where you're blowing bubbles with a big straw into air. Of course, this is all in the therapist domain. I do not do any therapy for my patients. We have an excellent team of speech and swallowing therapists, and we have a singing therapist because we get singers. Besides that, we give PPI to patients for a month, not only people who complain of laryngopharyngeal reflux, but all patients. Because after surgery, for some reason, even patients who don't have reflux occasionally do start refluxing. And acid on the vocal folds has 10 times more damage than acid in the food pipe. So it's a good idea to give PPIs for a month. I also tend to give, like Kimoral TDS for 7 days.
PPI for high doses. Some doctors.
40, I give 40 milligrams before breakfast. I don't give domperidone. Can I have a pillow? Only PPI, no domperidone. Occasionally, I give Gaviscon. If the patient has been aspirating I want to neutralize the pepsin also then. And besides some kind of an anti-inflammatory like Kimoral and this PPI, I also give paracetamol for 5 days. No antibiotic or steroids is given to patients routinely, but we do give one IV antibiotic. I think we've given IV antibiotic, and we give steroid IV intra-op if the patient is not diabetic. If the patient is diabetic, we try to avoid that also. We give a cough syrup, SOS, if the patient has a cough. And that's my basic. We also give a vitamin for 3-4 weeks, typically neurovitamin. So this is our typical post-operative management. And I do a repeat stroboscopy at 1 month.
One question, ma'am.
Yes.
From how many days post-operatively patient can speak in a normal voice?
So when I take the consent of the patient, I tell the patient that no promises are being made about a normal voice in any patient. First of all, we take a sign like that. We say that though in the last 17 years, we've not had any patient with similar lesion worsen, but there is academically and technically a chance of voice worsening. So these are things we must take in our consent, because unusual healing patterns and unusual things can happen in anyone's hands. But we explain to them that the healing process is such that by 4 weeks, you would get the best possible recovery in your speaking voice. For singers and professional voice users, once a stroboscopy is done at 4 weeks and we get a good mucosal wave with good symmetry and good amplitude, we start the singing therapy, and we allow them to start their shows around 4 to 6 weeks after surgery.
Okay, ma'am. Ma'am, one more question can I ask you? Ma'am, what is your take on Thrive? Do you use Thrive during surgeries or
We don't have.
surgeries?
Dr. Rakesh Srivastav is using that quite a bit. We don't have the facility and we're not using it. What we have used is the Hunsaker distal jet ventilation tube, which is actually a laser safe tube and which can be used with a high pressure venturi. But the airway remains unprotected. So I'm happier using the laser safe tubes, and I'm happier using apnea technique, like taking the tube out when warranted. Like if I want to work on the interarytenoid area or posterior larynx, then I'm happier taking the tube out, doing a little bit of work, putting the tube in through the scope again. So that's what we are doing.
Ma'am, there is a lot of questions. Can I just ask you a couple of?
Of course.
Yeah,
with the permission of Dr. Janki, I hope I'm not.
Yeah, Dr. Janki, can we keep on asking her a few questions? There are a lot of questions waiting.
Carry on.
Okay, thank you, sir. So the first question is, ma'am, it's very important. Madam, would you please tell us, light cable clip, the cost and the name of the company?
Oh my gosh.
Babu.
I'm not a partner in any company. I'm just telling you, this is by Stores company. The light clip, it is fantastic. It provides a very bright illumination. I have no idea what the cost is.
Okay,
don't-
okay.
Sorry.
One other question was additional maneuvers for thick, short neck. I think you have answered that already. And,
Yeah, if I was to just summarize, not only thick, short neck, very often the thick, short necks are okay, and you may get a thin, long neck. Ask Dr. Kirtane, he's had a patient where the laryngeal exposure can be so challenging and difficult. So just to, again, just summarize, go with the anterior commissure laryngoscope such as a Dido, go with a smaller size rather than a bigger size, withdraw the scope rather than going towards the anterior commissure, go more towards the false vocal folds, give continuous pressure on the cricothyroid membrane by a bandage rather than a hand pressure. Ask your anesthetist to keep the patient completely relaxed. With complete relaxation and 20 minutes of pressure, we have found something which we call a laryngeal drop. The larynx actually will drop, and after the end of surgery, you will feel, was this really a difficult laryngeal exposure? How can I see so much better now? That is a laryngeal drop. And if all of this doesn't provide for the exposure, you can use angle telescopes with flexible tip instruments. If you don't have that, you can use a flexible laryngoscope or bronchoscope with a side channel. And if none of this works, you can abandon the surgery and you can do it as an office procedure with a fiber laser. And if you, or as a last option, you can refer the patient.
okay, ma'am, there was another question. If not having laser and only having conventional tools like forceps, etc., how to do it very safely, ma'am?
So polyps, cysts, these are lesions which you can operate sickle knife in very nicely with cold steel instruments. So where I've been in Sion Hospital for about 11 years, and we did not have a laser, and I was doing all phonomicrosurgery with cold steel. So here is your sickle. This is you will have to invest in instruments like sharp sickle knife. These sickle knives will be used to make the incision. When you make the incision, the tip of the sickle knife will go just underneath the epithelium, like how the infiltration needle went. Then move it in an upward way like this and get the epithelium tethered on and move upwards. Then give me the straight scissors. Once you've made that incision, you can continue the incision with a upward scissors or a straight scissors, and you can extend the incision anteriorly. Don't make the mistake of starting your sickle knife incision if the lesion is here at a midpoint. Always start from posterior. Making the incision from posterior to anterior is much easier than trying to extend the incision anteriorly and then posteriorly. Extending posteriorly is a very challenging thing to do without tearing the epithelium. So make your point of incision the most posterior. This is for cold steel. For laser, you can make incision anterior, posterior, whatever you want. It doesn't matter because you don't have to engage the epithelium.
Right.
I hope that is making sense. So use a good sickle knife, use a good scissors to extend the incision. So this is of course your scissors, and then you use the same microflap elevator, which I had shown you during palpation, with the same handle. The handle is the same for the sickle, for the elevator, and elevate the epithelium by using it in your right hand, if you're a right-handed surgeon. Hold the lesion with a heart shape pointing to the right side in your left hand. So you elevate that same epithelium, and in the same fashion, then you cut it with the scissor. So the whole surgery, same steps. It's just a question of you need a little bit more precision, and the instruments should not, shake, etc. It's just may get a little bit challenging, but you can do the exact same surgery.
Ma'am, can we use some form of a hand rest while doing this MLS surgeries?
Yes. Can you see this chair over here?
Yeah.
This is the chair I was sitting on. Okay. Now, if you want, you can keep the chair like that.
Great.
I can sit here and I can use this as my hand rest. If I don't want to do that, I can take the Mayos and I can put one Mayos here, Mayos here, and I can use it as hand rest. You get robotic chairs now, very fancy chairs, which have got hand rests, which can be armrests. Armrests are motorized also. It can be with a motorized or it can be with a screw, and you can move it up and down. Of course, one can use all of these. In most of the places I went for my fellowship, they always had them.
Ma'am, one question
Till
from.
now, I'm comfortable without. So personally, I'm not using it because I'm comfortable. But of course, one should do whatever makes the situation most comfortable.
Yes, yes, ma'am.
Ma'am, one question from audience, Ram Babu. What precautions should take pre-operatively to prevent post-operative laryngospasm, and how to
Aisa
deal
turn
with
करें?
laryngospasm?
Yes. So to prevent a laryngospasm, one of the most important things is ये back रख सकते हैं. So basically, use that lignocaine spray, 10% lignocaine spray, to spray the larynx and the pyriform before extubation. Secondly, to have the patient completely awake before extubation. Instead of using a spray, you can also take lignocaine on a cotton pledget and put it in the medial wall of the pyriform to desensitize that area. It has the same effect. And anything you want to add, ma'am, to that?
Ma'am, she's talking to you. Hello, ma'am.
Who's talking to me?
Going in for a supralaryngeal block, like? I mean, it's frozen. It's not working. Yeah. Now we can see, ma'am. Yeah, now we can see you, ma'am.
Okay. So was there a question I did not answer?
Yeah, ma'am, that was it. The question was regarding how to prevent the laryngospasm. You are
Yes.
putting 10% xylocaine spray you did, like in a piriform fossa block, like we can use 4% xylocaine cotton, neuropathy to pack the piriform fossa. And is there any possibility that if we pack it, then in post-operative recovery, the patient can aspirate? If the
No. You don't leave the pack inside. You're using a patty with a thread with a lignocaine, and you're putting the lignocaine there for 2-3 minutes, and you're taking it out before extubation.
That's right. That's
You're
right.
not leaving anything inside. No.
No. What I was talking about is not leaving it, ma'am. We are taking it out. But if the postpharyngeal wall, that hypopharyngeal wall mucosa get anesthetized, so if there is any chance of, aspiration, just immediate post-operative.
No, we've never seen that happen.
Okay.
With the patient totally awake. Also,
Madam.
the patient is 8 hours NBM and the patient is fully awake. So we've never seen that happen. So therefore, the importance of having the patient completely awake before extubation.
Madam, in a case of hemangiomatous polyp, if you use a cold still instrument and do a microflap, if the polyp starts bleeding, then in that case, how do you manage?
Yeah, that's a very, very good question. So the first thing is do an infiltration a little away from the polyp. Don't have your infiltration needle pierce the polyp in the infiltration itself.
Okay.
Second is make the incision slightly more lateral, because the hemorrhagic polyps tend to have a little bit of a capsule. The minute you start dissecting into the capsule, think of a tonsil kind of situation, it starts bleeding. But it's like a pseudo capsule almost. So stay a little bit away from it.
They should not bang onto the polyp. It should not be bang onto the polyp, but laterally to the polyp.
Slightly lateral to the polyp. Okay. And use cotton balls, small cotton balls soaked in saline adrenaline for the dissection, like you see me use. Okay, you'll be able to get a very good plane of that hemorrhagic polyp from the SLP and from the epithelium. Yes. And then finally, when you've done a little bit of separation of that hemorrhagic polyp from the SLP, hold the lesion itself with a heart shape, not with a crocodile. Crocodile will puncture it. Hold it with a heart shape and then do your trimming with the scissors. Whatever bleeding you still do have, if you keep a large hemostatic patty there for 3 to 4 minutes, you will see that almost all hemorrhage will settle down.
Okay, thank you.
Can we use, ma'am, monopolar cautery?
No.
They should never be used, I think.
No, please. I mean, if you're doing a Kashima chordotomy or you're doing malignancy work, fair enough. But otherwise, please do avoid using a cautery on the vocal folds, because you will get a bad scar, which will be very challenging to treat. So better you have you can take a very large patty with a thread, keep it there, or you can take a very soft roller with, the long nasal packs, put it in saline adrenaline and put it in Botrupes or some, hemlock, and put it over there for 7 minutes, 10 minutes with pressure, almost all bleeding. There is no vascularity per se in the SLP and the
Madam,
epithelium.
can the vascularity be reduced preoperatively by giving steroids for a week or so?
So if you're talking about subepithelial hemorrhage, we will always want to give steroids for subepithelial hemorrhage preoperatively and want all the hemorrhage to settle. But what you're left with now, what we were discussing, is the hemorrhagic polyp per se. That very often doesn't settle. But yes, definitely the hemorrhage, you want to take care of it with the steroids, especially non-diabetic patients. Also, if a patient has only subepithelial hemorrhage, that's not a good candidate for surgery itself, because if you try to remove all the hemorrhage by laserizing it, you will cause a lot of scarring of the SLP.
Can we use, ma'am, intralesional sclerotherapy agent in hemangiomatous polyp or the hemorrhagic polyp?
So for a large hemangioma, like, we know in children, propranolol works well, but for large hemangiomas, you can try sclerosant injections, and they may regress the hemangioma after 2 to 3 sittings. It can be tried as office procedure if the patient is cooperative, or in theater also. But the large ones, I mean, at least in our experience, we've seen the large ones hardly regress, and then in those situations we use a coblation actually.
Which
and
one is
sometimes
safest?
the harmonic scalpel also, the supraglottic hemangiomas.
Sclerotherapy agent, which one is safest one?
We usually have our person who does the for the angiofibromas. I'm forgetting what sclerosant they advise, but there were 2 which he usually asks us to use. Is there any way I can get back to you on that answer? If you email me on nupurkapoor@yahoo.com, can I get back to you on that answer?
Madam, Smith and Nephew
Sorry?
Smith and Nephew company has come out with a laryngeal band, a little bit costlier, around 25,000. So it is useful for proglottic hemangiomas. The cobblator.
Actually, ma'am was probably talking about sclerosing agents. Sclerosing agents.
No, I am talking about the other way, other thing. I am talking about the other thing.
Yeah, we did discuss the wands. So basically I have seen their wands, but they are going to come out with apparently an even thinner wand. The wands they have currently are not appropriate for phonomicrosurgery. They may be appropriate for other situations like papilloma, Kashima, hemangiomas. But you saw the precision with the AccuBlade. I don't think any of the wands currently in the market can give you this kind of precision, but cold steel instruments can.
Okay.
If there are no more questions, I think I would like to take this opportunity to thank Sun.
Ma'am,
Dr. Janki.
can you just, the rule of 2 you usually teach regarding mitomycin C, some questions have been asked, like, please explain the use of mitomycin C for prevention of synechiae.
I was using mitomycin C many years ago when we were doing, web surgery. At the end of the web surgery, put the mitomycin there for 5 minutes, 4 milligram in 4 ml, then wash it out. And I have really seen no studies which categorically can prove that mitomycin helps in any way. For the last 10 years, we completely abandoned the use of mitomycin C. I think all my international colleagues also do not use it.
Okay, ma'am, the last question probably will be, which modality should be used in case of corrosive supraglottic stenosis? And how about the results with monopolar cautery? That was Vikas Kumar from New Delhi.
For supraglottic stenosis, I mean, if you have the facility of a laser rather than a cautery, it is better because, it's just a question of charring. And if there's charring, there's going to be more fibrosis. The whole problem is there are no stents available right now to properly fashion and keep in the supraglottic area. So it is more a question of doing the excision in a staged fashion, giving, time for healing and preventing synechia. Here there's a role of injection of steroids also in that area. So supraglottic stenosis is a whole different game altogether, very challenging condition to treat.
Thank you so very much, ma'am. Thank you so much. It was an excellent
Thank you.
session
Thank
we
you.
had. Thank you so very much, ma'am.
Yeah, thank you, ma'am.
Pleasure.
Thank you so much.
Would like to thank San, Dr. Kirtane and Dr. Janki very much. I really enjoyed myself, and from me and my team in Bombay Hospital, thank you so much. Just want to mention that we have a laryngology fellowship program that we run, 2 fellows in a year. So anyone who's interested for this 6-month fellowship, please email me on nupurkapoor@yahoo.com, NUPURKAPOOR@yahoo.com. And I hope to see many of you in November in our workshop. Thank you.
Yes.
Bye-bye.
So much, ma'am. Thank you so much. It was such a difficult surgery. So we'll particularly also like to thank the anesthesia team and a whole OT team from the hospital. Thank you all the panelists. It was a treat watching the surgery, ma'am, today. We learned a lot.
Thank you. Just want to mention this was not a difficult surgery. This was a very easy surgery, which I purposely kept so that I can teach nicely. And if you want, I will keep a more difficult surgery at some other opportunity.
Right, ma'am. But then those people who are online and offline, as rightly mentioned today and yesterday as well, it is from like A to Z. And those who are taking the notes, probably if this comes as a long question in the ENT exams, it would be out of marks for those who have already taken from A to Z.
Very good. Thanks a lot.
Thank you so
much. Thank you so much.
Thank you.
Thank you, ma'am. Thank you so much.
Bye-bye. Bye-bye. Enjoy your rest
Have
of
a
the
good day. Thank you.
Thank you.
Janki, sir.
Yes. A
Sir,
very good morning.
good morning, sir.
Good morning, sir. So this is Dr. Vijay. So I would like to take this opportunity, and it's my honor to present you Dr. Janki. So he's the Managing Director, Royal Pearl ENT and Skull Base Institute, Trichy and Hyderabad. So I'll take a minute here, and sir, don't mind if I take liberty. So since yesterday I'm seeing you wearing that J, right? Yeah, that's true. And there is a recent Thalaiva movies, Jailer, and the dialogue of anybody has seen the Jailer? Hukum, Tiger ka hukum. So that's sorry, sir. I've taken this liberty, but seriously, I wanted to say this since yesterday, saying that J or J there. Thank you, sir. So, just wanted to introduce Dr. Janki. He is a versatile, dynamic, and passionate, world-class, renowned surgeon.
Slide share on the
Yeah, and he has been invited operating faculty in a various national as well as international masterclass and workshop. Still attached to his roots, the medical education, free camps, free online YouTube channel, ENT encyclopedia, free online platforms, and there are so many things, sir is involved for the teaching purpose. International pioneer in endoscopic management of extensive sinonasal and skull-based tumors. Numerous honors, awards to his kitty. Just to mention the recent Best Teacher in Rhinology Award and a 17th Otolaryngology Conference in Dubai in March 2022. Very humble and full of energy. So I have this pleasure to present you Dr. Janki sir, who will be taking us through the case here. And with that, over to you, Janki sir, before I introduce our today's panel for this session.
So I request Dr. Rahul Garg to join us on the stage as a panelist, please. He's a senior consultant at Manipal Hospital and director of RG ENT Hospital. He has special interest in nasal allergies and endoscopic skull base and sinus surgeries. He's one of the few Indian doctors who are reviver of world's most prestigious ENT journal, Laryngoscope. He had given lectures on allergies and other topics at various national and international events. Thank you, Dr. Garg, for joining us. I request Dr. Prasad Kelkar to join us on the dais, please. Presently working as a head department of ENT, Ashwini Rural Medical College, Solapur. Consultant ENT surgeon at Kelkar ENT Hospital at Solapur. He has in his kitty fellowship at Fish Microsurgical Foundation, Switzerland, and fellowship by Indian Society of Otology, Cossé Clinic, France. We have request Dr. Kelkar to join us on the stage, please. Okay, so he will be joining us soon. And then we have two more experts here who are joining us online, Dr. Nageshwar Rao sir and Dr. Anthony sir, both. So I think Dr. Janki sir will like to talk about these two friends, and obviously Kirtane sir is standing here as a pillar and mentor. So I request Janki sir to take it over, please.
Can I start?
Sir, give us a moment. Kirtane sir would like to have some fun.
Please, Janki, go ahead and start. We're just waiting to hear you.
Okay. So very good morning to all of you from Royal Pearl Hospital, Trichy. First of all, I want to thank Sun Pharma for this wonderful opportunity they have given, the brainchild of Elite ENT Club. And I really want to thank my teacher, Professor Milind V. Kirtane, who was instrumental in inspiring me to take up the field of skull base and rhinology. I want to tell a few words about the Royal Pearl group of hospitals. Many people keep asking me, what is the Royal Pearl group of hospitals? Why not Royal Pearl Hospital? Well, during the COVID period, I was thinking, because for the past 18 years, I have been an academician. I wanted to do something different. It got boring because I was running around to several countries to teach. And then I hit upon an idea where we have to do something like entrepreneurship. And when the idea of entrepreneurship came up to me, it is not new to me. In 1998, when I started in Trichy, we were the first to start the Kaveri group of hospitals. So myself, Dr. Chandra Kumar was the brain behind, and we had extensive discussions. 6 of us started. It was just a very, very small, humble beginning of 45 lakhs where we started in Trichy. Today, it is worth more than 3,000 crores. And but I told Dr. Chandra Kumar after 1 year that I want to go towards academics and not towards entrepreneurship. But academics can be converted into entrepreneurship anytime. So that is why after Corona, I thought, let me do something different. I started in Hyderabad, and seeing the success of Hyderabad became a super duper hit. We were operating on 25 cases right from the first month, all high-end cases. And then I thought we'll start in Chennai. The most important thing for entrepreneurship, I believe, in ENT, because ENT does not have a chain of hospitals, is number one is you need trust in the people whom you're appointing in that particular center. Number two is financial management, administration, and then, of course, academics. So we at Royal Pearl want to expand in the next coming 5 years and have as many branches in India and also abroad. That is going to be my goal and aim. And with this few words about Royal Pearl Group of Hospitals, I want to start off with our cases today. So we basically, you know that I am not only doing rhinology, but I also operate on all fields of ENT. And I was formerly trained in otology rather than rhinology by Professor Helms. And also I went to Australia twice and also House Institute. But I was projecting myself as a rhinologist all this while because I wanted to become an academician globally known. And after now, I am now planning to diversify my demonstrations. And today we have 6-7 cases, but tomorrow my inauguration in Chennai is there. So I have to catch my flight at 5 o'clock. So we will try to demonstrate as many cases as possible. The first case being a case which has been referred from the government of Bahrain. So I thank the governments, many governments whom I'm approaching. They are readily willing to collaborate with Royal Pearl Group of Hospitals. And we are now in the process of signing MOUs with governments of various, countries. So now this is a case which has been sent by the MOH of Bahrain. And this patient is okay. I will just read the CT scans for you right now. Before that, I pass it on to Dr. Soumya, who is going to give you a brief account of the case, and then I will take over from there with the radiology. So first of all, again, I thank my teachers who are responsible. Like I remember Professor Gananathan sir, Professor M.P. Rajshekar sir, and then Professor Keithre sir, and more importantly, Professor Sethi, Dharamveer S. Sethi, who was, instrumental in mentoring me, and many of my friends as well, who are involved in this process. Thank you.
Sure. Hello.
Hello.
Focus. First focus, sir. Not the PPT.
On screen, we now have the PPT. Somebody going to talk on that?
Yeah.
Yes.
Just focus, sir, please. Yeah.
Good morning, everybody. This is Dr. Soumya from Royal Group of Hospitals. I'm from Bangalore. I'll be presenting the first case for the day, which is a case of left V2 schwannoma. Here is a patient who presented with the history of left-sided facial numbness for the last 3 months with no other significant history and no other comorbidity. On examination, the vitals are stable. No, the nasal endoscopic examination is within normal limit, and the ear examination is within normal limit. The throat examination is within normal limits. I'll hand over the mic to sir to explain in detail about the CT scan and the MRI scans.
Hello, can you hear me, please? Hello.
Yeah, go ahead.
So we are going to discuss about schwannomas. As we all know, schwannomas, the commonest schwannoma is vestibular schwannoma, but then trigeminal schwannoma is the second most commonest. And we have seen all V1, V2, V3 schwannomas. Basically, when we look at a schwannoma, always look for 3 important things. Number 1, whether it is arising from the cisternal part of the nerve, or it is arising from the intra petrous part, or whatever bone it goes into, or the cavernous part, or the distal part of the nerve. So if it is going to be the cisternal part, sometimes you can have it in the posterior fossa, middle fossa, and outside. So we can have 3 components in 3 different areas. This case, first of all, you should see which is the nerve from which it is originating from, whether it's V1, V2, or V3. This is very, very important. How do you differentiate? So schwannomas are of 2 types, the type 1 and type 2. And basically, Antony type A and type B. In Antony type A, you have a lot of palisades. You have, it's thickly palisaded. And whereas in type B, you have more of cystic degeneration. Always, when you're looking at cystic schwannomas, it's slightly easy in the nose, but more difficult in the brainstem. That is when you do vestibular schwannomas. Now, let us look at, so what are the investigation of choice for schwannomas? The first investigation of choice is a CT scan. But CT scan is not the final investigation of choice for a schwannoma. Why? Because it doesn't give you a lot of findings which are actually seen in a schwannoma and an MRI. So now you can see here, I'm going to read the CT scan. Can you zoom? So basically, if you look at it, I always read the coronal CTs. I'm so used to reading coronal CTs. You can see here, that's the first cut. always look at the nasal septum. The nasal septum is in the midline. The maxilla is not involved. That's the middle turbinate. This is the anterior posterior ethmoids, which are free. And then that's the, the orbit. And then you can see here, that is the inferior orbital fissure. You can see here. There's a small widening of the inferior orbital fissure. And you can see that's the schwannoma coming out. So it's a very classical V2 schwannoma. So you don't have to have any other thing which is actually, pointing towards it. And you can see here, that's the infratemporal fossa, the whole infratemporal fossa. So there are 5 levels of infratemporal fossa according to the Pittsburgh classification. This is the level 1 infratemporal fossa, and it is pushing the posterior wall of the maxillary sinus anteriorly. If you see the axial cut, you will see that very clearly. This is the Hallman-Muller sign. So Hallman-Muller sign is not a diagnostic feature for JNA. This is very, very important. Many people think Hallman-Muller sign means JNA. No. Any tumor which is the infratemporal fossa, which pushes the, which causes the anterior bowing of the posterior wall of maxillary sinus is Hallman-Muller sign. It can be there in the schwannoma. It can be there in any tumors, spindle cell tumors. So here you can see that this is the schwannoma. This is a greater ring of sphenoid. You can see that this is actually the schwannoma. So you have to always look at the transpterygoid space, otherwise called the pterygoid fossa, to see if there is involvement of the pterygoid fossa. And you are not able to clearly differentiate that in a CT scan. So with the CT scan, you can plan the surgery. Planning of surgery is usually done by a CECT. What is the plan for this case? I will tell you. Before that, let me tell you how it will look in an MRI. Whenever you look at the MRI of schwannoma, first look at the T1. T1 weighted image will always be, there will be iso-intensity. Iso-intense tumor involving a specific area, which is very classical of a schwannoma. You can see that it will be well encapsulated. You are having a well encapsulated tumor, and you see that this is iso-intense with the gray matter. You can see that very clearly. And you can see that this is the schwannoma here, and this is the muscle, tensor levi paratene muscle. And you can see that the schwannoma is okay. Now go for the T2. T2 gives you a better picture of the type, whether it is Antony type A, type B, what is the consistency of the tumor. You have irregular consistency, you have hemorrhages inside. All that can be seen in T2. You can see variable intensities. So this is very classical of schwannoma, cystic, well encapsulated lesion. Sometimes you have cysts, sometimes you have hemorrhages, and that is going towards the inferior orbital fissure, not involving the temporal lobe. So if it is involving the temporal lobe, then think of a V3. Whereas if it is not involving, then think of a V2. So here we are. So this is actually a classical example of a V2 schwannoma. Let us go for the contrast. But the best is the T1 with contrast. It enhances very nicely with T1 with contrast. And you can see if there are variable intensities here. And you can see here that this is a very classical example of a schwannoma. You can see that's the bone separating it from the middle cranial fossa. And you can see here, this is the tumor. So how are we going to deal with this schwannoma? What is the plan? Always in a schwannoma, there are 2 ways of dealing with a schwannoma. Number 1 is you can remove it in toto, but that is not good because in V3 schwannomas, it will be very closely related to the carotid artery. So if you go centripetal and try to remove it, you might injure the carotid artery. We've seen a lot of cases where the carotid is compressed by the V3 schwannomas. In a V2 schwannoma, of course, the only artery which is going to be involved is the IMAX. So we should know what artery is going to be involved, what nerve is going to be involved, and whether it is going intracranially or not. Only 3 things you have to look for in anterior skull-based schwannomas. In this case, the first step is exposure of the tumor. Number 2 is internal debulking. So we have to do a lot of internal debulking. You can use a curette, you can use a debrider, you can use a coagulator, whatever you want, debulk it, and then remove the capsule completely. So this is the plan. So I always insist that you should write the plan. The first would be an anterior posterior ethmoidectomy and a sphenotomy. Why do you do an ethmoidectomy for a infratemporal fossa tumor? Because the posterior ethmoids are directly related to the inferior orbital fissure. Only if you decompress the posterior ethmoids, you can release the inferior orbital fissure. So that's why this step is very important, the posterior ethmoidectomy. Sphenoidectomy is important when you have a V3 schwannoma because you drill the maxillary strut. So inferior turbinate will be resected, and then you will do a modified endoscopic Denkers, and then posterior wall will be drilled. In this, I'm expecting the IMAX to be pushed inferiorly and laterally, and then internal decompression and removal of the tumor. So these are the points. If you have any doubts regarding the theory part, I'm most willing to answer.
Yeah, Janki, one question here.
Yeah.
Is there a percentage of the schwannomas which are possibly malignant?
Yeah, so there is a very, very small chance of a schwannoma to be malignant, maybe 2 to 3%. In my practice, I have yet to come across a schwannoma which has not been irradiated, which has given a malignancy report. But however, if you irradiate such cases, there are some centers which give irradiation, and then there is a chance of mitotic changes.
Janki?
Any other questions?
And Dr. Palni Punjab.
Hi, Palni.
The idea you have written, the one, first step, ethmoid and sphenoid dissections, and third step is a Denker. Why not the first step is a Denker?
A very nice question. Actually, whenever we do a Denker, what happens is that we remove the maxilla. Yeah. We remove the maxilla, and if you look at it, to do an anterior posterior ethmoid after that is 1 or 2% more difficult than doing a virgin anterior posterior ethmoid dissection, then coming to the Denker. So for juniors, I teach them, do an anterior posterior ethmoid in a virgin, because we are all used to FES. FES is so easy, and we are used to that very clearly. And we know where exactly the nasolacrimal duct is, and so the Denkers becomes easy. Very nice question. Very good observation.
Thank you, John.
Hello.
Yeah.
Can I ask you a question? See, the schwannomas are the benign, well-encapsulated tumors which stretch the nerve fibers. So is it possible to dissect it from the nerve fibers?
Absolutely not. Absolutely not. It's going to be very... Yeah. So see, basically there are a few differential diagnoses. As I have to tell you, the NF2 can be there, where you have neurofibromatosis too, and you have multiple nerves getting involved. In schwannomas, they are arising from the Schwann cells, but it is very, 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 very unlikely that we can save this V2. And he has already got numbness, and once the patient has already got numbness of a nerve, it's very difficult for the patient to recover the nerve function. Okay. We have never tried to, our main goal would be to resect the tumor completely. But if there are adjacent nerves, try to save the nerves. Shall I go and wash up?
Yeah.
Okay, right. You can keep discussing with Professor Kirtane sir, and yeah, I will wash up and come. Thank you. No.
Hello, sir. Kirtane sir.
Yeah.
Sir, what is your opinion about doing such, small case by open approach, just for the discussion? I just want to know your view. Sublabial approach.
Yeah, I think this is how we used to handle them before the pre-endoscopy eras, but with the endoscopy, your visualization and capacity to visualize deeper structures or surrounding structures is so much better because you can go around angle scopes. So I think when we didn't have the endoscopes, we approached them with a sublabial or even a flap. But Now with the endoscope, I think there's no question. Your visualization, your approach is extremely clearer as compared to when you go just with a headlight. Yeah.
Doing something combined with open approach and endoscopy. In this case, I'm talking about this case only, because this is a quite straightforward tumor if you approach it by the intermaxillary wall, from the anterior wall, rather than going
Yeah,
from
but
the nose
he
into the
said he's going to do Denker, so he will be using the
Yeah.
anterior approach as well. But the visualization that you get with an endoscope is far superior to what you would get with a headlight.
So, Ketan, sir?
So, are you getting my endoscopic picture,
Yes,
please?
Yes.
Can we start, Professor Kirtane, sir?
Please go ahead.
Okay, so I'm just going to just follow my instructions, which I've already written. The first step is lateralization of the inferior tub. This I always do in most of my cases. And this is the first step we do. And then the second step we do is to do the anterior posterior ethmoidectomy, which
Reported of histology malignancy.
this is just to visualize. So you can see here very clearly, that is the uncinate, the free border of the uncinate. You can see the axillary ostium there. Now I'm using the backbiter, and here we are. You go towards the hiatus similaris inferioris, highlighting the base of the Nix triangle. Of course, yesterday we had a beautiful demonstration by Pradeepak Haldipur of basic FES. So we are not going to discuss about all the basic steps. So here we are. So then we do what is called the hanging technique. This is called the hanging technique. I go here, I hang on this lower part of the uncinate process, and then you just see here, you go down and backwards, down, backwards. That's called the hanging technique. And you see here, you get the horizontal part of the uncinate process very beautifully. And then you just have to remove this with the Blakeslee forceps. See, that's the horizontal part of the uncinate process very beautifully. Keep irrigation, please. Yeah. So always keep irrigating with warm saline. Okay, so that's it. You can see here the maxillary sinus, which has already been opened here. Now give me a small ball probe. So the next step here would be using a ball probe to make the attachment of the uncinate process in the coronal plane. So the sagittal plane or the oblique plane is converted into a coronal plane. Now debrider. So then we use the debrider, RAT12 debrider blade. And the movement of the debrider is from anterior to posterior. See here, that is it. 1, 2, 3, 4, 5, 6. And you can see that that's the mucosa of the uncinate process. And that's it. I'm not going towards the frontal. It's not required. So here we are. Now I've exposed the Blakeslee, the bulla. I'm being helped by Dr. Shilpi Bhatia Sharma and Dr. Vishal. Dr. Vishal has been recommended by Professor Renuka Bradu, madam. Wonderful person. Now I can see that's the maxillary sinus. And that's the bulla. Hey, can you give me the straight, please? I don't like to use the curve. Give me the straight, please. 0 rad, pack, pack, pack. So I'm just going to pack the nose. Basically, in my opinion, it's not ideal to suck too much inside a cavity, because by sucking, you're opening up the mucosal bleeders. So basically, I pack. And of course, there are various ways of packing. Some use Merosil, some use packs. For me, I need the pressure. This pressure is very, very important. I will not get this with a sponge. That's why I don't even use the lint, neural lint that is used only in the brain. Whereas this pack is a wonderful pack. And you have.
What was it soaked in?
It is soaked in 1,000 unquantified, undiluted adrenaline. This is what I learned from Professor Stamberger. Yeah. Now you can see here that this is the ethmoids which are going to be dissected. And as I go back, see, there's a small trick I want to show you. When I go like this, see here, when I go like this and my scope is inside, just see what happens. Wait. See, there's a fogging. So see that's the fogging. Now what I do is when you have the external camera, you will know that I stent the middle turbinate. You see here, I stent it like this. So my pressure is towards the stem of the debrider is towards the middle turbinate. So what happens is that it doesn't come into the field at all. So this is exactly where I'm going to find the inferior orbital fissure. Put forward mode. Forward mode, please. So I use the forward mode now. Ready?
Drill mode.
Drill mode. So in the debrider, you can use the drill mode also. See here. Where is it? No. Irrigate. It's okay. Now I can see here that Dr. Nupur madam gave me a beautiful simile which I can use in the nose also. She said, whenever you want to visualize the vocal cords, just go slightly posteriorly with your laryngoscope. It's the same in endoscopic sinus surgery. When you have a little fogging, go slightly anterior and then irrigate. So you have a little distance. Now I've used my drill mode. You can see that's the drill mode. That's the drill mode.
Any reason why you shift to the drill mode instead of the alternate?
Because this area, which is the inferior part of the posterior ethmoid, this area is a little thick, and that's exactly where I have to, concentrate when I do my surgery of the inferior orbital fissure. So this area, I usually drill it off. So give me the drill mode. Now I'm just going to take that out here now with the drill mode. Hello.
So the upper lobe is the maxillary line, huh?
What? What is it?
Maxillary line.
Yeah, that is the ethmomaxillary crest. This is the ethmomaxillary crest. Change bladder mode. See how clearly now. See, doing an anterior post. Dr. Palniappan made a very good statement. Why didn't you do the Denker first? See, this we are used to every day, and so my residents can follow it so easily. That's why always try to do something which people can replicate easily. If you do a Denkers, you might be a little lost when you're doing the anterior posterior ethmoid dissection. So that is the reason why. Okay, now I'm done. Mostly, I have not opened the sphenoid sinus. I don't mind. I'm now going to see how nicely it's been opened now. That's it. Give me a pack. So having done this, the next step is I'm going to follow my next step, which is the inferior turbinate. And then I will go for the modified endoscopic Denkers. So some people are a little apprehensive about this Denkers. Will it cause a piriform aperture problem? So believe me, it all depends on the osteotomies you do. So there are 3 osteotomies we always plan. I will show you how we plan the osteotomies. So, okay, give me the cobblator.
Let's go.
So what we do with the cobblator is, see here, I palpate the piriform aperture here. Tani. So I have to now open up.
Which wand this is?
Tonsillectomy.
This is just EVAC 70.
EVAC 70. Okay.
I don't use the Precise Max. It's too expensive. Hey, what is the 9.5? 9.5? Huh? I use the 9.5.
So EVAC 70, 9.5.
So I'm trying to visualize the piriform aperture.
Yeah. We have one or two online questions. Can we
You can
go
see the piriform aperture very clearly, all of you. Can you all see that very clearly, my dear friends?
Yes, yes.
Dr. Anthony is there?
Yes, very much.
Professor Anthony?
Yes, very much.
So the next step is to remove this inferior.
Hello.
Hello.
You can keep asking questions if you have.
Hello. Yeah, there are one or two online questions.
Let it become very interactive so that.
Yeah. Dr. Deepak Dalmia wants to ask what will happen if we do only intracapsular dissection in schwannoma and leave the capsule?
Hello, I can't hear you, please.
Hello, can you hear me?
Janki. Hello.
Hello.
What?
The question is,
some problem.
You are doing an intracapsular dissection, leaving the capsule again. Intracapsular dissection.
Oh, okay.
Janigram, can you hear me?
Yeah, Dr. Anthony. Carry on.
Yeah,
you can ask me the question.
So can you hear us? Janki, can you hear?
Yes, I can hear you.
Sir, the question is, can you do an intracapsular dissection leaving the capsule behind?
You want to leave behind the capsule?
Yeah, there is a question. The online question.
No, but the question is, should we leave? Does he want to leave behind the capsule?
Capsule. Yeah.
Intracapsular dissection.
I don't think it's the idea.
Yes.
So it's better to remove once you have debulked the tumor inside, it's always better to remove the capsule. It's better to take a complete removal of the tumor because you don't want recurrence. And these elevator, these tumors can recur if you leave behind remnants. So that is the anterolateral wall of the maxillary sinus, which is being dissected here. I generally don't use coblation in this step. The reason is I don't want to do an injury to the asan and masan. What is asan and masan? Asan and masan are anterior superior alveolar nerve and middle superior alveolar nerve, which are branches of the infraorbital nerve. So infraorbital nerve is the upper limit for our dissection, suction. So this is the upper limit of our dissection. You can see here. So I'm just trying to.
Just one question. If we remain in a subperiosteal plane, do we preserve all these nerves?
Of course, yes. Stretch, a little stretch, but definitely we'll preserve it. Now I'm going for the triple osteotomy. You can see here that I go for four-handed. Shilpi is holding the scope now. So we do four-handed technique. So you see how you can see from the external camera. You can see. So I'm not going in for. So there are three osteotomies. One is here like this, lateral osteotomy. Second is superior osteotomy, and third is inferior osteotomy. It depends on what area you want to tackle. If the tumor is in the parapharyngeal space, then I'll go for a low inferior osteotomy. If it's going towards the temporal fossa, I'll go for a far lateral osteotomy. If I have involvement of the cavernous sinus, I'll go for a high superior osteotomy. In this, I might not go in for a high superior osteotomy. High superior osteotomies are notorious for producing alar deformities. So I'm just going to do what is called the mid osteotomy there.
This is a diamond bore on an angled handpiece, or it's some different drill system?
This is a ST Neuro drill system by Karl Storz. This is a hybrid. So it's neither a diamond nor a cutting. It's a fast diamond burr.
It's 75,000 RPM?
This is 1 lakh.
Oh.
And I do most of my carotid work with this burr. I love this. Of course, you can. It's not the tool. I always say it's the person
Burr while
behind.
rotating, how much is the chance of injury to the vestibule? Because we can see some burr touching the vestibule.
You see here, that happens only for, the stylus one, the Midas. You see here, this will never injure the vestibule.
Okay.
So there is a sheath, sir. It will not injure the vessel.
This literally cuts like a butter. Have you approached the NLD?
Janki? Hello?
కట్టేది మరి మక్కడ తేనంలో కనిపిస్తుందా?
Hello?
Janki, can you show the site of NLD?
Hello?
Good Nageswarrao here.
Hello, theater?
Disturbance. Unmute చేసాను.
Hello, Johnny Ram, can you hear us?
See, hello?
Hello?
We are able, yeah.
Hello, Dr. Janki, can you hear us?
Very much, very much. I can hear you very loud and clear.
Okay, just wanted to know about the position of the nasolacrimal duct here.
This is the nasal. See, this is the uncinate process here.
Yeah.
So this is the level of the nasal lacrimal duct. I am not doing anything to the nasal lacrimal duct. See, she's pressing. Can you see the tears?
Yes.
Or no? So in every Denkers, it's not necessary that you should actually cut the nasal lacrimal duct. You can go inferior to it and work. Give. So that's a slight modification. So it is. You can read the paper on modified medial maxillectomy. That is a paper by I'm not sure who has done that. Huh? Ah, yeah, Alberto Schreiber. He was here actually. He's from Italy.
Hello.
Hello.
Yeah. So regarding nasolacrimal duct, you have not transacted or you have not cut the entries into inframatus. Is that right?
Yes.
Okay.
So
So there is no
you
chance of.
don't need to, in every case, you don't need to. Only if the lesion is going towards the cavernous sinus, we have to do that. Or else you don't even have to do that. See, that's the nasolacrimal duct, which is just above this area. I'll preserve that area completely and go behind and forward. So that way, I will not even touch the nasolacrimal duct when I do a Denkers. So that was the controversy in doing the modified endoscopy. Said you're cutting the nasolacrimal duct. It's not required. It's not required at all. Give me elevator. Now you can actually, what you can do is you can medially fracture it. You can actually medial transfer. We have also done nasolacrimal duct transposition. So you just have to do this and then gently transpose it above like this. That's all, finished. So you don't have to even touch that nasolacrimal duct. Come. Now I'm going to take this part out a little bit. Yeah, hold it. So that's it. I'm almost done with my exposure. No, I will do a little more.
Janagram is it enough, the lateral exposure?
I can't hear. Who is that, please?
I'm Anthony here.
Anto, I'm not able to hear. Anto.
So the lateral exposure, is it enough or you have to do it some more?
Sir,
I'm doing a little bit more. I'm revising it a
sir,
little.
good morning, sir. Dr. Nageshwar here.
Hi, Dr. Nageshwar Rao Garu.
Sir, good morning, sir. What is the lateral limit of this dissection, sir?
The lateral limit, you see, you just have to get the lateral
Sir.
aspect of the tumor. That's all. And for that, I'm just extending it a little laterally. That's it. So this gives you a very good access. You can see here very clearly. Can you all appreciate that?
Yes.
Yeah. Take a sleep.
Yes, sir.
So you can see this is the edge of the tumor. Can you see here? That's the edge of the tumor.
Yes. So now you are using four-handed technique?
Yeah, this is four-handed technique. This is just four-handed technique. So I'm not going to take off this mucosa also. Go, finish, please. Okay, right. Now you can see here. Come up, Shilpi. Here. Okay. Now I'm going to show you the of the nasolacrimal duct very clearly. Elevator. Can you see the duct there, all of you? Clearly, I'm pressing and you can see that very clearly. Can you see?
Yes.
Yeah, it's the Hasner's valve. Now, what I can do is just decompress it a little bit and transpose it also. So you don't have to resect it at all. See here what I do. So we have done a lot of cases of nasolacrimal duct transposition. So that is the Hasner's valve. Give me a Blexley now. So that's it. See, this mucosa is preserved. This mucosa is completely preserved, this area. Give me a scissors. Through biting is there? Now, okay. Give me a scissors. Now I'm going in for the Okay, right. Now you see, I have not gone superiorly. I think this is not required. Now, give me a big pack. So finish now. The exposure is over. This patient will not develop an alar deformity. He will not develop nasal lacrimal duct stenosis for sure. So this is the Hasner's valve. I preserved the mucosa there. And now I'm going to start my drilling of the posterior wall of the what?
Population ready, clip ready, ball probe.
Okay, right.
So there is a question from Dr. Vijay from Trichy. Dr. Vijay wanted to understand in this case, since the V2 is already affected, can we sacrifice the intraorbital nerve for exposure?
Scissors. Can we sacrifice what?
Can we sacrifice infraorbital nerve for exposure?
Infraorbital now.
But why you want to sacrifice it for exposure? It's not required, no. If you want, you can do that, but why you want to sacrifice it for exposure? For exposure, you don't need it.
Hello.
Right, sir.
Yeah, we see some raw bone anterior to the NLD. Would you like to remove it or keep it? That bone.
No, it heals by just by fibrosis. I just need to see here the mucosa here around the NLD. I've kept intact. I have not touched it. You can see here very clearly.
The posterior, the anterior one.
This one is raw.
Yes.
I understand it's raw. In case I want, I can drill it, but it's not required. It's not required.
Do you feel that will increase your lateral exposure?
No, it will increase my superior exposure, not lateral.
superior
Lateral
and
is
lateral. Yeah.
This is lateral.
Yeah. Superior
This
exposure.
will be superior. Okay. Right. I'll drill. The problem with the superior exposure is the alar deformity. This is what we have repeatedly faced. This guy is a very, very handsome guy. And I was very particular that I should not cause sort of So I'm just going to keep that rim of the alar. So I'm just going to keep that rim of the alar as much as possible. So that's NLD there.
Yeah.
I'm not going to do anything to the NLD now. The mucosa also. Okay. Okay, now elevator. Elevator, please. So what we call the nasal lacrimal duct transposition. That's it. See, I'm just pushing the nasal lacrimal duct. That's all finished. I'll reposition it back at the end of the surgery. Can you see the nasal lacrimal duct, please? All of you.
Yes.
Nasal lacrimal duct. This is the superior wall. Now, let me not take off this mucosa completely. Back now. So that's the nasal lacrimal duct. I've just transposed the nasal lacrimal duct a little bit and then I'll reposition it back. Okay, now give me a pack. Now I'm going to... Okay, here we are. And once we do that, we will be ready for the tumor. Okay, right. Drill. This is all mucus. I'll place it later. Give. Hey, hold this mucosa. I want the mucosa to be preserved in saline. Have this mucosa in saline, please. Okay, right? Give me good irrigation, my dear friend. Can you all see how is the picture quality, please?
Picture quality is very good. You said you are going to preserve the mucosa. What's the purpose of that?
I will reposition that mucosa. Finally.
Excellent picture quality, sir. We are able to see very clearly.
Thank you, Nageshwar Rao Garu.
Sir.
So that's the region of the inferior orbital fissure.
Yes, sir.
This is the
Palmar sign we can see, sir, here.
This is the intraorbital nerve here.
Yes,
Very
sir.
clearly seen. Okay, now I'm going to start my exposure of
Yes.
the tumor. Hey, the next patient can be shifted. Now, this is the, yes.
I think there's a lag between the picture here and your voice. Your voice comes early.
Audio visual, Dinesh.
Hello.
Audio visual.
There is a problem with his network. This person is
Anto.
Yes.
This person says that you have to check your net connection.
I think that's the reason that this thing also is not very smooth here. Surgery, it's jerky.
Check your net connection because others are able to get it properly. So what bone is this? That's the palatine bone.
Palatine bone, yeah.
So you will have a little bleed here.
The palatine vessels.
Descending palatine artery. And
Branch of third part of IMAX.
Yeah. Now I can see how we have shown completely. Can you all appreciate that?
Yes.
Yes, sir.
Oblation.
Wait. No.
See, that's a periosteum.
Yes. Okay.
So I'm removing the periosteum.
So do you expect vessels before the tumor?
Basically, V2 schwannoma. See, it depends on what tumor and how it grows. For example, in JNA, what happens is, you see here, that's where exactly I expected the infero-lateral area, because the V2 grows from here. So the IMAX is here. It pushes it downwards and laterally. So coblation. See the advantage of four-handed.
Yellow or blue?
So you see, if you have four-handed technique, you can control bleed so easily in endoscopic skull base. There is no problem at all. Now you can see here, this is where, see, basically the V2 schwannoma grows from here and the IMAX is somewhere here. So it depends on how it grows. In JNA, we find it anterior, lateral, or posterior. You can see now very clearly the tumor. Can you all see the tumor very nicely here?
Yes.
Now, again, don't go for the tumor urgently. There is no urgency in getting the tumor. Many people, they want to immediately, jump and get the tumor. Don't. Get your exposure completely. The main thing in skull base is to get your exposure.
Johnny.
Now, what is the exposure which is left? The exposure is left behind the orbital fissure. Okay, give me elevator. Can you see the tumor beautifully there?
Yeah. Tumor, we are able to see that.
Yes.
Now, first I will take off the palatine bone. That's the palatine bone to expose. See here. This is the palatine bone. Plexley, please.
Janagaram, can you hear me?
Yeah. Yes, Dr. Anthony.
What is the consistency of the tumor when you feel it?
Basically, it's variable in consistency. Schwannomas are very friendly tumors. They are not like meningiomas. Meningiomas are little sometimes they are very friendly, sometimes they are very angry. So schwannomas are not like that. They're generally, some parts are suckable, some parts are firm. You just have to nicely internally debulk. So this is the inferior orbital fissure. And see, this is why I did the ethmoidectomy. And exactly where the schwannoma is attached there. So I will take off this area with a punch. This area is very, very, very important. Or give me a drill. Give me a drill. So that area is the key area in a V2 schwannoma. So it's the junction of the inferior wall with the roof of the maxillary sinus. So inferior part of the ethmoids, posterior ethmoids. You see here, this is exactly where the inferior orbital fissure is.
This bone behind, is it a greater wing of the sphenoid?
Which one?
The one which you are drilling laterally.
Here.
Yes.
This is orbit. This is the orbit.
Orbital flows.
So I'm opening up the periorbita there. This is exactly where I'm expecting the site of attachment of this tumor to be. So any doubt so far?
Sir, good morning, sir. Nageshwar Rao here.
Hi, Nageshwar Rao Garu.
Sir, can you show the maxillary strut area, sir?
No, maxillary strut is, see, anything above the V2 is the maxillary strut. We have not yet gone there at all. We have not opened the sphenoid also, boss. See, that's the optic now. This should be the maxillary strut here. This one. Here. Where that's the optic, 1OD. And this is the maxillary strut. Come. Now I'm going to open up the tumor now and start debulking the tumor. I'm very happy with the exposure.
Okay.
Population.
Would you like to get the plane around or you are going directly intracapsular?
We see basically in schwannomas never try to do centripetal approach. It's a waste of time. It doesn't work that way in schwannoma.
Okay.
In schwannoma, it's always centrifugal.
So now you are making an incision with the
You have
carburetor.
to do internal debulking followed by extracapsular resection. You get my point, sir? Biopsy. So it is the same in any tumor inside the brain as well. Craniopharyngiomas, pituitaries, whatever it is, don't go for extracapsular dissection unless it is a very, very highly bleeding tumor like JNA. You go for centripetal approach. Here you don't go for centripetal approach. Go for centrifugal approach. What is centrifugal? Go inside the tumor, debulk the tumor as much as possible. That's it. Give me debrider. Debrider and cobblator. Debrider, cobblator. Debrider, cobblator. No. Give me the debrider, my dear friends. Okay, I'll use the cobblator. No problem. Is it vlogged already? Hey, it's blocked, I think. Debrider, please. Debrider will bleed a little bit, but it's okay. So in vestibular schwannomas, what we do is we use CUSA. This is the same principle. CUSA works with ultrasound, and this is just mechanical.
The ultrasonic aspirator.
Yeah. What are you doing, man? No, no, no. Can you see how I'm doing the internal debulking, please?
Yes, yes. Can you use CUSA with the endoscope?
Of course. But CUSA takes time. It's not like the debrider. Debrider is
Yes, yes.
very fast version of the CUSA. So our neuro colleagues always say, neuro colleagues, when you work with good neuro colleagues, they always say, don't be in a hurry for extracapsular. Do a nice internal debulking. It should be just only the thin capsule. It will just deliver itself. So as long as you stay inside the capsule, there is no structure. See, one advantage of the CUSA over the debrider. What is the advantage? The CUSA doesn't bite the capsule. Whereas the debrider can actually perforate the capsule. Yeah. Cob later. Oh, give. Cob later, please. Can you all appreciate how we have completely debulked the tumor, please?
Yes.
Blue.
Blue now, blue. Okay. So having done that, now I'm going to start my dissection of the tumor. Now, give me a pack.
How will you assess how much depth you have gone and how much more posterior capsule is there? I mean, it's just
By the
on the
feel,
sides.
I was just feeling the posterior capsule with the debrider. That's a little tactile feel, but the best would be the navigation.
Okay.
If you have a navigation, nothing like it. We have used navigation in so many schwannomas, especially when it is going towards the dura. Then one more. Best would be the navigation, the brain navigation, of course.
Yeah.
Because sometimes in the sinus navigation, it doesn't cover all these areas. When you go back towards the posterior fossa and things like that, doesn't cover. So we use the Stryker brain navigation in our center. Hey, come out, man.
Actually, we can see the capsule very clearly now.
Yeah. No, cut. No, cut now. Cut. Yeah. So here we are. So I'm almost done with the internal debulking. I'm now going to start dissecting the tumor. That's it. Now give me a Blakeslee and coagulation.
Just want your opinion between the difference between the sinus navigation and brain navigation.
Yeah, that's a good question. Actually, the sinus navigation, they have a limited coverage. Where is the blue? So you can cover only till the sinuses. When you go beyond the dura, it doesn't cover. Whereas the brain navigation, you have a beautiful cover right till you can cover any part of the brain. So when you get if you want to be a skull-based surgeon, please ask them to attach the brain protocol also.
This is an electromagnetic system or optical system? Hello.
Yes.
Yeah.
Near which part laterally and posteriorly you will
Yes,
look
please.
for radiography? Where is that area you should be careful for internal radiography?
Some echo.
Janagram?
Huh?
Hello.
This is Anthony. Hello.
Hello.
Janagram, this is Anthony. Can you hear me?
Hello.
Hello, Janagram. We are hearing you. Can you hear me?
Hello.
Hello. Can you hear
Can you
us?
hear me, please?
Yeah, we can hear you well.
Yeah. Any questions, please put it forward because.
Yeah, just wanted to know what lateral structure you expect now. Is it a pterygoid muscle you will go till?
Yeah, the temporalis muscle laterally.
Okay, the temporalis.
You will have the IMAX here, inferiorly and laterally. You can go piecemeal. It is not necessary that you should remove it one capsule, one complete piece. Ultimately, at the end, you should be able to see all the structures. That is the idea. The surgeon. So it is the same like acoustic schwannoma when we do skull also. We don't try to remove it completely in one piece. Never. It is wrong to do that because there will be stretch of the nerves. There it's even more difficult. Here also it's the same principle. So remove it piece by piece. Have your patience.
We haven't seen the IMAX yet. So what do you expect? Is it lateral or it's
I told
posterior?
you it will be here.
Still the capsule is there, sir.
I am intracapsular.
Intracapsular, sir. The capsule has to be dissected. Then only we can see the IMAX. So centrifugals.
As long as you are inside the capsule, you will not see any vital structure.
Yes, sir. Yes. It's a protective covering.
You get my point?
Yes, sir. Janki.
Action. Hey, take for biopsy. Huh? Biopsy.
Lux கொடுமா Lux கொடு
So there is a question from Dr. Ravi. Wanted to understand the advantage of cobbler extracapsular dissection with cold steel dissection.
See, cobbler, one thing is there is no bleeding, right? The bleeding is very beautifully controlled by the cobbler. And I think we should use the cobbler in such. And I think this is one of the good tools. Of course, you can do it. Hey, Tani.
Janki,
Yeah.
the question is, you are using the carburetor. What is why can't you use the same carburetor doing the extracapsular dissection?
Oh, yeah, I will. But just wait till I take off the capsule.
Yes.
Right, sir.
I am in no hurry to do the extracapsular now.
Yes.
See, extracapsular, when you use heat, when you use anything, no. The problem is you will cause collateral damage. I don't want the patient to develop trismus after the surgery. If I use a lot of coblation over the pterygoid muscles,
Right.
I don't want him to go back and say, oh, I have pain while opening the mouth. And so I will try my level best to use cold steel when I go outside and inside the tumor, reduce the bleeding with the cobbler. You get my point?
Yes. So the normal structures, when you are approaching normal structure, you want to go cold steel.
Now you see, I'm already getting at the capsule. Can you all appreciate that?
Yes. Very well.
See, this side, I don't have any vital structure here.
Yes.
So I can confidently go and just open up extracapsular with the cobbler.
Okay.
So it all depends on which part you are operating. That is very important.
Yes.
See how nicely it's coming out.
Just peeling of the capsule.
Yeah, I'm just peeling. Can you see that clearly?
Yes.
Elevator. Elevator, please. So it is a matter of just internal debulking followed by extracapsular.
Yeah. Dissection.
See that?
Now you are using a cold steel when going near the pterygoid muscles.
Exactly.
Exactly. Yes.
Come out. Back, please. Can you see? I have now
It's
removed.
coming like a eggshell, no?
Yeah, like it is delivering itself. See, if I had hurried on it, then what would have not been able to do this step.
Yes.
So I think the most important thing is patience. This is what neurosurgery taught me. Patience.
Then they're controlling the bleeding, no?
Huh?
Then they're controlling the bleeding.
Yes. I don't want any rain from above.
Yeah.
So I'm just trying. Yeah, give me elevator now. So this is where I'm expecting the artery. Some person was asking me. Ball proof, Burka. See the fat. Can you see the fat there, all of you?
Yes. The infratemporal fossa.
What were they? Yeah, the vessel is there. I saw it. Can you see the vessel, all of you here, very clearly?
Yes.
Give me a ball probe. Now I'm just going to separate that and then get that vessel. Go inside. Blexley. So you will have the vessel here very clearly.
Yeah.
See, that's the vessel.
Yeah.
Can you see the vessel? All of you, very,
Yes,
very
yeah,
nicely
able to see.
seen.
Yes, yes.
Go inside. That's the vessel.
So 360-degree dissection and hooking out the IMAX.
Yes. Yes. Cobblator. Give me Blexley. Now I'm going to keep a little traction of the tumor, and I want to see where the IMAX is. This is principle of traction and counter traction. Can you see here?
Yeah.
Get ready with coblation. Small vessel entering. Usually in we have even in acoustic tumors, capsular vessels.
Yeah.
They'll just keep entering. You just have to coagulate or bipolarize. In the brain, we bipolarize. Here we can coagulate and gently go and visualize. See the endoscope, how nicely it's giving you visualization. This patient actually was referred to America by the government, and then they got a reference from one of my students in Bahrain. Now you see here, that is the tumor again. Coagulator. Coagulator. So don't damage the, you can see the pulsations there also.
You can see the pulsation.
Can you see that clearly?
Yeah. That is IMAX, no?
Yeah.
So
it's being pushed downwards and laterally.
Janki, why can't we go put a clip there and?
No, if it goes inside, I'll put a clip.
Yeah.
I'm not in a hurry. I'm just seeing what I can do.
Okay.
That's the IMAX.
Yeah.
Go inside. Clip. Clip, please. Now you can see the artery, small artery going there. Can you see that clearly, all of you?
Yes.
Cobblator. Go closer.
Sir, Dr. Gladson from Bangalore wants to know which brand of cobblator do you recommend?
Which what?
Brand of
Brand of
Brand, huh? All brands are good, boss.
right, sir.
I use all the brands.
This nowadays Smith and Nephew is dominating, sir.
Whatever brand works in good for you for many times, use it. That's it. I am not a brand ambassador for any brands.
Right, sir. So there's a question from Dr. Rais from Sharjah. Is there is a possibility of accidentally debriding the capsule?
Accidentally what?
Is there a possibility of accidentally debriding the capsule?
Yeah, so what? Nothing will happen. It's going inside the debrider only, no? So nothing wrong.
Right, right.
If you leave behind capsule only, it's a problem.
Right, sir.
See how beautifully we have removed it. Can you see that clearly, my dear friends?
Yeah.
Yes, yes. Yes, sir.
Is the picture quality good? Clear?
Very, very good.
Yes, sir.
Flip. So the next case is a very, 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 very interesting case. In fact, I'm a little scared to do that case. But I thought every year, Sun Pharma, we should give something very, very tooth breaking. So I'm doing that case.
So the next case is a very, 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 very interesting case. In fact, I'm a little scared to do the case. But
This is not a tough case, it's a simple case.
every year, Sun Pharma, we should give something very, very tooth breaking.
So you can see how can you see all that area, please, all of you?
Yes, sir.
Now I have clipped cobblator. Huh? Yeah. Clip. Clip, please. Give cobblator. That's it. I'm almost going to take it off. Now I'm going to pack it and see whether I have left behind a part of the capsule. There is something below and medially, as Shilpi says, because that's the area we didn't actually. So here we are. See, we have transposed the nasolacrimal duct. This is called transposition of nasolacrimal duct. You don't have to cut the nasolacrimal duct. People have kept on talking about what do you do with nasolacrimal duct? What do you do? Do you cut? Nothing like that. You don't have to do. We have transposed it in several cases. Sometimes what we do is we uncap it and push it upwards. It'll go upwards. You can put a small stitch, and at the end of it, you can remove that stitch. So all this can be done. It is just your imagination, that's all. Okay, right. Now I'm going to take this out and see the infero-medial part. That also is completely gone. So let me use my Doppler. Oh, beautiful. Can you see that? Yeah. Can you give me a cobblator now? Cobblator, Doppler. Give me Doppler. Irrigation.
The descending palatine will come
That's
here.
me, lateral pterygoid plate. Hmm. Can you give me the Doppler, please? Ready? Yeah. See, that's the optic now here. So this
Yes.
should be the carotid artery. And this should be the level of the carotid. I don't know if you can hear it because Zoom filters off the high frequency noises. So we should always be very conscious about where we are, what we are doing, what is the structure underneath. In skull-based surgery, all this very, 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 very important. Now I can see here that's a clip. Give me coblation. I think I've done the surgery completely. Professor Keithre, sir, is there? Or he is left?
Yes, sir. No. Sir is here.
Sir, any comments from your side, sir? Because you are the teacher of teachers.
No, I can't make a comment. I'm speechless.
Sir.
No, beautiful surgery. And I think, Prasad, that answers your question. These details, what the endoscope gives you, you can't get with an external approach. But absolutely fabulous surgery, Janki, and done in record time. I think your speed of surgery is also absolutely amazing. But the clarity and planning, superb, absolutely superb.
Thank you very much, sir. It's all your blessings. What you taught, we are just propagating. That's all. Again and again, we see this far because we stand on the shoulders of our teachers. Without you, I always call you the father of endoscopic sinus surgery, and Dr. Nishit Shah as the father of skull-based surgery in India. So I will never change this opinion.
If you make Nishit the father, then I have to become grandfather.
Endoscopic sinus surgery, Nishit is father of skull-based surgery. Because he was the one who really brought in India a lot of, eye openers. Give me this one now, Surgicel. So having completed, is the other case ready? Who is going to present the next case? That's the case of the.
Janki, you were saying something in the beginning about putting the mucosa back. Are you going to?
Yeah, that's what I'm going to do now. That's what I'm going to do right now. So I'm making sure there's no bleeding. Best is Surgicel. Surgicel is such a beautiful hemostat. So that's the artery being covered. And you see here, there's something which, if you have heard about Professor Karao, I don't know, many of you would have heard. See what I'm going to do now, right now. See here.
So that's the artery being covered. And
Hold. This is what is called, he has presented a paper on vascularized fat from infratemporal fossa used for Stenberg canal leak, and closure of dead space. So many things you can do. So that's exactly what I'm doing right now. So we are also writing a paper on this. So you can see here what I'm doing. This is actually, you can see Professor Karao's paper. It's a wonderful paper on how this vascularized fat is being used for many, many things. Many things they use. So
And it's
here
also
I'm just going to.
Hello, Janki, it is also having a fascia, no? The fat and fascia. Both the
Yeah,
things.
yeah.
Yeah.
No. Here, come out. It's vascularized. The most important thing he did, the research was that it is a vascularized pad of fat. Give me Surgicel. Surgicel, please. See now the dead space. See how beautifully it's covering the dead space. Surgicel. So I think that article, we have been using this for Stenberg canal leak. We have been using this for covering dead space. See how nicely we are able to cover the dead space. Now that's it. So I've covered the dead space. Of course, don't take a MRI without fat suppression, and you will find this is there, and you will say that there is residual tumor. So whenever you take the MRI, take a fat suppressed MRI. I'm just keeping that bone. Give me mucosa now. Mucosa. Give me the mucosa. You see, this is what is called the mucosal repositioning. See, I took the mucosa from the maxillary sinus. Give me ball probe. I'm just going to keep that so that the mucosalization is very, very rapid. Ma suction purchiko. Hey, purchiko suction. Blackesley. Now you see what I will do is to keep this mucosa. Same we can do in sphenoid mucosa also. We can just take it out and keep it back. It's a fantastic layer the other way. Can you hold it now?
Ball probe and definitely. Hold it here.
Blackesley. And we have done this for a lot of cases, and the healing looks beautiful when you see this. Not much. Okay, thank you very much. I hope now what do you do with the nasal lacrimal duct? See here.
I hope
Elevator.
you can hear the applause there. Huh?
Sir, thank you, all your blessings. Sir, see, this is the one which I was always telling. You don't have to cut the nasal lacrimal duct. Many
I hope now what you do with the nasal lacrimal duct?
And the is about nasal lacrimal.
Yes.
Mute చేస్తారు కదా.
Okay, so thank you very much. I will go to the next case. Can I go to the next case, Professor Kirtane, sir?
Please, we are waiting.
Yeah.
Sir, good morning, sir.
Good morning, Nageshwar Rao Garu.
Sir, wonderful case, sir.
Thank you so much.
Wonderful case, sir.
Thank you. The next case is going to be a thriller, suspense thriller.
Yeah.
To Janki sir, and I thanks our today's chair. Thank you so much, sir. Thank you for being here.
Dr. Kusum is not here. Okay. Take the chair, please. Next morning. Dr. Sanjay Agarwal is here. It was here yesterday.
तिथे आता मोरवानी सर मी नाही कुसुम मॅमला चेअर होती तर मग हे आहे अर्चना येते डॉक्टर अर्चना येत आहेत येतो म्हणाले एकच मिनिट ते सांगतो म्हणते
Why so much time?
तिसऱ्या केसची हे जर 2 डॉक्टर असतील तर त्यांना नको बोलवायला.
ठीक आहे ठीक आहे. So I would like to invite Dr. Kusum ma'am as a chair for this second case. Also, I would like to invite Dr. Amol Patil. Welcome, sir. Please be on stage. And Dr. Gaurav Bamba. And I would request Morwani sir also to please join the chair on the dais.
Janki sir, are we ready? We'd like to take this opportunity to introduce our panel just in brief because Janki sir is already ready with the cases. Dr. Morwani sir, I know there is no need to even introduce him. So he's a mentor, teacher, and stalwart in the field. We are honored to even introduce Dr. Amol Patil. He's a gold medalist for post-graduation from BJ Medical College, my alumni. He has special interest in field of lateral and anterior skull-base surgery. He has actively participated in many cadaver dissections and live surgery workshops. I take this honor to introduce and welcome Dr. Kusum Patidar, who has worked in MGM Medical College for a few years. She has done her graduation and post-graduation from Indore and gold medalist in her post-graduation. She's serving aggressively in rural community around Indore, and she had been instrumental in saving thousands of young patients who needed cochlear implants in facilitating and supporting all that care. And she has keen interest in early detection and treatment of head and neck cancer patients. And as I have already mentioned that we have a stalwart here, teacher, mentor to n number of ENT surgeons and
Just introduce him. Don't introduce me. Introduce Amul.
we have already introduced.
Okay.
So we request the esteemed panel to take this program ahead for the session.
Good. Janki, can you start the surgery, please? You're not washed up yet. You want us to do the CT scan before?
Janki sir, can you hear us?
Dr. Janki, can you hear us?
Can you please check?
No, mic nahi
Haan. Because I think it's time to talk, but even patient looks induced.
Check. Check.
Janki sir, can you hear us? Okay. No.
Can show the CT scan.
Dr. Janki na bol.
Hello?
Hello. Yeah, but
Hello, can you hear me?
Yes, sir, we can hear you.
There was a lot of problem in audio visual here. That's why I was reluctant to start the case. Okay, fine. So we are going to start with the second case. I thank the moderators, Professor Morwani sir, Professor Kusum Patidar madam, and of course my teacher, Professor Milind V. Kirtane. This case is a case of a clivosphenoidal ossifying fibroma, and it was compressing the optic nerve on the left side and causing partial blindness on the left side. Now, over to Dr. Manasi for case discussion.
Janki? Dr. Janki? I must take it on.
Janki sir, can you hear us?
Just talk.
Hello, are we audible?
Yeah, you're audible, doctor.
Yes, ma'am. I'll just present the case. Good afternoon, everybody. I'm Dr. Mansi from Chennai. I'm a fellow here at Royal Pearl Group of Hospitals. I'll be presenting the second case. So this is a case of clivosphenoethmoidal ossifying fibroma with left compressive orbitopathy with left compressive optic neuropathy.
Okay, take off that participants.
So this patient is a 16-year-old female. She had complaints of headache that was intermittent and moderate intensity since 2017, and also had worsening left eye proptosis and left vision loss since November of 21. Her left eye vision was 6/9, but rest of the eye was normal. The patient underwent bifrontal craniotomy with bilateral orbital osteotomy with tumor excision on 3rd of March of 2021. In that surgery, the tumor was of variable consistency. It was dual curated, and the dura was closed with frontal sinus exteriorized. And the histopathology at the time said it was ossifying fibroma. Post-surgery, she had mild relief of symptoms. Now, since the last 5 months, all her symptoms had increased again, and also she noted episodes of nasal discharge and facial heaviness on the left side. So on examination, she has a scar over the bilateral frontal region, and ophthalmology examination showed on the left side she had axial proptosis, disc pallor, optic neuropathy, color vision, red and green plates were defective. Endoscopic nasal examination showed mucoid discharge from the left middle meatus, oral cavity and ears were normal. Now over to Dr. Janki Ram sir to explain the scans.
Hello, can you see me? Can you hear me?
Yeah, we can see you, we can hear you.
Okay, now this is a very, very interesting case of a spheno-clivo-ethmoidal ossifying fibroma. This patient presented with diminishing vision for the past around 1 year. She was operated by the neurosurgeon. In my opinion, I think that was the biggest bottleneck for any surgeon to operate again. Why? Let us read the scan and you will know why. Now, this was the scan, pre-operative scan. This was the pre-operative scan. Can just focus the scan. You see here, this is the ossifying fibroma involving the ethmoids and going right inside the frontal lobe. Okay, now this is the, can you focus? Zoom. So you can see how high it is here. Can you see that clearly? And that's the sella here, that's the clivus. It's going right inside the clivus and it is going behind the frontal sinus. It's like, you know, a dome sitting there. Now, what you can see the MRI, pre-op MRI. Pre-op MRI clinches the diagnosis because you can see here that in fibrous dysplasia, you will have uniform ground glass appearance, whereas in ossifying fibroma, you might have a little hemorrhage there, you might have, and it's a young patient also, classical of an ossifying fibroma. Now it is compressing both the optic nerves. Yeah. Now post-operative, just see what happened. After the surgery, what has happened? Now the neurosurgeons try to remove the tumor from above. And what has happened is that the brain has descended into the nose. You can see that the brain is now right inside the nose. And imagine if I remove this, there is no pericranial flap. There is no Haddad flap. And we are left to the mercy of closing it with a facial lata, which is just not enough because the whole of the frontal lobe has already descended. Now, how do you plan the surgery? You see here, the brain is right there. And, this is the lesion here. So I discussed, the patient is very apprehensive, doesn't want any sort of complications. This is the kind of patient I'm facing here, this particular patient. He said that I don't want a complication. Then how do I operate? I mean, a patient can develop meningitis. So now then comes to the aim of surgery. What is the aim of my surgery? Please understand that ossifying fibroma, you have to remove it completely. And if I had removed it in the first shot, we could have done a beautiful job, but we have lost it. The brain is now down without any support. Now it is not possible for me to remove it completely, because if I remove it completely, then the brain will still descend into the nose, which is going to be a massive disaster. Now the only thing which I can do is to save the optic nerve. So the patient is having diminishing vision and I have to save the optic nerve. How do I do it? See here, I'm going to put this MRI scan. So this is the challenge which we are going to face. This is see here, the planum, you can see CSF sitting right there. And these are all the brain tissue going right there. And now what I'm planning is this. I will do a modified endoscopic Denkers. You cannot take a Hadar flap. I will get this lamina papracia and I will start drilling the lamina papracia here. Of course, ossifying fibromas bleed. As you know, there are various kinds, cementifying fibromas. There are so many varieties. Now, I'm going to decompress this optic nerve completely on both sides. This is going to be the optic nerve here. This is going to be the optic nerve. And my aim of the surgery is to take off as much as possible without producing a CSF leak. That means I leave behind a little bit of tumor along the skull base. But we don't know if these tumors are all connected with this brain. This is going to be the challenge. Once I open this, you might have CSF leak. Something like, mastoid. You open the mastoid, the dura is open, it will come through one cell, it will come inside, and you'll have a CSF leak. Like that, I might face a CSF leak. This is going to be a real challenge. Let us see what best we can do for this case. So the idea is not to remove the tumor completely, but to decompress both the optic nerves, with the brain standing right in the center, ready to go down into the nose. And my neurosurgeon said it's going to be very difficult for us to, reconstruct this whole brain from above too. So this is the scenario right now. With this, I'm going to start the surgery. I'm being helped by Dr. Shilpi Bhatia Sharma and Dr. Shiva. Dr. Shiva is Anthony's student. Now you can see that's the endoscopic view. Can you shift to the endoscopic view? Lights down, lights down. Yellow light on the green light on down below. Is the picture quality good, please?
Very good.
Okay, now here we are. So you can see that is looking as if there's nothing there, but it is all full of tumor. And now we will go in for this side. And here again, you can see that this is how it presents right now. Now, the best would be here in this navigation. A navigation would really help. But of course, I'm not connected it to the navigation. Now, I'm going for the modified endoscopic Denker surgery. Ma Tanni. Tanni. So in this, what I will do is I'll be taking off the nasolacrimal duct, not like the previous surgery. Here I'll be removing the.
Sir, good morning, sir. Nayeshwar here.
Hi, sir.
Can you show the landmark for the pre-lacrimal approach to the recurrent lacy polyp, sir? Yes.
Yeah, I'll do that. Hey, coagulation work foot switch.
Janki has come to see your next case of cholesterol for your information.
Please, sir, please.
This is what you
Yeah. Hey, can you give me the foot switch?
keep it ready. Keep it ready.
Ready. Hey, come on.
Thank you, Nageshwar Rao, sir, for joining from the other center. Anthony, sir, is also there, sir. Janki, sir.
Elevator. Scissors.
Yes, thank you very much. Hello.
Yes, sir, we can hear you. Thank you so much for
Somebody
joining.
asked me, Anthony.
Ma foot switch pare.
It's not coming.
Irrigate. Elevator. Ma foot switch இருக்கா இல்லையாமா? Okay, so here we are opening up the anterolateral wall of the maxillary sinus. I am doing a modified endoscopic Tenkert surgery. Yeah. Can you give me a coblation? No? Okay, so here we are. I'm trying to see, that's the infraorbital nerve here, very clearly seen. Good. Honey. 9.5. Okay, here we are. So I'm now trying to go slightly superiorly, expose the superior aspect. It's not like the last case. Last case was different from this case. Here I want to go superiorly. The reason is I have to deal with the optic nerve. Okay, right. Now, drill. I'm going for 400 now. Ready? So first make the osteotomy and then go for the lateral osteotomy. And here I will go superiorly, nicely superior. Here you might have a little alar deformity. I agree. If I go very superior, then you might have a little. So here is where I have to open up the nasolacrimal duct. Now let me go inferiorly. So I'm trying to, yeah. Now give me a tuck tuck. So here we are. So what happens when I do the tuck tuck is that tuck 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 tuck. See. Now you can see here. Now you can see here very, very clearly. Wait. That's the posterior wall of the nasolacrimal. Okay. Now give me a Blexley. Shiva, thank you, Shiva, for coming all over from Tirunelveli just for this conference to help us out. Yeah, that is the anterolateral wall of the maxilla. Give me a debrider.
Right side.
Scissors. Debrider kudu. Now you see what I'm doing is I'm just taking off the nasolacrimal duct is there. Don't worry about it. We can create another. Okay. Scissors.
So with your permission, I will like to make one announcement, please.
Drill. Please go ahead. Yeah, drill.
Dear experts in the hall, a request from the hotel. If anyone has not checked out, please do your checkout procedures. Please do your checkout procedures earliest possible because the hotel authority has contacted us that few of us have not done the checkout. So request to do that, please. Thank you, sir. Sorry to bother.
So that's a nasolacrimal duct. Can you see the nasolacrimal duct, please, all of you?
Yes, sir.
Clear, right? Okay, right. Now, having done that, now I'm going for the next step, namely the middle top. Take it off. Middle turbinate resection. You have to hold the. You can see here, that's the middle turbinate. That's the tumor behind.
Yes. Can we take that?
No chance. Okay, now you can see the superior turbinate also there. Now give me a debrider.
Debrider foot switch.
So the thing is, never go superior. Go superior, you're into trouble because you're going to have the brain coming down. So be very, very, very cautious. Don't irrigate. No. Don't irrigate. That's a tumor. That's superior turbinate.
Block.
Block. Now that's all the tumor here. This is all the tumor. Okay, so having done that, for the tumor ablation now. Bala, there's some air leak, is it? Paranga. Huh? Cobblator, foot switch. Ready? So what is the main aim of the surgery? The aim of the surgery is to depress the optic nerve. That is the main aim. Let us understand what the aim of the surgery is. That should go on in your mind. No heroism here. Patient didn't want any complications. That's posterior wall of the maxillary sinus. Okay. Now let me go in for the next side. So I have now done one side now to my satisfaction. This is the tumor here. That is the superior turbinate. This is the nasolacrimal duct. This is the middle turbinate. The problem is there is air leak, please. Please. Now, this side, please. Elevator. Now I'm going for the next side. Okay, now this is the tumor. Can you see the tumor very clearly, all of you? Now give me a scissors. I can't retain this middle turbinate fully. I will partially resect it. Everything comes under the planning protocol. I have already planned all this before. I didn't show you the plan anyways. It's okay. It's a very narrow nose. You can see it's a small.
So are you planning to completely dissect it? Means remove it, the middle turbinate?
No, I have not planned to resect the middle turbinate completely. You can see that I have left behind so much of middle turbinate.
Okay.
Population.
For the students, I just wanted to understand, like for the students who have joined online, I wanted to understand how you will decide while during the dissection that this much portion I will retain and this much I will.
Nice question. Tani. The planning is all about how, so it's all pre-op planned based on the CT scan. Everything is planned based on the CT scan. So nothing goes without planning. It's all, see, surgery is all about planning, whether it is ear surgery, whether it is skull base, whatever. I always say the hands are just executive tools, execution tools. It's the brain which gives the command. And if your brain gives the proper command, it is based on either your experience before or it depends on how you learned the scan, how you read the scan. So that's exactly how I feel every junior should approach every case. That is, plan your surgery. Plan your surgery. If you don't plan your surgery, orbital tumor. This will take some time.
Half an hour?
Half an hour. Okay, now give me one more. Coblation. Now you see what I'm trying to do is to get a binocular axis. See the tumor. This is the tumor. You suction. Lexley. In my opinion, when I watch surgeons all over the world, I think the main problem in failures, that is failure of removing tumor or execution, I mean, the complications are a byproduct of improper planning, not of execution. Execution, most of them do very well, but the planning, preoperative planning, something which coblation, very, very important. So I'm consciously not going up. I know if I go up, I'm into trouble. I'm really into trouble. Because the brain is sitting right, it's ready to come down. The brain is ready to come down.
So then what is your word of caution here? Because
the word of caution is again and again, I'm telling you, the V2, the level of the V2. That's why I did the Denkers first. You see here, that's Denker. And anything above this level is going to give me the caution, because I've read the scan. Anything above this level is going to be very, 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 very dangerous. So anteriorly this level, posteriorly I can go towards the optic nerve. So that is what we have already planned. Yeah. So the V2 was my landmark. Elevator. So I'll be staying very much below the V2.
Thank you so much, sir, for sharing this.
Give me a tuck tuck. Tuck tuck. So I will show you also in the scan how I planned it. Tuck tuck. See, what we are doing is not new at all, please. I have seen Professor Kirtane, I don't know if he's there in the audience now. He used to do osteopetrosis. I have seen one video cassette when I was working there in with him, marble bone disease. And he had done optic nerve decompression, several optic nerve decompressions for that. So all this is okay.
Kirtane sir is listening to you what you're saying.
Oh, okay.
He is waving from backside. He was standing there. So he will give his expert comment now.
No, I have seen him. Yeah. I've seen his cassettes also. And he used to have that big cassette, not even that small one. It's a very big one.
That video that you saw was 30 years ago.
Yeah, that is what I'm telling. 30 years back, you have done all this. Something new, we are nothing new you are doing here, I said.
No, I think you have taken it to a different level altogether.
Right, it's because of the... The thing is, if the neurosurgeons sort of, cooperate as a teamwork, believe me, there are so many things we can do in skull base, both lateral and anterior. I really don't know who is going to bell the cat in this. Drill. I'm going to start my drilling now. I'm now very, very cautious. What are the landmarks which I have? Let me go to the scan and show you, because many people don't know what I'm planning actually, why I'm doing all this. See here. Give me a, yeah. Can you focus the scan? See here. Now, this is the Denkers, right? Hello?
Yes,
Can you see the scan, please?
Yes, sir, we can see.
Okay, this is the Denkers which I opened here, right? And this is what you're seeing, the bulge which you're seeing here. And this is the center which you're seeing here. And at this level, at the anterior level, the brain is very high. You can see that it's very high. But when I go just one cut posterior, which is around 2-3 millimeters, see how the brain has come down.
Down into the nose.
So if I use this infraorbital nerve as my landmark here, like this, if I draw a line, then I will not hit this brain. Am I right or wrong?
Yes, yes.
See here. Now I'm using this as the landmark. This is going to be my landmark. Not even the roof of the maxillary. If I go towards the roof of the right maxillary sinus, I'll hit the brain here. So I'm using the infraorbital fissure as the landmark and going right there. I'm going to shave it. But as I go posteriorly, this is the orbital apex. This is the orbital apex. I will not go towards midline. Midline is where the whole danger starts. So I will just rub against the lamina papracia.
Yes.
See, this is the lamina papracia. So I'll go here, and then this is the optic nerve here. I will decompress the optic nerve, this part. So this is a safe zone where this is the vomer. This is the keel. So I can take off this part posteriorly, but anteriorly is where the whole, the danger lies. So posteriorly, I can go towards the clivus. This is the clivus, and that's the optic nerve here. This is the optic nerve. So I can decompress this optic nerve, but just medial to the optic nerve, you'll have the brain. So this is what is the planning. This is all the planning is all about. This is just like walking on an electric wire. Now the first step I'm going to do is so I know that is the level. I should not go superiorly here. If I go superiorly, I might have a CSF leak. Of course, small CSF leaks I can manage. But if the whole brain comes down, I'm into trouble. Now here, I don't want to go here again. Now you see, I'm cutting off this tumor like this here. So this is the V2 again there.
Both Burr and your hand are lovely to watch. The way you are taking it.
Behind every man, there's a woman. It's because of Shilpi that it looks good. Blexley, give me a biopsy. If I had done it as a primary case, believe me, I would not be so tensed at all. This is nothing. I can easily remove this. But the problem is already done, and the brain has gone down. Wait, this is blocked. We have done near to 100 cases like this. Not revision, but overall osseous tumors, we have done close to 100 cases.
Sorry, sir, for one naive question. I have missed the initial part of this case. So the patient has any CNS symptoms?
What?
Any CNS symptoms along with?
Yeah. Patient has only optic symptoms. They are diminishing vision.
And headache.
And headache. That is the only complaint now. The problem with the patient is he's got diminishing vision and headache. So now my only aim is to decompress the optic nerve. That's all. That is only my aim of the surgery. Nothing else. Okay. Coblation. So this is completely planned to execute. Now you see here, I'm going here. I'm going to see the level of the inferior orbital fissure. This is the level of the inferior orbital fissure, I know. Bexley, please. Now, this is the, I have to get the lamina paprasia. So, the biopsy, man. Biopsy. Now, what I will do is I'll just take biopsies. I'm not bothered about the center. The center is again and again worrying me.
Biopsy.
Hold. Population.
Biopsies. Now what I will do is I'll just take biopsies. I'm not
Irrigation.
about the center. The center is again and again worrying me. Hold.
Sir, why this patient is having defective vision for red and green light colors only, sir?
There's compression on the optic nerve, boss.
No, red and green colors only. Why is defective?
Earliest is color vision. Earliest we lose color vision. And red is the first which goes. See the sphenopalatine artery. Can you all see that clearly? My dear friends.
Yes.
Hey, wait. Don't press. See the sphenopalatine artery. So we have around 7 cases today. But I'm sure because I have to catch a flight, we will do the cases which have been demanding me to operate. So there are few cases which are actually demanding me, you have to operate like that. So because they have been admitted for 2 days already now. And Vetrivel is already here. Vetrivel, he has got one case from Virupuram. Hold this side. Left side. Drill. Now I'm going straight for the optic nerve. This side.
So these are the few questions which were there. You can.
I think we can go to the other OTs. Yeah.
We can't hear you, boss.
Thank you, Niranjan.
So methylene blue, 1 cc of methylene blue plus 5 cc. You get ampoules to get methylene blue. So that they are for IV use. So 1 cc from that and 5 cc of 0.25 or 0.5 would be okay.
Elevator. Now, am I audible or?
One request for Chennai Center, please have your laptop near you because your voice is not having that high pitch to for the audience to hear. Request for Chennai Center.
Hello.
Anthony, you're not able. We are not able to hear you properly, boss.
Yes, I could see that.
Huh?
Anthony, sir.
Yes.
Thank you, sir.
Can you hear me?
Drill. Now we can hear you, but muffled, very muffled.
Can you hear me now?
Better. Now better.
அங்கேருந்து சொன்னீங்க இங்கேருந்து சவுண்ட் ஈஸியா
voice.
Action block.
மைக் டைரக்டா கனெக்ட் பண்ணீங்கன்னா
இந்த கேப்சர் கார்டு போட்டுருக்கோம் ஒரு வெப்சைட்
Suction. See, the idea of this case is very clear, not to produce the brain prolapse into the nose. This is the most important thing. Come this side. This is maxillary sinus. So the posterior wall of the maxillary sinus is related to the anterior wall of the sphenoid sinus. So these are all the landmarks you should use. Coblation. Ready. Coblation. See, this is the posterior wall of the maxillary sinus. This forms the, you can see that this is closely related to the sphenoid sinus now. So all these are how you get into landmarks without navigation. Without any sort of navigation, you can get into the landmarks. So I know this is the drill. Now I'm going to get the clivus. Hey, drill. So I'm not going to touch here. No, please. Go to the other side. Now I'm going for the center clivus.
Sir, this is Nageshwara here, sir. We have many postgraduates here in Andhra Medical College, Visakhapatnam. They are all watching you, sir.
Thank you.
At this moment, can you classify the Pittsburgh classification of this clivus?
What?
Pittsburgh classification of the
Oh,
clivus.
okay. So the clivus is divided into three parts: the upper, middle, and the lower clivus. The upper clivus extends from the posterior clinoid process till the level of the Dorlos canal. Coblation. So that is upper clivus. The mid clivus extends from the Dorlos canal till the jugular foramen. The lower clivus extends from the jugular foramen till the level of the hypoglossal canal. There are bony landmarks as well. You can say very simply that the upper clivus is from the upper part of the sella till the level of the floor of the sphenoid sinus. The mid clivus from the floor of the sphenoid sinus, till the floor of the sella, upper clivus. Then the mid clivus from the floor of the sella till the floor of the sphenoid sinus. The lower clivus from the floor of the drill. See here, this is the medial pterygoid plate on both sides. What is the landmark? What is it used as a landmark? The medial pterygoid plate is a landmark for the paraclival carotid artery. Here, this is the landmark for the paraclival carotid. So I can drill between the two pterygoid plates. See, all these are the things which give you beautiful landmarks to identify the vital structure. See, that's the clivus. What a case. See that? Yeah, you can shift the other case.
Shift the next case.
Blexley. See how I am now luminizing the clivus. Drill. So I'm using the medial pterygoid plate on both sides. See how landmarks are used. Of course, you can use the navigation and find out. Come out. I'm only scared when I come anteriorly because you know that the brain is hanging anteriorly. I don't want to expose the brain. Drill. Now I'm going towards the lamina paprasia. All tumor. Bob later.
So can I take a few questions and comments?
Of course, why not?
Kusu madam, can you take the questions, please?
Yeah. So, Dr. Janki,
Yeah,
there is one question from the audience.
yeah.
Yeah. What intra-op precautions or tricks to reduce the post-operative crusting in these cases?
What? Introp? What?
Precautions or tricks to reduce the post-operative crusting in these cases?
Post-operative crusting.
Yeah.
Any skull base, you will have crusting. There's no doubt about it.
What precautions do
But
you
only
take?
thing is, see, if you retain mucosa, there will not be crusting. But the crusting goes off in some time. The crusting actually vanishes by using mupyrosin douching. Mupyrosin douching. Yeah, drill.
Okay.
So 6 months, these guys are going to crust badly.
And Dr. M.V. Apparao's message for you.
Hi, Dr. M.V. Apparao garu. Very close friend of mine.
That's a superb skull-based reconstruction, Dr. Janki Ram. You operated one of my cases, V2 schwannoma, recurring 20 years after my excision by sublabial approach.
Thank you so much, sir. That's the clivus. I'm defining the clivus now.
Okay.
That is the mid clivus. Here is the mid clivus. Yeah, this is all. See here. This is awesome. Where is it? Come out. But this is the medial pterygoid plate.
Phenoid is smaller on one side. I don't know where you decide. I didn't do this one.
Not an easy case. It's a very, very, very tricky case.
Doppler ready.
Doppler ready.
Hello.
Yeah.
Can you hear me?
Hello.
This is Satya.
Hey, hi,
Hello,
Satya.
this is Satya. Hi.
You've reached Chennai?
Yeah, I'm in Chennai.
Good.
My doubt is, what is your landmark for the opposite side carotid? You're drilling. You've got the medial pterygoid.
See, this is a rostrum, right? This is a rostrum, right?
Yes.
Okay. So this is a medial pterygoid here. This is a medial pterygoid here. So all this should go between the medial pterygoids. Everything should go.
Right.
You get my point?
Yeah.
The landmark for the carotid is the medial pterygoid plate. There's no other landmark which is more reliable than the medial pterygoid plate for the paraclavial carotid. See how I'm getting the paraclavial carotid. I will get it very shortly, you see. Once I get the carotid, that's it. I get the cobra. After that, it's a matter of just a few minutes. I will get the optic nerve.
Phenoid other side is pneumatizing.
Janki sir, you mentioned you are going to decompress the optic nerve and not going to remove the tumor completely.
Of course.
Will there be any chances of recurrence? Dr. Ratnaswamy wanted to understand this.
Wonderful question. See, the idea is the patient does not want a single complication. Believe me, the patient came to me from Chennai, and he said, I have already undergone a surgery and now nothing has improved. My eye is the only problem. I told him, if I don't remove the tumor, you're going to have recurrence. He said, boss, if you remove, what are the complications? I told him, coblation. I told him that you will have a huge brain prolapse, meningitis. They immediately refused surgery. They said, then I don't want the surgery. I said, anyway, you're going to become blind. Then for that, they said, at least decompress the optic nerves.
Then in such cases, the consent must be very tricky part, sir.
Very tricky, very, very tricky consent. Consent should be like, solid consents, because, I've already got a consent for meningitis. I've already got a consent for CSF leak, but still they are begging me, please, sir, don't give like that. So, not easy to deal with patients who are demanding.
Very true in current times. How much emotional we are with patients and patient makes us emotional, but we need to be very firm and strict on the consent part, the way things are changing in the field.
Exactly. So unless you have a solid written consent, these
We
cases.
also take video consents also.
Yeah. We also take video consents. In Royal Pearl, we have video consents. Despite that, patients are not happy sometimes. Come this side. Hey. I'm going for the lamina papracia now. Completely now going for the optic nerve. Going for the kill here. This is the maxillary sinus. See how I'm going right there for the lamina papracia.
Very up.
I know.
This is the area that is the closest to the brain coming down.
No, here. This is the area.
Yes.
But anyway, we need access for getting the optic nerve, right?
Correct.
I think go closer.
And how to know for sure if it's not communicating with the part that's dehiscent?
Elevator. Now I'm very close to. You have adequate biopsy, right?
Janki sir,
Yeah.
there's a question for you from Indore city.
Yeah.
How would you have proceeded and planned for reconstruction had the patient given a consent for complete surgery with whatever complications will be there?
There is no pericranial.
The only way is to do it from above, boss. We can't do it from below. Because the whole frontal lobe is down. I asked my neurosurgeon whether he can do it from above. He agreed. So it becomes a combined procedure. The patient did not want any external incision. From below, it's almost impossible. You don't have any flap. Pericranial is gone. Oh. Now I'm going very close to the optic nerve now. It's like searching a small pearl in a sea. Not easy.
Very above.
Wait, just go. No problem. It has to be above.
Focus that much.
Hmm?
Getting narrow and narrow.
Hello. Hello. Good afternoon, Dr.
Yeah.
Janki. The question.
Go inside, please.
Yes, I am Dr. Khageshwar from Bhubaneswar.
Yeah.
So my question to you is how to prevent the recurrence of the ossifying fibroma. In the literature, how to prevent the progress.
Hello.
They whatever do, they recur very fast.
No, 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 no. We have a big series of ossifying fibromas, and we just go for the kill. We remove every bit of it. Unless of course, the patient should give consent. You remove the dural plate in which it is attached. You remove the orbital wall. All that you have to do. Then recurrence is less.
Yes, in skull-base particularly this case, you have to leave something. Otherwise, the brain will herniate. In this
In
situation,
this case, the problem is there is no reconstructive flap. That is the problem. And the brain is almost down. They have removed the superior wall.
any medical management in literature to prevent recurrence or
Nothing is that. Nothing, nothing, nothing. This is purely surgical. Can you see what I'm trying to do?
Yeah.
I'm trying to get the lamina. Can you see the lamina papyracea, all of you now? Can you see the fat here?
Yeah.
My dear friends, very beautifully seen. That's the fat and the lamina papyracea. Elevator. See. Now I just have to follow it behind towards the optic nerve. Now I'll show you that. I don't want it to prolapse. See, that's the fat. You can see even the blood vessels there. So I just have to follow this towards the optic nerve. Drill. Now I'm just going to follow that fat towards the optic nerve.
Janki. Hello.
Yeah.
Which is the fat? Please again show it, no? That area. Fat.
What?
See, you have shown the fat now. From the.
Yeah, wait. I'll show you.
We need to excuse Dr. Kusum because she has a flight to catch. Thank you, Dr. Kusum Patida, madam, for joining us.
Yeah. So, Dr. Janki?
Yeah.
Yeah, I have to catch the flight. So, leaving in between, I'm sorry for that. But
oh, madam,
whatever you
we'll
did,
miss you.
Wonderful demonstration.
But we have a lot of good cases. 7 cases we have. Please wait. You can see from the flight also.
Yeah. I'll be there. So thank you. Thank you so much.
Thank you, ma'am.
Janki sir, this is Dr. Moore, Mumbai. I just want to know, you're using a 0-degree endoscope, right?
Yes. This is held by Shilpi.
Yes. Will you be using a 0-degree all along, or you are planning to switch to angle scopes in between?
We generally don't use angle telescopes in skull base. We generally don't use angle telescopes.
Janki, hello.
Yes, sir.
See, you're doing the dissection. Actually, what we are seeing is a periorbital fascia.
Yes.
Yeah.
Yes.
Yeah. Okay.
Can you see that periorbita very clearly?
Yeah. So lamina removed.
Yeah.
Actually, what we are saying is that
Sir.
Yeah.
Sir, can you show the external pictures, how? Sir, can you show the external pictures, how madam is holding the endoscope?
Audio visual.
Sir, can you, the request is, can you just show the external picture?
External picture, sir.
Sure.
How madam is holding the
Cases. It's a 400 surgery. Shilpi is holding the. He's holding the scope, no?
Wow, wonderful, sir.
Scope, yeah.
It's a 400 surgery. Shilpi is holding the.
Thank you.
Elevator. Elevator. Can you see the lamina papyracea being slowly decompressed?
Yeah, we are able to see the fascia now.
See the periorbita.
Periorbita, yes, sir. So gradually you are going to that apex.
Optic, correct.
Orbital apex.
Correct.
Yeah.
See the optic nerve is here. Exactly here. I got it. So I just have to decompress the optic nerve. That's it. That's the idea of the surgery. Total surgery idea is this. Bilateral optic nerve decompression. Don't do anything funny. You don't need to do anything funny. Of course, this patient doesn't want any sort of complications. And from nowhere, how do you get the optic nerve? That's the carry home message for this case. From nowhere. Drill.
Janki sir, there's a question from Chennai. Dr. wants to know, is there any role of navigation in this case?
Of course. If you have navigation, yes, I have 2 navigations, but I mean, it's all your anatomy, boss, nothing else.
Can you drill laterally and medially and widen it a little?
No, I'm scared. Now, anything you go down, you might have the carotid artery.
Yeah. So approximately, can you show the site?
Which one of what?
You are working near the orbital apex.
This is the orbital apex.
Yeah, we know. Which will be the probable site of
elevator?
Carotid.
Yeah, 1 second, I'll show you.
Yes.
Now, you always remember that the optic nerve, if this is going to be the orbital apex here, it will go like this, upwards. So, so the carotid should be here and the optic should be there.
Yeah. Okay, superb.
Drill. Can you see all that orbit being decompressed there, please?
Yeah.
We are so breathless, sir.
Take that suction tip from above, sir.
Which one?
Suction tip of the irrigation. This one come out with a revolving bar. Remove this. Remove from this.
You hit it?
I didn't hit it. You hit it.
I hit it? No. Wait. Come out. Little bit of irrigate.
One minute, please. 1 minute.
Elevator. See, this is all
Better?
Yeah.
So now you are handling very critical structure like optic nerve. You
Yeah.
have
Drill.
that a best planning is important, and Kirtane sir also yesterday mentioned that practice is also very important. But then apart from that, during surgery, what other precautions the future ENT surgeons should take, because they are on virtual platform, and expert teacher like you can mention those knacks. So request to please guide.
The most important thing is knowledge of anatomy by cadavers. Do a lot of cadavers. You should exactly know where the optic will come when you are facing a situation like this, where absolutely there is no anatomy. Irrigate. So the main thing is do cadavers before you do anything. This is what I always elevator. Now,
sir, because the first centimeter of the optic nerve, sir, the first part of the optic nerve is carrying Jora. Is there chance of CSF leaking at this moment, sir?
No. Only if you open up the optic sheath, you will have CSF leak. Or else there is no way you will develop optic. Okay. Now this is the fibrous part. You can see here, that's the optic nerve. Very beautifully seen. Can you see here? That is where the bone has been compressing it. So I have to remove this part of the bone. Once I remove that part of the bone, I'm almost through with the left side. Then I'll go for the right side. Yeah, drill. Now I'm going to cavitate the center of the sphenoid sinus, because there you don't have the brain.
Janki sir, there's a question from Dr. Shashi from Vijaypura. He is asking, use of carotid Doppler will help further confidence to drill and decompression of the optic nerve.
Yeah, of course. But thing is, I'm not gone near the optic carotid, no.
No, irrigation code.
Biopsy. Is the picture quality clear, please?
Yes, it's clear.
Very nice.
Drill.
Irrigation.
Come on. Now here, posteriorly, I can go up because the brain is still not there. But near the planum, you can find the brain. Do whatever side I just want to see. That's it.
I want to let me go first, sir. Bring your drill down. Now you do.
No, but I'm hitching against you.
You are getting, you know.
No, I'm not. Because I'm hitching against you. This is the only way. Hey, drill. Drill, please.
That's it.
Drill. Hitching.
On the scope. Don't irrigate them.
Correct. Correct, correct, correct. Now you see, that is the area which is going to be very close to the optic nerve. There's no doubt about it. At the same time, it's also the area very close to the brain. Can you come out, Shilpi?
Janki, sir?
Yeah.
There's a question from Khalid Hamza from Jordan.
Yeah.
His question is, what about brain herniation falling down if the case was mucormycosis and you have to remove the osteomyelitic bone underneath?
Yeah, that's a good question. Actually, you see, if it is going to be a revision case, see, I'll tell you what, if it's going to be a revision case, then you don't have flaps. Okay, that's point number one. Point number two, mucormycosis is a totally different disease where you have bad prognosis, you can explain. This is a case where it's just an ossifying fibroma and you want to cause a meningitis and things like that, then the patient is not ready to accept certain things because we are not operating for something which is very dreaded. You get my point?
Yes, sir.
Yes, sir.
So we should clearly understand for what indication we are doing. Mucor is different.
Pathophysiology seems to be different.
Janki?
Yeah.
About the orientation, I think your suction tip is over the rostrum of the sphenoid. Am I right? And
No. Come out. See here. This is the rostrum.
Yeah.
This is the rostrum.
Please, rostrum. Okay, please.
And now this is the level of the carotid artery here.
Okay.
This is the level of the carotid artery.
Okay.
This should be the level of the median nerve.
Median, okay.
All this is just by judgment due to dissections.
Yeah.
Come on. It's not easy to show this. Actually, Shilpi is struggling to show me. I'm very close to the carotid artery here. Hey, show. Hey.
So, the help of a Doppler.
Now, if that is the sort of, the cavernous or whatever, then the optic should be above it. Elevator. So that is definitely not the carotid artery for sure. See, because that is the optic. This is the optic. There's no doubt. So these are all things you actually get by experience. See, that bleeding is not from the carotid artery. Drill. Not an easy case, my dear friend.
Janki, it is not carotid, then what could be? It's,
No, these are all vena commitants from the optic. If you have, some bleeders from the optic sheath, you might have bleeding from the optic sheath.
Yeah.
Elevator. See how difficult it is. It's not at all easy. This is a, see, this is the orbit. And the orbit leads towards the orbital apex. This is the,
Yeah.
this is the optic nerve. There's no doubt about it. That's the optic nerve. See, that's the optic nerve. If that is the optic nerve, that cannot be the carotid artery. It's as simple as that.
Very narrow corridor.
Give me a surgery cell, please. It's all venous bleed. Wait.
But then how it is so much pulsatile?
It's not pulsatile. It's actually the brain pulsations.
Okay.
Give me a small pack. Quick. So if I put some flow seal or surgery flow, it will stop.
Yeah, flow seal.
Just keep it like this. Always when there is bleeding, don't go and nibble it. Give me one more pack. Just make it stay and then go to the other side. That's all. This is skull-based surgery. Always, that's a lesson. Don't go put some bipolar. Bipolar should never be used because if you use there, you will damage the optic nerve. You understand? So this will stop just by irrigation. Come this side. Now I'm going towards this side. Drill. Come out. The problem is all because of the previous surgery. Or else I would have beautifully taken this out and then I would have gone very comfortably. This is exactly where you have the brain coming down. Come out.
So maybe a naive question, but just wanted to understand. I'm just curious about it. Whenever there is recurrence, lot many tissue has been replaced by fibrosis, right? So lot many structural changes happen. So how to manage that when you are doing it? And obviously on scan and all those things will not be very clear. So then you may suddenly unexpectedly see some structural change. Then how you deal with that?
No, but it depends on what complication you face, right?
Right.
If it is going to be venous bleed, you keep surgery flow. If it is going to be arterial bleed, then then you have to use heat. So it all depends on what complication you are facing.
Very true.
Go closer.
Sir, in such an extensive skull-based surgeries, what is the perioperative antibiotic and post-operative antibiotic choice?
If we don't open the dura, we go till monocyst. If we go intra.
So that is depending upon whether dura is opened or not. If dura is opened, then we go in for Vanco. If dura is not opened, then monocept. Go closer. It's not at all an easy case. Selected a bad case for demonstration. Very, very difficult. Now, first of all, I have to locate the lamina papyracea. That is the maxillary sinus. This is the middle turbinate. Now, yeah, drill. Decompressing optic nerve going to be very, 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 very difficult. Come on, come on.
Decompressing optic nerve going to be very, 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 very difficult.
Madam also having major role, sir, in assisting you in this such an extensive
Yeah.
She's having a great role, sir.
If she's not there, it's very difficult for me to even see, boss.
Yes, sir.
How will I see?
Janki sir, Khalid Amsha from Jordan, he's asking, what about coblation used beside optic nerve?
Coblation?
Yes, next to the optic nerve, can we use it?
Better avoid everything, boss. Elevator. Better to avoid all the heat generating instruments. Best is cold steel. Oh, this looks like the Dura.
So Avinash Kumar from Sonepat, he is writing, hats off to Dr. Shilpi for constantly holding the endoscope to provide such a beautiful view.
Yeah, really thank her. Deep Rider. Now I'm just going to have that posterior ethmoid exposed and then I will go. This is Deep Rider.
So Narendra Kumar from Chennai is saying, even in this case, you are not using navigation. That's very fantastic, sir.
It's not a compliment, but then I'm used to operating without it. See, our brain is the best navigation. And the more and more you do cadavers, you get into it. I mean, you don't feel the necessity of it. The problem in using the navigation, I always tell this to the youngsters, the moment you use it, no, that's it. You will lose your anatomical, so you will become dependent on it. I've seen several people abroad, without navigation, they cannot operate. And it gives you so much of comfort to open the drill. So you will not have the clinical acumen to operate at all. It will take off your anatomical knowledge completely. That's why even though we have two, I don't use it, because if I teach that to the juniors, they will start using for the frontal, everything. And then after that, you lose your total. So I'm trying to get the posterior skull base. See, the tumor is sitting right there. The maxilla. So this should be the lamina papyracea. See how completely distorted the anatomy is. Not easy. Corblator.
Yes, sir.
Corblator. That's paradigm. Drill. Now comes the difficult part. I'm going for the right side carotid.
Understood.
Where is the? Huh?
This is that. God.
Yeah. Okay. Okay. Come.
Thinner. Don't do it so much.
What?
There's no complication here. Just do a little bit and come in. This is actually navigation based.
Come on. Where is
Right.
this is the headline. Hey, go inside.
Right.
Huh? Dura. Dura?
Looks like mucosa or dura, not sure.
And some cholesterol. Give me elevator. I don't know if that's going to be the brain.
First is coming.
Uh-huh.
First is coming out.
Passa. Come on. Come out. Very close to the brain.
The fourth is that. We are not yet credit for anything.
That's a dura. That's a dura. Come out. Come out. Come this side. Irrigation. Hmm. Hmm. Where is the? Come on.
Big Doppler, sir.
You Doppler. No. Okay. Oh, anatomy. This is the optic nerve. No, that one above. No. But just a minute near the optic nerve, the dura is there. Sure.
There's a surgery, sir.
No. Irrigation. Irrigation. Kudiyanda dey. Kudira. So can you see the optic now there decompressed? I'm not sure if you can see. It's clearly seen. That's the optic now. Give me this one.
Janki, can you use a probe and that's right?
Yeah, I'll just show you the probe. See, this is the optic now which has been decompressed. Let me show you. So that's your orbiter. This is the orbiter. Okay.
Yes.
The orbit. You see here. This is the optic tubercle here. And then you can see that's the optic now there. Can you see here? This is the optic now.
Yeah.
Clearly decompressed.
Yeah, we can see that.
Can you see that or not? Clearly.
Yeah, we can see that.
Yeah. So this is the optic now which has been decompressed this side. And just near it, you have dura, the brain. So I can't do anything here because I don't want, patient has not given consent for a CSF leak. So this is what my plan of the surgery was, to decompress the optic nerve.
Janki, 1 minute.
Yeah.
With the probe, we have shown the optic now. We can use a carotid Doppler and show the site of the carotid now. That area.
No, a bone is still there. Give me the carotid Doppler. Bone is still there. Bone is still there.
Just to know the site.
So if that is the optic now here, this should be the carotid.
Yeah.
But bone is there. That's why you're not able to get it.
Okay. No problem.
This is the optic now here.
Yes. Okay. Yeah. Just to know the relationship. Okay.
Now this side, you see, I'll show you this side. This side, this already the dura has come here. Suction. See, according to the scan also, the planar dura is completely gone. I show you that. See here, already the dura is here. I don't want to produce any disturbance there. I'm just going to call it a day and come out. That's it. Because the left side only the patient had problem. See here, that's the dura already. Can you see that?
Yeah, we can see that.
I don't want to produce a CSF leak there. So I think I'm stopping here. And why? No, nothing. See, I'm pressing the orbit here.
Yeah, now we are able to see the periorbital.
See.
Yes, thank you.
See here.
Yes, now we are able to see.
Very clear.
Very clear.
See the optic. Till the optic I have decompressed.
Yes, sir.
Can you see clearly?
Clearly,
Yes,
it's seen.
we can see it clearly.
So I think this is the best I can do for this patient without any complications, because I don't want to produce complications. And the patient was very insistent, no complications, no CSF leak, nothing. So this is the best I can do. But I wanted to show you how to approach a case like this. You know, it's a very, very difficult and sinister case. It's not easy. And this side, already the dura has come here. You can see the dura is already there. So I don't want, I just keep a little cover over there. Okay. Right. Thank you. So that's actually the clival recess. So that's the maxillary sinus. This is the maxilla on this side. So I have not dealt with this area because you know that the brain is sitting right there and the patient has not given consent for anything. Okay, so thank you very much. I think
Janki, very good demonstration.
Thank you so much.
Janki, very well done.
Thank you, sir. Thank you. I think
I'm hoping to see next case cholestoma.
What is the next case?
Thank you so much, Dr. Janki, sir.
Sir, what has happened is that we have the next patient, we have shifted orbital apex lesion. There's a big lesion in the orbit and Vetrivel has come from Vilpuram and he wants to leave. So I'm putting that case. Then we will plan the next case. He has come all the way and he wanted to see that case being done, his own case. So I'm going to the next theater.
All right.
Thank you so much, sir. Thank you, Dr. Amol, for joining us, and Murvani sir and Dr. Kusum, who has to excuse us for because of the flight. I request the next panel. Murvani sir, you will like to come for the skull base or? Sure, sir. Sure. Thank you. So, thank you. So I request Dr. Vikram Khanna sir to join us as a panelist for the next case. And I will also additionally, I will like to introduce and even thank two other experts who are joining from the respective centers from Visakhapatnam and Chennai. So Dr. B. Nageshwara Rao sir, he's Associate Professor ENT in Andhra Medical College, Visakhapatnam. He did his MS ENT from Andhra Medical College, Visakhapatnam, and attended many national and international workshops and even chaired them. He has a special interest in anterior skull base. The other expert is Dr. Anthony Francis. He is Professor ENT, Madras Medical College, Chennai, more than 25 years of ENT surgical experience, and Chief ENT Surgeon for Dr. Anthony's Endoscopic ENT Center in Chennai. He has more than 3,000 endoscopes. Invited faculty at various national and state ENT conferences like speaker, moderator, expo panelists, conducted many instructional courses, hands-on training, workshops for skin-free based on allergy immunotherapy, and he is one of the editor for the official journal of the association. So I thank these three experts for joining us here as a panel. Thank you so much, sir. Janki sir, can you hear us? So the Trichy team is Khanna sir, by the time sir joins us, can you have your opinion about the workshop and other scientific things? Overall, till the time sir joins in the next OT.
No words can describe, the gratitude that each and every delegate would want to express to Sun Pharma for organizing this.
Sir, it is our honor, sir, to associate.
And
it is our honor.
These cases are not the run-of-the-mill types, the routine types. They are indeed very, rightly, in capital letters, elite cases for an elite audience. And, nice to see that even if it's a working lunch, half the auditorium is full here. And I'm sure it must be the same all over India.
True, sir, true.
And the magician is weaving his magic and leaving us all mesmerized.
And all the stalwarts, even though they have a lot of work, I do not have words for Kirtane sir, Murvani sir, continuously sitting here along with other work.
Very lucky
and
to be
all
living,
the stalwarts here.
Yeah, we are very lucky to be living in the same era.
True.
As Professor Kirtane, Professor Kameshwaran, Dr. Janki, Dr. Nupur, who has been my teacher also, Dr. Deepak Haldipur, and the legendary Dr. Vijendra. So, it was very aptly named Elite ENT Fan Club, and we are all mutual admirers of each other. And I think for especially Dr. Janki, even sky is beyond. The limit is beyond the sky for him.
Very true. Very true.
And all the best to him for his new venture in Chennai, which he's inaugurating tomorrow. And I'm sure it will soon become the center of excellence in clinical and research work both. And I think he is the pioneer ENT surgeon as far as publications and research goes. So many textbooks. I mean, and he's grooming Satya to, follow in his footsteps and take it to the next higher level.
Very true, sir.
And
Thank
I
you
just
so
want
much,
to request Janki that you are training us all. You are training Satya, but even train more Shilpis. You are the only one who has. So we are very envious of you. We want more Shilpis also. Because as he correctly said, behind every successful man, there is a woman. So please train more Shilpis.
Thank you so much, sir.
What will we do single-handedly?
Thank you so much, sir. Over to you, Janki, sir.
So, good afternoon, everybody. We are starting the third case. Actually, this is a very interesting case, and I really thank Dr. Vetrivel, who has come all the way from Virupuram. Come here, Vetri. Come, man. He sent this case, interesting case for the conference. I had asked him long time back, and he said, I will just come and see it and go back. So, this case actually is going to be presented by Dr. Shashi Kumar. Who we have a new set of residents this time. We have taken consultants. From now on, we are taking consultants in Royal Pearl, and we are training them for long periods of time, like 4 years, 5 years. So we'll create many more Shilpis, many more Janikrams also. Over to you, Sashi.
Good afternoon, all. I'm Dr. N. Shashi Kumar from Salem. I'm doing fellow in Royal Pearl Hospital, Trichy. I'm going to present the case 3. This is a left orbital apex lesion with left proptosis. Patient, 25-year-old male, came with the complaints of left eye bulging for past 1 month, double vision and headache for past 1 month. No history of any other complaints, no comorbidities. Patient underwent left side face with the left orbital mass biopsy under GA. On general examination normal, ophthalmic examination, patient have left axial proptosis, rest normal. On endoscopic nasal examination, post-operative status, left fist cavity. Biopsy was cori fungal sinusitis. Oral and ear examination normal. Now I call upon Dr. Janagraman sir for CT and MRI explanation.
Okay, so I hope you got the history. Actually, this patient is a very sinister patient. He presented with proptosis and double vision. And on examination, he had a swelling. He had a proptosis on the left eye with a mass lesion involving the intraorbital contents going towards the supraorbital fissure. Now, what are all the differential diagnoses we can think about? First is fungal sinusitis. You can have a fungus inside. The second is you can have a pseudotumor of the orbit. You can think about Tolosa-Hunt syndrome. You can think about optic nerve sheath gliomas. You can think about hemangiomas. You can think about schwannomas. You can think about any intraorbital, metastasis. So these are all the things which came into my mind. The first diagnosis was fungus. The second was pseudotumor of the orbit. Now, what is the treatment protocol which is followed for fungus? What is the treatment protocol followed for pseudotumor? So before we went inside, when with the patient around 15 days back, I said, inside we took a biopsy and it was a cori fungus. It's still not, confirmed. I contacted Dr. Rath and he said it could be fungus. So then I only did the biopsy. So I know exactly, I took the biopsy from the representative site only. So what if it is a pseudotumor orbit? So this is what was going on in my mind. Suppose it's a pseudotumor orbit, then the treatment is not surgery. It's just corticosteroids followed by radiotherapy. If it is going to be a Tolosa-Hunt, the patient will have painful ophthalmoplegia. Have any ophthalmoplegia, painful ophthalmoplegia?
Janki, we are losing your voice in between. Suddenly.
Hello?
Yeah, now I can hear you.
So the differential diagnosis, as I told you, would be a tumor, like for example, optic nerve sheath gliomas or schwannomas or anything like that, or it could be malignancy, metastasis, or inflammatory lesions. In inflammatory lesion, the commonest is fungus, second is pseudotumor of the orbit. So pseudotumor of the orbit, the treatment is take a biopsy, wide biopsy, and then send the patient for corticosteroids. So corticosteroids, if you give, it will vanish, along with plus or minus radiotherapy. Tolosa-Hunt syndrome will produce painful ophthalmoplegia. So, we got an opinion from the orbital surgeon, and he said, go ahead with, excising maximum of it, and then send it for biopsy and excision biopsy. But you don't have to go chase the tumor completely, because it will lead to thysis bulbi and all this stuff. So, with this in mind, with the orbital surgeon opinion, we do always what is called the MDT, that is a multidisciplinary team approach. So we contact, for example, if there's a neuro case, we have the neurosurgeon coming up, then the radiation oncologist, and then we sit and decide what to do. So that's how we plan in Royal Pearl. It's not just the ENT surgeon planning, so or the skull-based surgeon or a neurosurgeon. It's a complete team approach here. And the team approach, they said clearly that you just remove the tumor as far as possible, and then we will do an excision biopsy, then we will plan it. So with that in mind, we are now going ahead to read the scans. You can see the scan, very beautiful pictures you can see here. So this is the coronal cuts. Hello, can you see the scan, please?
Yes, we are able to see the scan very clearly.
Dr. Vikram Khanna, thank you for moderating this session. Thank you so much. Great friend. You can see here that this is the septum, that's the septum, and you can see here that's the middle turbinate, and that's the ethmoid. As we go, that's a maxilla. You can see the mass appearing along the inferior rectus muscle and going towards the medial aspect. And then you can see that's the inferior orbital fissure, and it's occupying completely the inferior part of the orbit, and the optic nerve is pushed upwards. You can see here. Can you see that clearly? Yes or no?
Yes,
Yeah.
very clearly see.
Yeah, here the superior orbital fissure is, this is a superior orbital fissure, and it's going towards from the, inferior orbital fissure continues, superior orbital fissure continues the cavernous sinus. So these three are like an arc. So here you can see that it's not stopping short of the inferior orbital fissure, going towards superior orbital fissure. Despite this, the patient has not developed any ophthalmoplegia, which is surprising, totally surprising. You should understand that why is there a proptosis? What is the volume of the orbit? The volume of the orbit is somewhere around 40 ml. And any rise in even 5 ml can produce, proptosis. Proptosis we call when we have more than 2 millimeter protrusion of the orbit. Now, this patient, you can see here, this is the axial view. Completely this mass is filling the posterior part of the globe. You can see here the posterior part of the retroorbital contents completely engulfed by this tumor. So what is our plan? The plan is I'm going to resect the inferior turbinate, and I've already done an anterior posterior ethmoidectomy. So I'll do a modified Denkers, remove the superior wall of the maxilla. I will start removing the tumor till the level of the superior orbital fissure. So that is going to be my plan of surgery. It is rather sad that the patient has got a problem like this, because you're going to lose the vision, and the extraocular movements also will be lost. But we can't help it. You saw the last case was also about vision. This case also is about vision. And what is the first case we did? That is also V2 schwannoma. So this theme is orbit, theme orbit. That's why we are taking all these cases related to orbit. And next case also is related to the orbit. So we wanted to make this elite ENT of 2023 theme orbit. So that is why we want to, present all the varieties of cases which are going into the orbit. So I'll wash up in 2-3 minutes and start. I'm being assisted by Dr. Vishal Bombay and Bhatia Sharma. So I'll wash up. Dr. Vikram Khanna, you can just moderate until I come. Hello?
Yes, we are with you.
Yeah. I'm going to wash up now.
Yeah. Is there another mic in the OT?
There is another mic.
Yeah. So Shilpi, one of the audience questions which even you can answer is that green light in the OT. You know, there are many delegates who are asking what is this green light. So maybe Shilpi, you can.
Okay, now I've washed up
hold the
and come, so
secret.
I can answer your question. See, if you look at the standard specifications of OR1 Neo, that is by Carl Stores, they have what is called the OR1. In that, in an ENT theater, there are a few points which have been mentioned. If it is going to be a general surgery theater, we have seen glass windows through which we see the external nature, natural environment we can see. These are all the latest theaters. Whereas for ENT theater, the theater should be dark. It should be very dark. The reason why it is dark is because we generally operate through microscopes. We operate through camera systems, and everything is camera based, ENT. And you all know that when white light hits on the monitor, the glare is more and the precision of the image is less.
Correct.
So there are three lights which are recommended. One is the green light, second is the red light, and third is the white light. So whenever we do general surgical procedures like thyroidectomies or thyroidectomies, we use white light. And with respect to any which has a lot of blood and you're seeing it through the monitor, the best is to use a green light. The green light gives you the best resolution in the monitor. So this is the international standards. So if you go to Germany, I've operated every year in Germany, and they use only the green lights. Okay, now let us go on. Are you able to get the endoscopic view, please?
Yeah, we are able to see the endoscopic picture with the pack in situ.
Yeah. Now I have done the biopsy of this patient, and you can see that I have opened up the, can you see that we have opened up the orbit? I'm going to press the orbit and show you.
Yes, beautifully seen.
Yeah, we have already opened up the orbit. This was done around 10 days back. And that is the orbit. So what I have to do in this case is that I have to do endoscopic modified Denkers, open up the sphenoid sinus, and then open it wide, and then go towards superior orbital fissure. Scissors. So the first step which I'm going to do in this case, next is the CSF leak, right?
Fungal and
Oh, fungal. Okay, right. We have to do. Oh.
Dr. Morwani in the audience is eagerly awaiting for the next case. Cholesterol.
The problem actually is, see, cholesteatoma, everybody demonstrates. So, like for example, Vijendra sir and all people demonstrate. So, there's nothing exclusive in me demonstrating cholesteatoma. And Dr. Morwani sir himself is a fantastic ear surgeon. And so, I want sir to demonstrate cholesteatoma rather than me demonstrating cholesteatoma. I want sir to demonstrate cholesteatoma. Is the other way. So that's why I'm having that as the last priority. Even we have glowers, we have two acoustics, all that. If you tune in every day, Dr. Bikram Khanna, we are almost every day live, if you know that we do live every day almost. So this is just by the Sun Pharma, but we are doing live almost every day. Okay. Now scissors. I'm going to cut the.
Janki, there's another question from the audience.
Yeah.
Next to your viewing box, you have put a needle and syringe with a elastocrep bandage. What is that? Next to
that
where
was
you-
the idea by Shilpi. And suppose nobody gives a marker, then that can be used as a marker.
Okay. We thought maybe it's some lucky charm or something.
Shilpi comes up with very vague ideas. And then she wants me to follow all those. Debrida. So we have a fantastic team here. Actually, it's a very nice teamwork. We all work in unison. And so I'm just going to use my debrider. Open up the sphenoid sinus. I'm trying to open up the sphenoid sinus now. So why do I have to open up the sphenoid sinus? It's because
The access to the superior orbital fissure.
superior orbital fissure, correct. I really want to thank, Sun Pharma for come up with this beautiful idea of LIT-ENT, involving all the nice. In fact, honestly speaking, I called Dr. Satish Jain. He's my close friend. I called him, but he didn't have dates. Maybe he was operating in a different conference. I wanted him also to operate. See, after all, we have to work as a team in India. Can you see the sphenoid sinus, please?
Yes, it's clearly visible now.
So that is actually the level of the. So now you can see here very clearly, I have opened up the sphenoid sinus. I have chopped off the inferior and the middle terminate for access. You can do any orbital procedure. See, that's the optic nerve. Can you see the optic nerve here, my dear friends?
Yes, the bulge is
Not
seen.
like, see this area I didn't touch, but you see there is no maxillary strut at all. See here.
Correct.
It is completely dazed and there's no bone there.
Where did you take biopsy from? He said he has taken biopsy 2-3 days back. इधर दिखाओ किधर से biopsy किया था.
Morwani sir wants to know from which exact side did you take the biopsy from?
Here, from here.
Okay.
See, I have opened up the orbit here and I have taken a biopsy from here, exactly from here. So I will do now a modified endoscopic Denkers. Give. Drill, coblation.
So you also send the sample for bacterial and fungal culture?
Yes.
Because one of the new theories is that you have to do the staphylococcal super antigen theory.
Yeah, but that is not new. It is very old. People have been shouting about it long time now, super antigen. It is not a new theory.
Yeah. And now it is also postulated that allergic fungal rhinosinusitis also has a type 3 hypersensitivity component apart from type 1. So we need to do the fungal allergy and if required, give immunotherapy also later.
You're the boss in that. You're an allergy specialist. We will send the patient to you. Elevator. Now you see, this is very important. See, this is the Denkers. Many people, what they do, they use the FRIAS and go upwards. You should not go upwards. you should go parallel to the floor. See here, you go parallel to the floor and then you go right inside. You will get the junction of the anterolateral wall and the posterior wall. Then you just put it like this and then pull it out like this. This is how you deal with the Denkers. This is how, very simple way. So don't complicate it. Oh, give me a coblation. So any questions? Lunch is over there.
This is people are back.
Yes, sir. Just information for the junior boys. If you ever think about metastasis, do a PET scan. If you're thinking of metastasis, do a PET scan. You can, I've been saying the case, you can get metastasis anywhere. Like you can get a CP angle and clinically or radiologist can say acoustic neuroma, for example. So if you have a suspicion, in fact, one of the best friend of mine was diagnosed as acoustic neuroma, but he had a big patch in the lung. So I said, no, this is CA in the lung and this is metastasis. This is about 15 years back. Okay. So remember, if you have like he has got lesion only in the orbit. They do not have any supplementary lesion anywhere, clinically speaking, you know. If you had some lesion, I'm sure this guy would have done a CT scan.
Very true.
You see? So remember, PET scan is the answer for whenever we are suspecting metastasis. And metastasis can be anywhere. I have seen CP angle. I'm sorry, you're just telling them about acoustic neuroma. 3 CAs I have seen. What it means diagnosed acoustic? CA lung, CA prostate, CA breast.
Yeah.
I don't know whether Kirtan is in the auditorium. Kirtan, are you there? Okay, anyway. So one of the case was Kirtan's patient, okay? CA breast. This lady was operated 20 years back for CA breast. And then she came with acoustic neuroma, go to the metastasis from the breast. These are very rare things, but you have to keep it in your mind.
See the synchrony between the 3 surgeons. See, I am drilling with my suction. Vishal is irrigating and Shilpi is showing. See the synchrony. This is what is called the Russian synchronous swimming. There is no unnecessary movement. Everything is so beautifully planned. Now I'm going for the nasolacrimal duct. Irrigate.
Like in the previous case, here also you will transpose it or you leave it alone?
No, we'll transect it. We'll transect it. Elevator. Now you see what's happening now. When I use the elevator, not this, my dear friend. Give me the elevator. Now see here. Whenever I use the elevator, you see here, that's the nasolacrimal. Hey, can you?
Correct. The tubular structure there.
That's a duct. Yeah. Drill. क्या दबा रहा है यार? नहीं वो डक्ट नहीं है. हाँ ये है डक्ट. So whenever you have that, take a obtuse angle here. Don't take an acute angle here. Take an obtuse angle. So the slice, you can make the slice little obtuse. Okay, can you see the nasal lacrimal duct, all of you, very clearly? Yes or no? Here. See the duct. Scissors. Scissors. Now I'm going to cut the duct now. What?
Yes. Now that bony crest will need to be removed.
Now you can see that the nasal lacrimal duct has been transected here.
Muted and
Now I'm just going to take off that bone till I expose the posterior wall of the maxillary sinus. Who is that? My voice. That's a palatine bone. Debrider. Debrider, please. Scissors. Hey, is the next case ready? Huh? Debrider, please. Come on. Debrider, please.
The right foot.
Hey, block, man. Debrider, block. Pack.
Can we just pack it for a minute or two after giving the wash?
Pack. Why are you pulling it? Come on. Pack. No, I need a bigger pack, man. This is too small, man.
Long pack.
Long pack, my dear friend. Okay. So I'm going to pack and give a wash, good wash. And I'm going to start decompressing the orbit. I've already decompressed the medial wall.
Sir, what is the role of warm saline wash, sir?
Warm saline at 40 degrees, what happens is it activates the extrinsic pathway of hemostasis.
I'm going to start decompressing the orbit.
Why is there an echo?
Sir, what is the role of
There's a time lag between your voice that we hear and its other center, and it is echoing back in your OT.
No, are you also able to hear the same thing which I'm hearing, or?
Yes.
Then the audio visual should do something. It looks very.
Yeah, they are doing something about it from here.
Janki, hello.
Yes, Pal.
The question was why you can't use the warm saline. You have answered, but we were not able to hear.
Why we are using warm saline? Warm saline is a wonderful hemostat.
Yeah.
It acts by extrinsic pathway of hemostasis, suction, and it produces hemostasis by acting on the extrinsic pathway.
Neurosurgeons have been using for 50, 60 years. When there was no surgery, when there were no bipolar cauteries, that's the time this warm saline has been used. Okay.
Yeah, I think Kasam gave a very nice explanation that the barbers, when they have a little bleeding when they shave, they use warm saline and tap the cheek.
Yeah, yeah.
So we got it from the other specialty.
Yeah. So you are working in the palatine bone?
Yeah. Did you see that?
Yeah.
That's a sphenopalatine artery which was
Yeah,
coagulated already.
Yes, yes, yes.
Next case also is a case of proptosis. All proptosis. The theme proptosis. So that's a medial pterygoid plate. Okay. Now that's it. So I have given my good exposure. Exposure is very, very satisfactory.
We are able to see the raphe.
What?
The raphe, the bony element.
Yeah.
Yes. Pterygoid. Yeah.
So that is actually the level of the VDN nerve.
Yeah, no, yes. Okay.
Bhatia. Start. We will start our elevator. Now I'm going to decompress the floor of the orbit. This is the medial wall of the orbit which has been decompressed here.
Yes.
This is the intraorbital nerve here.
Yeah.
And now we are going to decompress the floor of the orbit. Give. Now I just want to see Can you see that? I'm decompressing the floor.
Yeah, we are able to see that. Able to see the orbital periosteum also.
Yes. Blexley. So in case you want to do orbital decompression for Graves' disease, you have to do the same thing. You have to decompress the medial wall and the
inferior.
All part of the inferior wall.
The so-called 1.5 orbitotomy, sir.
Exactly. It's called 1.5 orbitotomy drill. Now I'm going to drill off the inferior orbital fissure. So again and again I say this is the key. This is the key area. Hey, drill. So this is exactly where the V2 goes. So that's the pterygopart and infratemporal fossa. Irrigate. So I've just give me. I've just decompressed the bone. For the next case is ready. Blexley. So we have a lot of cases. I don't know how to finish before I leave to Chennai. This is all mass. No, don't take biopsy now.
Sir, in this case, the lateral recess is there, sir, here?
No,
it
there is no
wrong?
lateral recess. That's the sphenoid sinus. Now I'm going to drill off this area. This is the maxillary strut.
Yeah.
Drill. Coagulation ready go. Okay, now coagulation. I'm ready. My exposure is very good. I'm happy about the exposure. I'm now going for the coagulation, please. So that's the posterior septal branch of the sphenopalatine artery. I'm going to cut it off. Drill. I just want to take off this part of the bone of the sphenoid sinus. Plexly. See the rubbery sphenoid mucosa, it's not normal. It's very rubbery. Petrival, can you see petrival? Don't leave to Vipram without telling me, man. Thanks for coming all the way. So that's the optic nerve here.
Yeah.
And this is the orbit here. Elevator. Now I'm going to work around the orbit just to check what is going to be my exposure. See that? That is the orbit here.
Yes.
Can you see the optic nerve which is being decompressed here? Please, all of you.
Yes.
See the optic nerve.
Yes. We are able to see that.
So you'll have the carotid just below it.
Inframedially, the ophthalmic vessels are now.
This is the. Come out.
Sir, why you have to decompress the optic nerve? Why you have to decompress the optic nerve superolaterally, sir?
See, basically, the optic nerve is here. You decompress from the 9 o'clock to 12 o'clock position. Here.
Because ophthalmic vessels.
Ophthalmic vessels are
in the inframedial
lateral, but sometimes can be inferior. Very rarely. Okay. Now, having done that now, I have almost got the complete exposure. Now I'm going for the kill. Now, give me the coagulation. Ma, Blexley. So, ma, next case ready,
Sir, there is a question from Kanpur. Dr. Sanjeev wants to know, how do you manage empty nose syndrome when you leave behind such wide roomy cavity?
Honestly speaking, empty nose syndrome we have never faced in skull base. Never. I can put my hands down and say we've done more than 2,000, 3,000 cases of skull base and we have never faced empty nose syndrome. Empty nose syndrome, I think, is a genetic disorder. Still, we have not understood what this empty nose syndrome is. See, I did one turbinate resection long time back. Professor Kirtane is there. I don't know if he is there. He will know. That patient was going on complaining of loss of air, sensation, all that. Honestly speaking, it didn't correlate with that surgery which I did at all. The patient actually put a NLD, statement saying I have developed empty nose syndrome. He put a statement. Then I got the letter from Professor Kirtane sir and empty nose syndrome is a very sinister. It's all psychosomatic. Very, see the tissue.
So the role of lateral medialization of the lateral wall in case of ENS. Yes.
So you are working in the area of pterygoparotid fossa, no?
Exactly where
Exactly. Yeah.
Come on. You can go inside. Where is the optic nerve? Optic nerve, come out. All gone.
तो कोई कंप्लेन नहीं तो
So I'm just taking an extended biopsy of all this lesion. Huh? Like what? Yeah, it looks like fungus only. So this is again a biopsy. See, the treatment for, if it is going to be mucor, it's different. But if it's, see, that's the orbital wall, medial orbital wall. I'll give elevator. If it is going to be mucor, it's different. If it's going to be asper, it is not necessary that you should chase it till the, that's V2.
We'll see some yellow coloration of the Haversian system, no?
Yes.
If it's a muca, the appearance of it will be different.
Yes. So this in my most probability will be asper.
Yeah.
And for that, we don't have to chase it till the cavernous and all. Just debulk it, take a good biopsy chunk, come out and give voriconazole or amphotericin. That is the treatment of choice. Okay.
How long would you prefer to give voriconazole post-op? For how many weeks or months?
So basically, we start with amphotericin only in our center, and we give a cumulative dose of around 1.5 to 2 grams.
I think you are talking about liposomal.
Yeah. Take this for biopsy, man.
Janki, Dr. Purvani here. You have a lot of experience. To me, it looks more like a pseudo tumor rather than fungus, yeah?
Yeah.
Looks more like a tumor rather than fungus.
I mean, yeah, you might be right, but the thing
fungus can get sucked out so easily. What mucormycosis, is loose. This is a formed tumor.
Formed tumor. I agree. Sometimes fungus can be very deceptive. It can actually present as a very firm mass. I agree with you. We should have pseudotumor as one of the differential diagnoses.
What is the feeling when you
So
are doing?
that's why I'm not trying to go and do something very dramatic. I'm just going to come out.
Janki, what is your feeling? It is firm? That area?
The treatment for pseudotumor is
No. What is your feeling in that area?
corticosteroids.
What is your tactile
Feeling.
sense tell you that whether this is pseudotumor or fungus? Have you ever seen such fungus before? You have done thousands of cases.
What's your tactile feeling now?
Very firm.
Yeah.
Very firm.
Yes, so it's more like a pseudotumor.
Yeah.
Goes more in favor of pseudotumor rather than fungus then. Even the consistency, the visual consistency that we see.
Yeah.
This is more like mucin and
It's not a mucin at
thin.
all.
This is not mucin, this is a firm tissue.
So if it is going to be, see, one thing you have to remember is that there's something called the oculocardiac reflex.
Yeah. Oculocardiac reflex.
So whenever you are manipulating on the posterior wall of the supraorbital fissure and things like that, you might have a bradycardia. Always check for bradycardia, number one, and don't apply traction on the corbulator. Don't apply traction on the muscles of the orbital apex. So you see the artery is here. So I'm not going to go posteriorly and screw around there. Let us wait for the complete biopsy report and then we'll plan it.
Yeah.
So I think a very important lesson which we learned out of these cases is that when to stop, It's not only that a good surgeon should actually go by his ego and do everything. He should know when to stop.
Yeah. So if
Am
you
I
are,
right?
yes, Janki, if you are having a facility of frozen section, will you proceed?
Sunday, Rat, you are from my city. He'll be sleeping happily. He says, don't disturb me, Janaki. What to do?
Okay.
Yeah, but in this case, a frozen would have definitely helped.
It won't help. Frozen helps you when there's a common pathology. Remember that. When there's rare pathology, frozen is not very good.
Exactly.
It can help. It can help, but for common, like squamous cell carcinoma, any common pathology, or fungus, frozen is good for all those pathologies. When it's a rare pathology, it may not help. Remember that.
So here it may help us to, rule out fungus rather than establish fungus. And
Yeah, but clinically it doesn't look like fungus anyway.
So I'm now going to call it a day. I'm not going to proceed still further. And I've removed quite a chunk of the mass. This is a V2. That's the optic nerve which is here.
Yeah.
I've decompressed the orbit. I didn't want the fat to prolapse. So that's all I have to do here. And that's exactly what I was planning also. Take a extended biopsy and come out. And as Professor Morwani says, I agree with him because it doesn't look like a mucor, or neither does it look, but it is very firm, could be a pseudotumor of the orbit. And if it's going to be a pseudotumor, then it's going to be corticosteroids. That's the treatment of choice. So then I think now I'm coming out of this case. Every case teaches us a lesson, as we know, and we become humble and we know when to stop.
Janki, your pre-op diagnosis also, differential diagnosis was pseudotumor. So some people may give a steroid before going for surgery. You know what I mean? If your diagnosis is pseudotumor, then there's no harm in giving steroid, then going for surgery if required.
Yeah, agreed.
But
some people most of us are not as good as him as a surgeon. So we better all give steroid. Don't go like him. He's too good, you know what I mean? Surgically, he knows how to handle the situation. For junior people, this is a case for steroid. Okay? If it doesn't help, then send it to people like Janki or Satijan and things like that.
But there was also a differential diagnosis of fungus.
That would
also have benefit.
No, the CT scan, the way is a well-defined mass, semicircular mass that doesn't look fungus to me on CT scan also.
Yeah, the only way to prove it is by proper biopsy. And sir says we can start on steroids, then go ahead and take a repeat scan and see whether it vanishes or not.
Yes.
That's another way of looking at it. Good points, well taken. Thank you very much. I'm going to pack it with Surgicel and start the
Yes.
next case.
And thank you, Janki, for organizing this with Sun Pharma. Thank you on behalf of every ENT surgeon all over the world. Okay. I'm just taking your leave. Thank you very much to all of you here also.
Thank you so much, sir. Thank you so much for being there. You are our teacher, and it's always a pleasure to have you and interact with you, sir. I can't forget those days when you used to come to Trichy and operate. And it's a great honor for us to always interact with you, sir.
You go to people where you think इसको अपन रेस हॉर्स बना सकता है, उसके पास जाते हो, गधे के पास तुम नहीं जाओगे हमेशा. You know, people like Satish Jain, I must have gone about 150 times. I have gone to Madhuri about 100 times. I must have come to you about 15, 20 times. I don't know. I don't remember, but that's a long time back. So when you think the potential in the person, I'll tell you funny joke, not joke, real. I went to one lady somewhere from Bangalore. I had to travel 4.5 hours by the what you call Maruti van her husband is to bring. वो खड्डा में से जाते थे. I went to her 5 times. I could not teach her Maring or Tommy. So I told in front of husband, I can't teach you surgery. We are not having affair, so I'm quitting. I'm not coming anymore. You know, I'm not joking. So a point is you go to people and if you can't think that you can improve them, there's no point wasting your time and going to those people, you know. So anyway, Janki, all the best to all of us.
Thank you, sir. Thank you.
Thank you, sir. Dr. Nishi Gupta from New Delhi has commented that they have seen plenty of such cases in their setup, and she feels that this could be aspergillus because it also presents as thickening firm tumor-like mass, you know, like cartilage consistency, and they have a bit of experience in dealing such cases. So that is Dr. Nishi Gupta's opinion.
Yes.
Nishi Gupta is a very nice orbital surgeon. I have had the opportunity to see her and I also work with her for some workshops. She is dedicated her life to orbit, DCA.
That is very true. She has a lot of experience in orbital lesions. Yeah, that's very true.
Shop Eye Charitable Institute. That is the name.
Yeah, so we'll be meeting her on 20. So she's been invited as faculty to Arvind Eye Hospital. Arvind Eye Hospital is a very big ocean in ophthalmology, and she's been invited as faculty, and we'll be meeting her on 25th. It's a privilege to have a ENT surgeon working on the orbit, you know, throughout their life, dedicating their life to orbit.
There is one more question from Jaipur, Dr. Achintya Chavla. How do you manage post-op pain because of the use of the, wide use of the coblator? So, are there any post-op pain issues? And if there are any, what is your formula?
We should understand that in this case, we have actually resected the V2. Other the pain, the patient will have numbness. It will not have pain, they'll have numbness. So, coagulation per se, whether we use it, we don't use it is not a question. What nerve we are stretching, what nerve we are damaging is more important than what instrument you are using to do it. So if you it's the nerve or whatever it is, the patient will develop neuralgia. So we should not produce neuralgia in patients. That is very, very important. Patient will have severe pain. So the other cause of severe pain is creeping osteomyelitis. So if you suspect severe pain post-operatively on long term, suspect osteomyelitis. If you suspect on short term, think about stretching of that nerve. Then what you have to do is go and cut the nerve, do a rhizotomy, cut the nerve. Then you will have numbness, which is better than having severe pain.
There is a comment from Amman, Dr. Khalid Hamsha, saying that in the previous case, to avoid injury to the branches of the inferior orbital nerve, you were hesitant to use the coblation. But in this case, you were near the optic nerve, but you used coblation. So,
see, previous case, that is the first case, we wanted to save the V2. So we want to save a V2, then you don't use coblation, you don't use any instruments by being close to the V2. But in this case, we have cut the V2. I'm committing on cutting the V2. What is the big deal? I have this the tumor itself is sitting on the V2 only. So I directly went, coagulated it, took off the V2. The V2 is gone. I showed you the V2 foramen also. So we should be very clear about what is going to be the post-operative result after we have done the surgery. What is the result? What is going to be? Suppose in a JNA, I want to preserve the V2. And I'm stretching the V2 so much that the patient lands up in a neuralgia. Patient will be rid of tumor, but complaining of severe pain. You want a patient like that? Rather, what you will do is you just cut the V2. So we should be very clear about post-operative out of a little experience. So as you go down the line, Shilpi herself says, no, this is too much stretch cut off. So this comes out of a experience where patients come and nag you for pain, severe pain. And that is when you decide on sacrificing certain cutaneous nerves. Anything else, Dr. Vikram?
There's a question from Morocco saying that if it is a tumor, then Dr. Morwani suggested to give steroids. But will it not worsen fungal disease? So I think if it's allergic fungal, so it should also benefit from corticosteroid rather.
No, that's a brilliant actually. Giving preoperative steroid diagnosis is going to work like a bungee jump. You never know. You can exacerbate the disease also. That's why for definite biopsy, then go in for whatever definitive treatment. Of course, there are some people who may think with the scan itself, this is a pseudotumor and go ahead. But you never know. If it exacerbates, who knows? I mean, fungus exacerbates.
So it is always better to have a tissue biopsy report on paper before giving a trial of corticosteroids, especially if the report comes negative for fungus.
Exactly. Anything else?
That was the last question for this case.
Shall we go ahead with the next case?
Yes. While you shift OTs, we can also take a small break and get our tea or coffee after using the washroom.
I also want to eat a little.
Yes,
I'll
please.
take a 5 minutes break.
Yeah, please do. I think curd rice is waiting for you.
Yeah.
Staple diet.
Okay. Thank you, Dr. Vikram. Wonderful moderation by you.
Always a pleasure.
Give us 5 minutes. I'll be back with the next case.
Yes.
Sure, sir.
Sure.
So around 3:30, sir? Or it will be too late?
Yeah, 3:30.
Sure. Thank you. So I request if you want to grab a tea or coffee, please have it and back to hall soon by 3:30. Thank you, sir. Thank you. And I would request Khanna sir to be there on chair for the next session as well. Thank you, sir.
करेक्ट चेक चेक आ रहा है एक सेकंड हैंड में चेक करो हैंड में कनेक्ट नहीं कर दिया अच्छा नहीं हैंड में कनेक्ट नहीं किया दो इधर से कनेक्ट कर वो भी चेक करो चेक हे हे check check hello yes check hello 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 check check आ रहा है बंद करो बोलो हेलो 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 टेस्टिंग ठीक है
Hi, Siva. What are you looking, man?
रुको अभी देखो बोला Hello, hello, check. Hello, 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 check. Hello, check, 1 2 3. Check 1 2 3. hello, hello, check. ये क्या कर रही है? इसको कम करना है. Check, hello. Hello, check 1 2 3. Check, hello, 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 hello. हेलो. ये बराबर है सर. हेलो. ये बराबर है ना. हेलो. ठीक. हेलो. नहीं मैं माइक के बाजू में ही खड़ा हूँ ना. हेलो. ठीक है ना. तो छोड़ दो.
हेलो. कॉल तो आए नहीं. कॉल तो आए नहीं. फोन वगैरह.
Are you ready? Hello? Hello?
Yeah. Listening. So give us a 5 minutes. We'll call all the people inside the hall.
Yeah. So we have some more interesting cases. Shall I wait?
They told 5 minutes. 2 minutes.
Where is my cell phone?
So 5 minutes, sir.
Oh, put it on.
As panel, I request Dr. Palani Appan, sir, to you can join with the cup. No issue, sir. You can take and join. As expert, Janki, sir,
Yes.
so you could take some food or no?
Yeah, I'm ready. I'm ready.
So if you want, you can start because few of the experts are already inside the hall, and rest all are coming.
You want me to wait? I'll wait. No problem.
No, sir, don't wait. I request you to continue because online all the students and all the experts are waiting.
I heard online 5,000 people are watching. Is it true?
So more than 6,000.
6,000. Hello? Hello?
Your viewers are currently enjoying the visual treat given by Dr. Janki, sir.
6,000 people watching, is it?
Yes, sir.
Oh my God, it's a record. It's a record, big record. Okay, now let us start with the next case on team proptosis. So this is the fourth case we are posting to you with proptosis. Now, the case will be first presented by Dr. Vinay and bilateral. And then we will start from there. Dr. Vinay, over to you.
Good evening, everyone. I thank Madam Sir and for this opportunity. I am Dr. Varun Kumar, a consultant in the Royal First Group Hospitals. So today I'm going to present a case of a 21-year-old female who was brought by her parents with complaints of right-sided nasal obstruction since last 6 months, with right-sided nasal discharge and weekly smell sensation for the last 2 months. And she had complaints of right eye swelling and watering of the side for the last 15 days. No other history and no other comorbidities. So on examination, general examination was within normal limits. And patient had a right side axial proptosis. Other than that, she didn't have any ophthalmoplegia. And the patient on endoscopic nasal examination, there was a right polyp which was visualized till the vestibule and a left PNS was there. Rest, oral cavity examination and ear examination was within normal limits. So this is the endoscopic image which you could see.
So I asked Dr. Janki to take over for the CD scanning.
Hello, can you hear me?
Yes, sir.
Hello.
Oh, answer me. I'm patient from Assam for journey. So I'm going to briefly tell about the history. The patient has right axial proptosis, and on examination there is a polyp with fungus. So here we can see, in case of if you suspect a fungal sinusitis, you always have to take a soft tissue window. Bone window may not be useful, very useful. Soft tissue window always in case of tumors, in case of fungus. These two you should ask for a soft tissue window. Now let us read the scan. This is the bone window. You can see this is the frontal sinus on both sides. You can see here that the lesion is going inside the orbit. Can you see here the lesion going inside the orbit?
Yeah, now it is visible. Okay. Able to see.
Who is moderating?
So Dr. Palani
Hi, Pal, can you see?
Yeah. We are able to see. We are able to see. Very well, we are
Now-
able to see them.
Yeah, now you can see here.
Yeah.
This is the lesion which is going right inside the orbit. There's no lamina papyracea,
Yeah.
and it is completely expanding the frontal recess. Usually, fungus expands the frontal recess.
Frontal recess, yes.
Yeah, and you can see here that this is the dural plate completely eroded. Can you see the erosion of the dural plate here?
We are able to see the erosion.
There is no dural plate at all.
Yeah. Yes, sir. We
And
are
here, this is the anterethmoidal artery. This is the anterethmoidal artery right in between the fungus. The fungus is engulfing the anterethmoidal artery.
Yeah.
So we will find the anterethmoidal artery somewhere right in the center.
Yes.
Now, if you look at the planum also is completely eroded, the lesser wing of sphenoid.
Yeah.
And both sides, the sphenoid is completely involved by disease. So if I see the soft tissue window, you can see here, this is the frontal sinus. It's very narrow.
Yeah.
Frontal is very narrow. And you can see the lesion in the orbit here.
Orbit, yeah.
That's the frontal recess, which is widened like a balloon.
Balloon, yeah.
The dural plate is completely eroded here.
Yeah.
The anterethmoidal artery is right in the center here.
Yeah.
And then you can see the planum also is completely eroded. And here you can see that the mass is eroding the posterior wall of the maxilla also, little bit. Only the periosteum will be there. The bone might not be there. So then you can see here that this is not going into the infratemporal fossa.
Anterolateral wall? Anterolateral wall.
Yeah, anterolateral wall. This is the anterolateral wall.
Yeah.
This is the posterior wall.
Yeah.
So definitely there's erosion. This is a sphenoid sinus, both sides sphenoid sinus involved.
Okay.
And that's a choana. So how are we going to deal with it? The most important thing, the common case we'll be seeing in our practice, especially anterethmoidal artery, how to deal with it. This is the main idea of this case. Now I will wash up and start the case. Dr. Palniappan, you can keep interacting with the audience.
Yeah. Okay. So in many cases, we are saying this sinusitis. It is due to allergy due to fungus. So AFRS cases, many cases we are dealing. Any question, please ask.
Any question from the audience, please?
Regarding CT.
Sir, what about the parasagittal pictures in case of sphenoid and extrasphenoidal mass lesions?
Yeah. Janki?
He has got.
Now he is washing.
Washing.
Yeah.
Okay. So I'm here.
Janki, meantime, there is a question from the audience. Okay. The parasagittal sections, will you give importance?
No, more case. Last one.
Parasagittal sections.
It's only 4.
No, it's okay.
Then you have to do CSF link because she's running fever.
We'll do it. Okay. Now, what is the question, please?
Parasagittal sections.
Sagittal section, huh?
Yeah.
We can take it. See, I think we have. Hey, do you have the Sag view? Axial is there. So basically, sagittal view is taken for the frontal recess.
Oh, there is
If
a question from the audience.
Cell.
Yeah.
In this case, there is no cell.
Okay.
Axial and coronal are there. Sagittal is not there.
It's a question from the audience. They are asking. Yeah.
You can see that there's a DNS on this side.
Yes.
Clear?
Yes, we are able to see that.
Now I'm going to start my
mass lesion on the right side. Yeah.
Hey, drill model irukku.
Yeah, press sir. Now do. Okay.
No, man. No, man.
Now.
Janki Raman. Hello, Janki.
Suction is not working. Yes, Dr. Pal.
Preoperatively, when you admit, what is your protocol?
Preoperatively, basically, we put the patient on itraconazole.
Itraconazole? How long?
Itraconazole 200 milligram BD.
BD.
We can put it for at least 2 to 3 weeks. It helps very well.
Okay.
It actually causes nice fungal load reduction.
Yeah, it reduces the load, fungal load.
Yes.
Yes. Okay.
Now you can see here that I'm starting the surgery.
Yeah.
The first step is to luminize the airway.
Yeah.
So first is, see, I've gone till the choana. You can clearly see that. Can you see that?
Yes, we are able to see the choana.
Now the next step is we have to get anatomical landmarks.
Yeah.
So we don't know which is the middle turbinate.
Yeah.
So we are now trying to delineate the middle turbinate.
Turbinate.
So you can see that's the turbinate, very clearly seen.
Yes.
So this is all like mathematics. It's so easy.
Yeah.
Nothing difficult about it. So this looks maybe like a concha bullosa.
Concha.
Okay, that's the Ansonet process.
Yeah.
See how Shiva is irrigating. Most important thing, many people, they don't use the irrigation in their practice. That is not good. See the bulging of the Ansonet.
Yeah. Even we are able to see the fungal mass inside, no?
You can see the fungal mass.
Right? Yeah. Are you using the endoscrub?
No. This is Shiva who is.
Yeah. He is endoscrub. Yeah. Shiva, great.
So it's going into the orbit.
Yeah, great.
So I want to see where it is going into the orbit also. Shiva, keep irrigating.
So that's the middle turbinate.
You can see the middle turbinate very beautifully here. Can you see here?
Yes.
Very nicely seen middle turbinate.
Turbinate, yeah. Going to the ethmoids.
See,
yeah.
Fungus, it is just every sinus will be dilated.
Yeah.
So it is very easy to operate. Can you shift the next case? Give me a good wash. So the main thing here is to give good washes.
Sir, this is Nageswara. What is the meaning of choanal banking effect for the benefit of the postgraduates?
Yeah, choanal banking effect. You see, whenever there is polyp which is obstructing the choana, the blood regurgitates and it actually fogs the scope. It's a very difficult thing. So I always advise the first step in your surgery should be luminization of the airway to clear off the choanal banking effect. So that is what I always advocate. So Dr. Nageshwar Rao Garu, right?
Hello,
Visakhapatnam.
Huh, sir?
Visakhapatnam.
Yes, sir. Yes, sir. Thank you, sir.
I think there is some echo. On some of the center, the mic is on. So I request all the centers to mute themselves unless needed.
Please mute yourselves, all of you. There is a lot of echo here also. Very disturbing. So you can see here that I'm now trying to just irrigate and take off all that allergic fungal rhinosinusitis. My estimated time is around 30 minutes. That's all. In 30 minutes, we are able to finish this.
Seems to be a mere fungal mucin.
This is fungal mucin. Yes, correct. Yes. Allergic mucin with charcot-laden crystals.
Yeah.
So this case also presents with proptosis. I will show you where this proptosis has occurred. So very shortly you will be seeing that. Is the next case ready?
Sir, liposuction is better in this situation, sir.
Yeah, my suctions are all liposuctions. They're all very powerful suctions. And all my suctions are liposuctions. The main problem in taking time is suction block only. If we get good suctions, you can do these cases fast, or else it's going to take a long time. Okay.
So Janki, unlike the previous case, this consistency is more and appearance is more of, polyps and maybe.
Exactly.
So now, we have immediate comparison where the previous case, now we can be more sure that it was a pseudo tumor rather than fungus. And this looks more like fungus. You can see this.
Dr. Vikramji, is it you?
Yeah.
Actually, Dr. Vikramji, you see here, you have 4 kinds of fungus. It's not just one. This is allergic fungal rhinosinusitis, which is a totally different entity.
Yeah.
So we have the second is mycetoma, that is a fungal ball.
Correct.
And there you will not find the chitin, allergic mucin and all this stuff.
True.
Then in case of invasive fungal sinusitis, there are 2 varieties. Number 1 is acute fulminant and second is chronic granulomatous. Chronic granulomatous can present as just rubbery masses. And I have seen both mucor and aspergillus presenting like that. So you cannot put your hands and say it is pseudotumor. I will give you the biopsy report. That's a different issue. But fungus can present any way. There are
Janki.
4 different ways the fungus present. We have seen rubbery tissue of aspergillosis. We give, I told you, we give preoperative itraconazole and steroids.
Yeah.
And that helps. Of course, this case we didn't give because patient came only 2 days back and we wanted to post that case for
Okay.
workshop. Certain things we cannot.
And the next question is from Haldwani, Pooja Suyal. Dr. Pooja Suyal. The question is, what kind of fungal sinusitis is it? AFRS?
This is allergic fungal. AFRS, eosinophilic fungal rhinosinusitis.
Yes.
There is no doubt about it.
Again, she is asking another question. Any pre-op biopsy and antifungal treatment in this case? Any pre-op biopsy and antifungal treatment?
This is very classical. There is no need for biopsy.
Okay.
What you can do is once you see this itself, you know it's allergic fungal rhinosinusitis. And
Any
for such cases, you can start the patient straight away on
And any
itraconazole.
antifungal treatment you have given it or not? Preoperatively.
Yeah, itraconazole.
Okay. And another question from Ravindra Bansal from Gwalior. What are the indications of draft procedures in case of AFRS?
See, usually in AFRS, what happens is that it widens the recesses. So there's very hardly any indication for radical procedures like draft 3. They open up all the sinuses. The fungus itself, you will see now. Once I open the frontal, you will see it has completely opened up the frontal.
Yeah. Okay, thanks.
Sir, that time you were mentioning about 4 types of fungus. Is there any difference in the management of all of them?
Of course, there's a lot of difference between management of allergic fungal rhinosinusitis versus fungal ball versus chronic granulomatous versus invasive. So that's totally different. All 4 are totally different entities. Please understand. So what is the treatment for allergic fungal rhinosinusitis? The treatment is you have to debride all the fungus, marsupialize all the sinuses, and then put the patient on itraconazole. 2x2 regime. We call it 2x2 regime. That is 2. See that it's going. That's the dura. You can see that very clearly. Can you see that?
Yeah.
That's sitting right on the dura. Now give me this one, debrider. Now that is about allergic fungal rhinosinusitis. For mycetoma cases, that is for fungal ball, it's the best prognosis. You don't need anything. The patient will have super result if you clear it. You don't need any antifungal, nothing. So
Janki, we have lost audio from your side.
No, he's in contact. Janki? Hello? Hello?
Janki, sir, can you hear us?
Hello? Audio?
Team, please check. Check on that, sir.
Hello?
Hello, can you hear me?
Yes, we are able to.
Now we can hear us.
This is the first time Dinesh is causing some problem in audio visual. He is always a professional. We never experienced this before. RAT 40. Okay, what was I telling?
Last we heard from you was for post-op in AFRS.
AFRS
is given.
Itraconazole.
After marsupialization of all the sinus openings.
Yes.
Different management.
And you showed us the dura in.
Give me J-curate. Now, in mycetoma, that is the fungal ball, no need for any antifungal treatment. No need for any antifungal treatment. It's the best prognostic out of the 4. This is the best, the fungal ball. So that is the second. The third will be the acute fulminant. Acute fulminant due to mucor. In that, what we do is we completely clear all the fungus, including the osteomyelitic bone. This comes usually in diabetics, mucor cases, like, post-COVID, all that you would have known all that. So for that case, we give amphotericin, liposomal amphotericin B. In case of chronic granulomatous, so that is another condition where you will have rubbery fungus, immunocompetent individual. Patient will be completely immunocompetent, yet have mucor. We have seen a lot of cases like that. And in those cases, what we do is we do not chase the fungus. It is just, we have to open up the pathways. We don't go and, do orbital exenteration and things like that. We don't do that. And we put the patient on voriconazole. So all four have 4 different treatments. And all the 4 presentations are completely different from each other. So last case, if somebody says it's not fungus, then that means you have not seen enough fungus. That's the orbital fat. Can you see that clearly? If you have that, don't worry. You just have to use the coagulation a little bit. See, I'm using the debrider straight away on the orbit. You can see that I'm using the debrider straight away on the orbit. So all these you should give me J-curate. Blexley.
Also, in the post-operative management of allergic fungal rhinosinusitis, we keep the patient on these budesonide respules by irrigation.
Yeah.
That is mostly, for a long period of time.
Absolutely.
And, we also do skin prick test for fungal allergy and give appropriate allergen immunotherapy by the sublingual route.
See, the most important word to be underlined is fungal specific. Fungal specific allergen therapy. That's the optic nerve. That's the dura, which is completely dehiscent.
Yeah.
Give me Blexley. Now comes.
Janki, there is a question. Could you please elaborate on the 2x2 regimen that you mentioned a little while back?
First 2 weeks of every 2 months. This has been propagated by Stamberger. You can read the article by Professor Stamberger. First 2 weeks of every 2 months. The debrider, please.
And that will be for how long?
It depends. You have to go by the Katzenstein's classification. If you have the Katzenstein classification showing a little fungus here and there, then you have to continue. So that is how we follow up. Now, give me a debrider. No, not rat potty, straight. Now you see, almost I've cleared it. I have to just open up a few more cells. Very nicely seen. Hey, get the next case ready, man. I'm almost through.
So Janki, in such situations, how do you safeguard against causing trauma to the anterior ethmoidal artery?
Honestly speaking, anterior ethmoidal artery has been overemphasized in literature. Nothing happens if you cut this case. I'll cut the anterior ethmoidal artery and show you. Believe me, nothing happens. Actually, they create much ado about nothing. We are not afraid of any artery, including the carotid. You have seen
just like facial nerve in the ear, anterethmoid artery in the face, people are afraid of these two, sir.
Simply they want to tell don't do FES means they will say, oh, anterior ethmoidal artery, nothing will happen. Just see, I'm going to, for that alone, I will do this case. Give me J-curate.
I hope you have taken consent for the same. Huh?
What?
I said, hope you have taken consent for the same.
Suspender. What is it?
Safety, he is asking. Nothing will happen.
Boss, nothing will happen, boss. In anterior craniofacial resection, the first structure we cut is anterior ethmoidal artery. The intersphenoidal septum. Yeah, ira. Other sphenoid open through this sphenoid.
Janki, no?
Yeah.
Janki, when we were PGs, in certain the conferences, they used to demonstrate the posture. They used to tell that it was sphenoid.
Correct.
And don't go here, don't go there, like that.
Exactly. Blexley.
Sir, have you seen third ethmoid artery or artery of Kerau, middle ethmoid artery at any time?
Many times, sir. See the optic now. Can you see the optic now there very clearly?
Yeah, you're able to see that. Yeah.
Hello.
You're able
See
to
the
see
optic
that.
now here.
Yeah.
Can you see? Yes or no?
Yes, you're able to see that.
Absolutely clear.
Very beautiful.
Give me J accurate. See, that's the cella.
Yeah.
Now I'm just going to open up the
Frontal.
lower part of the sphenoid sinus.
Sphenoid.
Debrida, that's all. This is the sphenoid open completely. So basically what you have to do is to marsupialize all these sinuses. That is the dictum.
So the frontal area you will be going last.
Come again? What?
The frontal area you will be going last after finishing.
Yeah. Now finished, almost done the whole case. Now I just have to show you only a few things. One is the anterior ethmoidal artery. Second is the frontal. Third is the dura. And fourth is the orbit. So these are all the things I have to show. So if you have a sort of an orbital prolapse like this, don't worry. Again and again I say, what you have to do? What you have to do is take a coblation. Best is take the coblation. Or take bipolar. If you don't have coblation, take bipolar. Okay. Very simple. See, all these are like, just now we opened the orbit so beautifully. We opened the orbit. What was there? Nothing was there.
Just to begin that there is a fungus. So if you are irrigating, you can get some more.
Can you see the posterior ethmoidal artery there very clearly?
Yes.
See how nicely, bipolar, sorry, cobbleter blue. See what you do when you have a little prolapse, don't worry. Hey, Tanni. That's all, boss. That's all you have to do. Finished, over. Now we have gone. Now I'm going to go for the sphenoid sinus, optic nerve, posterior ethmoidal artery. Now I'll go for the frontal sinus. Give me 70-degree telescope. 70-degree telescope. Quick. I will do that last. This is nothing, boss. Next case ready, panne. Now here we are. That is the frontal with a 70-degree telescope. Give J curate. The first thing you have to do is to use the J curate. Always use the J curate, and you just palpate. It will lead you on. The fungus will lead you on to the frontal. See how nicely we were led on to the frontal. There is nothing there, boss. इसमें कुछ भी नहीं है. Much ado about just nothing. See, I am now giving irrigation.
Sir, can you press the eyeball, sir? Can you press the eyeball?
Wait. Don't worry. Don't be in a hurry, my dear friend.
Yes,
Nageshwar Rao Garu, don't be in a hurry. Okay. Give me frontal sinus suction tip.
Hello.
Frontal sinus suction tip.
Hello.
Yeah. Tell me.
Yeah. No, no, no,
Toronto,
no.
that's
My
16.
flight is by 9:50. So I'm leaving by around 7:30. Okay. How far is the airport from here?
Huh? Deepak Aldipura. Wow. Big boss.
Hello.
Hello, big boss.
Yes, boss.
Arey, big boss.
Hello, Deepak sir.
That neuromas,
Hello,
Huh?
good evening.
and then that fibro. Even that the first two cases were fantastic.
Ayo, second case was
Neuroma, the first one and the second, both were very good. No, the second was really good. This is child's play for you.
This is just nothing but even I want to show anterethmal artery alone. People are simply asking anterethmal artery, anterethmal artery.
Dr. Sethi had said that, no? Only in India, wherever it demonstrates, every time it
Anterethmal
demonstrates.
artery is much ado about nothing. Too much has been talked about this structure. The only thing you should not do is pull. Only thing you should not do is pull. Other than that, whatever you do to the anterethmal artery, nothing will happen.
Yeah.
So don't pull the anterethmal artery. If you pull, it will go into the orbit.
Absolutely. Absolutely.
Now you can see the frontal so beautifully seen. Can you see the frontal, all of you?
Absolutely. Yes.
Yeah, yeah.
Yes. Yes.
Even with fine irrigation, we are able to see. Yeah.
Deepak sir, Janki has to go to Chennai. Where are you going?
I'm in Kolkata actually. I'll be going back to Bangalore today night.
You are now in Kolkata.
Yeah. I think you because of that you helped me, no? Preponing my case yesterday to evening and
But I thought you're
I'm
doing
with
it on
Wi-Fi
Zoom.
in Mukesh. No. Zoom is with Renuka Bradu madam yesterday evening we did. After this, no, 7 o'clock, she had one program from CMAST.
Okay, now let me check which is the anterethmal artery. We have a lot of things hanging here and there.
Frontal sinus, posterior. Yeah.
But you have exposed the supraorbital cell very well and you're plugging the anterethmal artery.
Yeah.
Now let me check now. Hey, get the coagulation, man.
Here, when you are going deep, again, the fungal plaques are coming, no?
Give me a
Janki.
scissors. Give me a scissors. This is Dura.
Yeah.
Okay, my dear friends, people who are going on talking about anterethmal artery.
Nothing
Come on,
like that.
coagulator ready here, come on. Ready, scissors ready. Can you all see the anterethmal artery or not?
Yes, we are able to see.
Yes.
Either
Okay,
carburetor.
now see here what I'm doing. Just check. See.
Okay, now see here what I'm doing. Just check.
I have cut the anterethmal artery, my dear friends. See the lumen of the artery. Can you see the lumen of the artery here or not?
Yeah, very well seen.
What happened to this?
Hello?
What happened? Nothing
sir.
happened.
Hello?
Haldipo, sir.
Hello? Dr. Deepak ji.
Around 7:30.
Deepan.
Nothing happened. Much ado about nothing.
Much ado
Sorry,
about
Janki, I was
nothing,
another call.
but
Yeah.
nothing happened.
Don't pull the artery. That is what you should not do.
Yeah.
And whenever you want to resect the artery, cut it towards the intracranial side, not towards the orbital side. Very simple.
Yeah.
Give brother. See, I have cut the artery, clearly cut the artery. You see the lumen of the artery, very beautifully seen lumen. What more you want? This could be the middle eighth model or the post eighth model artery. This is the orbit. Now press the orbit, man. Can you see the orbit completely decent?
Yeah, yeah,
All of you?
Yes,
Yes,
Clear or not?
absolutely clear.
Yes, sir. Yes, sir.
See, I am now delineating the post eighth model artery also for you. Give me cob later. What is there? Nothing. Mahadevya sir always says, what is there, man? Like that. What is there, man? He will tell. His slang of English itself will give confidence. Hey, Sakshan Lama. Am I right, Deepak ji?
Yes, yes, sir. Yes, sir.
See, I am cutting the anterior small artery, posterior small artery, both. What is there? Nothing will happen. Give, quick. Now, you can use the coblation to cut, you can use the bipolar to cut, you can do whatever you want. See, that's the posterior small artery. Can you see that I have cut it already?
Yeah, already haircut.
Yeah.
Yeah. So that only the Mahadeva sir, he conducted a microscopic nasal surgery.
Yes. See, I have cut the anterior small artery, posterior small artery, कुछ भी नहीं है, कुछ भी नहीं है.
Still, there
Frontal.
is some amount of fungal element in the frontal.
I'm just going to wash.
Just to irrigate. Yeah.
That 60. I'm just going to see the maxilla first.
Yeah.
Then I will go for the frontal finally. See, that's all, boss. There's nothing here, boss. कुछ भी नहीं है. This and all is child's play. Okay, give me hue visor. So if you're not able to take it with at 60, don't go on doing something. Take a hue visor. Hue visor. Can you see the maxillary sinus, all of you?
Yeah.
Hey,
Yes.
J-curate. Now first you dislodge this fungus. The dislodgement of the fungus. You don't want fungus to sit inside. Okay, this is the first thing. Then second is you take the hue visor forceps. Best is hue visor. Hue visor forceps. And then see how nicely you are able to reach that area. See how much of fungus is coming out of the alveolar recess. Okay, that's it, finished. Now give me a good wash, please. Give me a good wash. Now I have to wash the maxilla frontal also.
Frontal.
Okay. Sorry?
The maxillary sinus in the What is that sinus to say?
Hello.
Hello.
Akshan. Hello, Satya.
Satya. In case you are not able to reach this with the Hue visor, then what do you do?
Then
You
go for
continue the
inferior
washes
medullary
or
anterotomy. Inferior medullary anterotomy.
You know, yeah.
Or you can go in for canine fossa
Canine fossa sublabial.
or pre-lacrimal approach. Anything you can do. You just have to have a lot in your kitty. Don't get stuck. That is the main thing. Good irrigation. Irrigation. So completely I have done everything to the fungus. I'm going to the next case now.
Okay.
Almost this is over. Pad 60. You go there. Shilpi, go. Shilpi, go to the next case.
Yeah. You're up.
We have 3 or 4 more cases.
Yes. Okay. Janki? Question from Vibhav Kepan. Shahapur. What do you mean? Auto draft. Is it
Auto draft.
Yeah.
Like auto mastectomy.
Yeah. Yes. And another question from Dr. Kapil Prabhu Desai from Goa. Hello, Janki.
Yeah. Ask.
Role of biological agents in recurrent CRS with polyps.
Yeah, biologics, yes. Use of dupilumab is very good. That's what now in Dubai I'm practicing that. When I go to Dubai, I practice that. But of course, in India, it's very expensive. 1.5 lakhs per injection. Every month for 6 months you have to give. So imagine the patient should spend a lot of money.
Since
if your patient is ready, then we can give. And J-Curate. They say that, of course, I don't have a long-term follow-up and all. Only 2 or 3 injections I have given so far. They say you have to give it for 6 months. That's the nasofrontal beak, anterior model artery, orbit, middle turbinate. So everything clearly seen.
And
frontal is beautifully seen there.
Hello, Dr. Achanya Chavala from Jaipur. Sir, which steroids and antibiotics do you prefer in AFRS cases?
What?
Which steroid, which antibiotic you will prefer?
Prednisolone 30 milligram.
Antibiotics.
Antibiotic is augmentin.
Another question from same doctor. Is bipolar artery useful? Is bipolar artery useful and enough for ethmoidal artery bleeding?
Of course.
Yes.
Bipolar is more than enough. You saw with the coagulation itself, we did it. So, any doubt so far? This is the common surgery which everybody will do.
And there is an appreciation from Pakistan. Bishop Riaz Safredi.
Riaz.
This child play in your hands, sir.
Thank you, Dr. Riaz.
Yeah.
Now, you see, the very important thing is what is called the checklist. So, the last checklist always will be the olfactory cleft. Straight debrider. You should always debride the olfactory cleft. Straight debrider. Always. Only then you will have good olfaction. Many people, they just leave behind a little bit there. And that leads to recurrence and olfaction is not good. So here, see what I'm doing now. See the polyp. This is a checklist I always have in my mind.
Medial to the middle turbinate.
Medial to the middle turbinate, yes.
Turbinate could be from a sinonasal.
And the debrider blade is facing the middle turbinate.
Yes.
Otherwise, it will cause bulgarization and anosmia.
Exactly. Again, you will lose olfaction. So now I'm happy about the whole. Anything, Dr. Vikram Kannaji, you want to add?
I was just wondering, after seeing this surgery, the MS and DNB candidates should not answer in their exams when asked how to handle the anterior ethmoid artery, in Mahadevaya style. What is there in there?
No, don't answer like that. You will be failed.
This is just on the lighter side.
No, but practically you should understand that if you cut it like this in the center, nothing happens. And only when you pull it, it will recoil inside. This is the carry home message. You should take the good carry home message, not the bad message that you cut the anterhythmal artery. So you should clearly understand why this demonstrator, what is his state of mind, why is he doing it? Not think in a bad sense. Okay. Another thing I want to tell you is that suppose if you have the artery like this, imagine, and you're doing suction, post-operatively you're pulling some crust, you can pull the anterhythmal artery. For that also what we do is we sometimes for post-operative follow-up, we do this. So all this should be remembered by you. This is optic nerve. Supraoptic recess is here. This is the dura. You can see the dura. Clearly the dura. Dural plate is eroded. And that's it. Thank you very much. Thank you.
Thank you.
Thank you so much. Thank you so much, sir. Thank you so much, panel. And I request.
We are going to the next case.
Yes,
the
sir.
next case is an interesting case again. It's a case of CS of rhinorrhea.
Commonly faced by many.
You want how many cases? You tell me. I have another 6 more, 7 more cases.
No, but you have a 5 p.m. flight also, no? You said.
No. It's been postponed now. Satya postponed it by another 3 hours. You want, I can keep showing you.
Thank you so much, panelist. And I request Paliyappan sir and Khanna sir to continue for the next case also.
Let us see who gets exhausted first, the surgeon or the panelist.
Surgeon will never, you know him. And Anthony sir and Nageshwar Rao sir is also there along with Deepak sir. He has to leave by 5. But then, if you will give a chance, he will not be tired till 10 p.m., 11 p.m. He will be on. Right, na?
Yeah, that speaks volumes about his
True.
physical fitness, to
Physical
which he gives a lot
and
of
the
attention to.
dedication, yeah.
You know, he's very particular with respect to his diet. He exercises a lot, plays badminton on a regular basis. So, the surgeon needs to be as fit as the patient on the table.
Very true. He is not well. Still, he is like.
Yeah, imagine if he would have been
Yes.
well, then maybe we could have seen one more case by now, given his speed.
Very true.
And full credit to the staff also of Royal Pearl Hospital, because they have been very efficient in changing the patients, getting the OT in order, and the team of anesthetists also, who are equally part of the team.
So, Janki, ready?
Okay. You tell me when I can start.
Yeah, we are with you, Janki. You can show us the scan and the site of the leak.
Who is on the other side?
Yeah.
So we have requested Khanna sir and Paliyappan sir along with Anthony sir.
Hey, Janagram, all of us are here.
All of us are here, Janki. Nobody is leaving today.
Okay.
We are with you.
Now this case is the case of. Hey, can we have some silence, please? Case of CS of rhinorrhea. Recently, we had a small, group, WhatsApp group controversy about what to do for cribriform leaks. That is the reason why I thought I'll show it to the juniors. So, how to tackle small leaks. So that is why I thought I'll select this case. I'm sure Dr. Anthony will remember that discussion. Dr. Anthony, Professor Anthony is there. Dr. Vikram Khanna also was there.
All of them are
We are all here,
Yeah.
Janki.
Yes, yes, very much, very much.
Okay, so I'm asking Dr. Soumya to present the case. She will present the case and then I'll take over. Can you post the next case? That where is your? Are you able to hear?
Yes, yes, very much.
Oh.
We cannot hear Dr. Soumya, but we can hear you, Dr. Janki.
Soumya.
Soumya, we cannot hear.
Dr. Soumya, we
Yeah.
cannot hear you, but we can hear Dr. Janki.
Hello?
Hello.
Hello, can you hear me now, sir?
Now we can hear you.
Yes. So the fifth case for the day, left-sided spontaneous.
We are waiting for this, sir.
Hello, sir.
Yes, go ahead, Soumya. Go ahead.
The fifth case for the day is left-sided spontaneous CSF rhinorrhea with resolving meningitis. A 32-year-old female presented with intermittent spontaneous left-sided watery nasal discharge for a period of 1 month. She also complained of fever and headaches since the last 10 days. She responded well to IV antibiotics. The spinal CSF analysis showed turbid fluid. There was no history of recurrent headaches or blurred vision or tinnitus. On examination, general examination was normal. Neurological examination was within normal limits with no signs of meningitis. Ophthalmic examination was within normal limits. The endoscopic nasal examination showed left-sided watery nasal discharge, which was noted in the medial side of the medial turbinate. Left-sided, the patient also presented with left-sided DNS. Oral cavity and the ear was within normal limits. Investigations, the nasal CSF showed glucose estimation of 64 mg/cent. CT cysternography showed left-sided cribriform defect. The MRI brain was within normal limits, and the vitamin D3 and serum calcium levels were within normal limits. I hand over the mic to Dr. Narayan Jankiram, sir. He'll explain the scans of the patient.
So, my dear friends, can you see me?
Yeah.
Yes, sir.
I want to have a small discussion regarding the CSF leak. See, number one is that many people go by, when they have intraoperatively the leak is coming, they think it's a high pressure. Please understand, high pressure CSF leaks are very rare in the basifrontal cistern. Basifrontal cistern is a low pressure cistern. Number one. Number two, what are the high pressure cisterns? Number one is the ventricle. Second is the posterior fossa. These two are the high pressure cisterns. Cisterns means a space in front of the brain. Number one. So now there can be BAH. Not that we will not have high pressure. Don't overdiagnose high pressure leaks. I have recently seen one person told me 25% of his cribriform leaks are high pressure, which is directly an overkill. It's a direct overkill. Not even 5%, not even 3% of our cases are high pressure. We have done more than, now is nearing 4-digit numbers of CSF rhinorrheas. And I am writing a book also, already written a book, and we have analyzed so many cases. So let us understand that if you are diagnosing a high pressure leak, then you should have specific criteria. Like, for example, MRI should show tortuosity, empty cella, slit-like ventricles, dilated Meckel's-cave. Then you should not have a sigmoid sinus, lateral sinus thrombosis. We have seen at least now 4 to 5 cases of lateral sinus thrombosis producing increase in intracranial hypertension. And then you send it to the neurologist. Neurologist will do a fundoscopic examination. And if the fundus is showing signs of BAH, only then you take it as BAH. Symptoms also will be different. Patient will have pulsatile tinnitus. You will have headache. You will have sixth nerve palsy, sometimes seventh nerve palsy. These are all symptoms of BAH. So, if the patient has got a leak, Paul, please understand, the leak in a cribriform is a pseudomeningocele. What is the meaning of pseudomeningocele? Pseudomeningocele means See, the olfactory fibers, they pierce the cribriform plate. And when there is a high pressure or maybe there's some erosion of the bone or whatever, the meninges, especially the arachnoid, it just prolapses. It is not a true meningocele means what? All three layers of the brain should be there. Whereas pseudo means not all three layers are present. So what is usually present is the arachnoid. So if you just locate it, it will be 2 millimeter, 3 millimeter defect. And there is no point in breaching the layers given by God. God has given dura, arachnoid and pia. There is no point in just so in an effort, this is written beautifully in paper law. In an effort to search for a leak, don't create a leak. Point number one. In an effort to close a leak, don't enlarge the leak. These are all dictums given by standard authors. I am not telling this. So there is no point in saying that I repaired a 10 centimeter leak if the patient is having a pre-op 1 millimeter leak. So this is all bakwas ka baat. So please understand, be as conservative, and the choice of your repair should depend on the size and the pressure of leak. If it is going, so small, medium, large. Small means 1 to 5 millimeters. 6 millimeters to 1.5 is medium. Above 1.5 is large. If it is a large or a medium, there can be sort of a nasoseptal flap. Whereas for small defects, it is not nasoseptal flaps. Point number one. If it is going to be a high pressure leak, please understand, you should always close the leak, but combine it with either a diversion procedure or with a lumbar drain. If your neurosurgeon doesn't advise it, then I think he doesn't know what a high pressure leak means. So you will have a defect. Even if you close it, it will just push that whatever you keep and come out. So these are all things you should remember. You should try to maybe because you have not diverted for 3 cases, 4 cases, you have escaped, doesn't mean that that's the standard protocol. The standard protocol is you should have a diversion procedure. Okay, so this is all textbook descriptions. It's not my description. So what is a diversion? You can take a thecoperitoneal shunt, ventriculoperitoneal shunt, whatever shunt you want, or do a lumbar drainage for 5 days, and you should adequately drain CSF.
Hello.
Patient on a CSF rhinorrhea, if the patient presents the idiopathic CSF rhinorrhea, I've seen multiple doctors putting the patient on Diamox. Please understand, Diamox is not the treatment for CSF rhinorrhea. Very, 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 very important statement. Many people put the patient on Diamox thinking that, okay, this is a treatment. I've seen even now, last week alone, we have seen 6 cases, out of which 4 cases had Diamox given by neurosurgeons. That is not the treatment. You are not supposed to give Diamox if you have diagnosed a CSF leak, because you're going to postpone that or get the patient into meningitis. This is what you're going to do, because there's ascending infection. So if you have a case of CSF leak, first collect the fluid, send it for beta-2 transferrin and glucose, and then do either a HRCT with MRI, MRI T2 heavily weighted, or MRI with contrast, GAD, which will stay there for 24 hours. You can repeat it. Or in our center, we do a CT cystinogram. CT cystinogram, after that, sometimes the leak might stop. Another important thing. So that's also a pseudo feeling. So you have any questions regarding this? You can ask me.
Yes, I have a question. What is your take on CSF manometry? There was also talk on the group about doing CSF manometry right before and diagnosing a VIH based on that. Do you still feel that if there is no signs on
send our
MRI?
patients, once the MRI is giving us the indication, we send it to RKE, and RKE does a manometric examination. And if the opening pressure is more than 20, 25, then there is a chance that their patient will have high pressure. Or put in a lumbar needle, the CSF will gush out. Then you know it is definitely. But if the patient is actively leaking, then it can be sometimes, low. The opening pressure can be low. So this is the only thing, but mostly it is high. You can clearly say BIH, if you don't have a tumor inside the brain, if you have CSF gushing out, not out of the nose, but opening pressure in the spine, then it can be KH.
So
Having said
what
that,
is modified Dundas criteria? What is modified Dundas criteria?
yeah. So if you have raised intracranial pressure without any evidence of space occupying lesion, without a thrombus in the lateral sinus, with headache, with pulsatile tinnitus, with sixth nerve palsy, with an MRI giving findings of flat sclera, with a tortuosity of the optic nerve and widening of the perioptic space, slit-like ventricles, empty sella, dilated Meckel's, this is modified Dandy's criteria. Now you can see here, this patient, you have a bony defect here. Has been marked. You can see also the intrathecal contrast, metrisemide coming out here. So this looks like the foveal defect. It looks like a foveal defect. So foveal defects generally, what is the difference between a foveal defect and a cribriform defect? In a cribriform defect, what you do is we don't dissect the ethmoids at all. Whereas in a foveal defect, we dissect the ethmoids. This is the only difference. We don't cut the middle turbinate in a case of a cribriform defect or a foveal defect. We generally don't do that. So with that in mind, I'm going to start my surgery and then we will see what we can do about it. Patient has got a septal deviation towards the left side. You can bear a section at 12. Here is 12. Parola. Let's go. Khatam de nala. So, who is moderating this session?
Oh. Hello.
Hello.
Sir is here.
Nageshwara from Visakhapatnam, sir.
Oh, Nageshwar Rao Garu. Excellent. Excellent.
From Visakhapatnam, sir.
Excellent. Excellent, Dr. Nageshwar Rao Garu.
Yeah,
okay, let's get started.
Yeah. From the hall, we have sir with us. So
from the hall,
moderating.
Who is moderating?
Dr. Palniappan.
Oh, Dr. Palniappan, sir, how are you?
Yeah. Fine. Yeah.
Are you getting the endoscopic picture, please?
Yeah, we are getting endoscopic picture now. Just to focus.
Now?
Yeah.
Okay.
Clear.
Done my best.
No problem.
You can see the cribriform.
So we are packing with 1 in 1,000 adrenaline. Dr. Shilpi has done it.
Sir,
and if you have a gross deviation like this, then it is better to do a septal correction.
Yeah.
If you have a gross, give me infiltration. So I'll do it in 2 minutes. Yeah, don't hesitate to do all these, because if you have gross deviations, then you do. If you don't have gross deviations, you can manage with just.
Septum suction.
Okay, see what I'm doing now. This is infiltration with saline. Just saline. Okay, now here we are.
One more question. You were talking about the size of the defect determining the type of closure that you would do. Will
Yes.
unilateral and bilateral defect also change your closure?
Of course, yes. If it's going to be bilateral, then first of all, multiple idiopathic defects. Think about BAH, multiple. And if you have it on either side of the septum, then you should always try to either close it individually or a single closure. I'm telling something. See, I have had patients. I've seen it in conference also who are diagnosed CSF rhinorias, and in the conference, in front of everybody, they couldn't find the leak. They couldn't find the leak, and it turned out to be allergic rhinitis. So that's why we always, and what do you do for that? People go for carpeting. There is no role for carpeting. There is no role
That's why
for
I asked, because
skull-based
there was
carpeting.
talk of carpeting the skull base also.
Huh?
Because when we spoke about that, there were people talking about carpeting the skull base also.
No, you should
So
never
I just
carpet skull-based. That means you don't know what you're doing. You have no clue of what you're doing. So all these are wrong concepts. So are the people from Sun Pharma there?
Yes,
Yes, sir.
they are very much there. Yeah.
Who is
Anything
there? Mr.
specific?
Mohan. Who is there?
So we are here. I'm Dr. Vijay. With me, I have Archana, then Shuklaji, then we have Dr. Ganesh.
Excellent, excellent.
Yeah, so the
whole
entire team is here,
there.
sir.
Entire team is there. Very good, very good. I hope you are enjoying the.
Absolutely, sir. Absolutely.
So we have already. This is the fifth case, right? This is the fifth case. Huh? Fourth case. Huh?
Yeah. Fifth
case we are doing, and apart from that, we have already finished. Yesterday we had 4 cases, right?
Right, sir.
So we have done 11
Yesterday
cases
also
in this
5
conference.
cases. 4 cases. 2 by Dr. Kameshwaran, 1 by Dr. Vijendra, 1 by Dr. Deepak Haldipur, and 1 by Kirtane sir at Hinduja, Sangeeta Varti. 5 cases yesterday.
5 cases, right, sir. Yesterday
was 5.
Yeah.
Today is 6.
6.
So this is something which is very, very good for. Hold. There's a tar. It's okay. It's okay. Hold. Elevator, because I'm not using my elevator. It's okay. It's okay. It's okay. No problem. Sometimes when you do too many cases, you don't get that again back. கேட்டா தர மாட்டேங்கிறாங்களா நீ பேசக்கூடாது புரியுதா நான் கேட்டா தர மாட்டேங்கிறாங்கன்னா புரியுது நீ கேட்டா தர மாட்டேங்கிறா Okay, leave, take it off. Take it off. Oh, scissors. Okay, now I'm almost done with the septal correction. The small tear, if I want a Haddad, then I will think about it. If not, I'm not bothered. Scissors, please. Not this, my dear friend. Okay, so it took hardly around 2-3 minutes for me to finish this. See the little cholesterol. That is because of the marrow. Quick. You should be quick, my dear friends. I can't wait for you. Suction. So in Madras, is Dr. Anthony there?
Yeah, he's here.
He said he wants to leave. Is it?
No, he's here.
Now I'm just going to do what is called the assessment. Is it enough for me? Or you have a little above? Yes. See.
There is high deviation.
Yes. See that one.
Janki? Hello?
Suction.
Janki?
Yes, sir. Yes, sir. Please tell me.
Kitne sir here?
Oh, Kirtane, sir.
Yeah.
Yeah, I've been watching all throughout, just keeping quiet and admiring what's going on.
Sir.
Yes.
No words, sir. I don't know if I'll be like you at your age.
What do you mean, my age? How old do you think I am?
Sir, he is very young. Janki.
No. He's the
You
youngest.
play badminton with me, I'll show you.
Ayyo. Sir. Sorry, sir.
Okay.
Okay. Now, what I've done now is I have just done a septal correction just to visualize the cribriform plate. So that's the first step I have done.
Kitne sir is very slim, young, energetic here.
No, he's the most handsome boss.
Yeah.
Yeah, can you give me a role in one of your next movies then?
He's asking for
Sir, one of my movies, I am old, sir. Nobody's giving me a chance. You will get easily.
I have to talk to Satya now.
Yeah, sir. Okay. Now here we are. I'm now going to see suction. Now you see this is the axilla of the middle meatus. Okay, so what is it that you have to see when you look for a cribriform defect? Of course, this looks like a foveal defect, but I want to show you what to do. See, whenever you start from the sphenoid sinus. See here, first is lateralization of inferior turbinate. So this is the first step you do. Okay. The second step is you start lateralizing from the, see the superior turbinate. Can you see the superior turbinate?
Yeah.
Now you have to start from the superior turbinate. See, don't start from the middle turbinate. This is the superior turbinate. Then lateralize the superior turbinate. Suction. So this is the first step in locating a cribriform site leak. So what do you see when you lateralize it? You are seeing the supreme turbinate also, is it? Okay, right. Elevator. Now,
Sir, as you have time, you please explain some mathematics in the antiscal base for CSF cases.
Yeah. I'll do that. So you have to locate that's the sphenoid sinus. Can you see the sphenoid os there?
Yeah.
All of you?
Yes.
Now you have to start seeing from here, the last part. That is the last part of the cribriform. See here. Usually it is not present there. It is a very unlikely site. Now you come anteriorly. Now as you come anteriorly, give me elevator. Now you have to look for the following sites. Number one is you look for the level of the anterior ethmoidal artery. Suction. So hold. Elevator.
So the commonest problems in cribriform plate leaks, which I have at least noticed, is inadequate pushing of the middle turbinate to visualize the olfactory cleft. That is what I have seen back. So you have to push it nicely to see whether you are able to see the pseudomeningocele. Now give me a pack. Now I'm going to place the pack now. I think I have done a good job by pushing the middle turbinate laterally. Of course, according to the scan, it was a foveal defect. But always examine the cribriform plate before you go for the fovea. This is dictum. I know that there was definitely a foveal defect. Even then, I wanted to examine the cribriform plate because 90% plus of the leaks which are idiopathic for fat female of 40 are cribriform. So you might have 2 leaks, cribriform might be missed, and then you will land up in problem.
Yeah, you can see a small pseudomeningocele there.
Exactly. Exactly.
Yes.
Now, you ask your anesthetist to give a Valsalva. Now, wait. Ready? Start. Okay, see the pseudomeningocele, what it does is that it's a thin layer, and unless you actually open up that layer, it will not leak. Many people think with the pseudomeningocele you might have a leak. Sometimes it doesn't happen. So this is definitely a pseudomeningocele. Professor Kirtane sir would have seen the maximum of all these.
Yeah, but Janki, if you miss this and if you go and close the fovea leak,
yeah,
after a few days, this fellow will start leaking.
This fellow will start leaking. Absolutely.
Because the pressure now, that pressure valve which was letting the CSF off from the fovea,
yeah,
once you have sealed that, these patients very often, if you see in the MRI, have an empty cellar, indicating some elevation of pressure. And if you close one, if you don't tackle this one, it will leak from there.
Exactly. So now what I'm going to do is to give a small merocil. I just want to place that to identify that area so that I don't miss that area. Or give me a coblation. So what I can do is I use that as a marker. You can use this coblation as a marker. Give. See, the first CSF leak closure properly demonstrated was by Professor Kirtane sir. I saw in Kambala Hospital. I can't forget those days. So I'm just making a small, that is just to so that later I don't miss that. Okay, now you can clearly see that the leak. Anyway, now I'm going for the fovea. Now, elevator. So, first of all, whether there's a foveal leak or not. See, sometimes the scans are highly deceptive. Okay, now give me a backbiter. So, you see here, what you really want to do in a CSF leak is you want to examine the skull base, the complete skull base. So the skull base starts, from the posterior wall of the frontal sinus, ball probe, and then it goes along the anterior fovea, posterior fovea, planum, sphenoid. So you want to examine the complete part of the skull base. So I'm just going to take off this.
Janki, this initial packing that you do is also with 1 in 1,000?
Yes. That is pre-operative packing is 1 in 5,000.
Okay.
So the first packing is done outside the theater is 1 in 5,000 because we don't know any reactions or anything like that. So we pack it with 1 in 5,000. But once the patient is on the table under anesthesia, the anesthetist is in full control, then it is 1 in 1,000. Now you see that's the suprabular recess, very clearly seen. This is the bulla. See how easy you can actually perform that in a very, very nice systematic fashion. Give me straight debrider. Straight blade, please. Now I'm just going to take off a part of this bulla. Okay, now that you can see how beautifully the artery is seen there. Come on. Quick. Now
Where
the
was
idea.
I missed that, Janki. Where was the foveal defect in relation to the artery? Was it
Posterior.
posterior to the artery? Okay.
According to the scan, but I still don't believe the scan. More block more. So that's the skull base. You can see the skull base very beautifully. That's the anterethmoidal artery. Quick. 2 minutes. I will just examine the fovea. If it's not there, then straight away go and just lock the cribriform and come out. That's it. Why let us sleep? Come on. Why are you waiting? So here, the most important thing here I want to tell you, the difference between a normal FES and a CSF leak case. The difference is here we remove the mucosa. We wantonly make the bone naked. Whereas see how I am taking off that bone. This is the sphenoid sinus, very clearly seen inside. I mean, this is not the sphenoid, that's the posterior ethmoid skull base. Debrider. So this is the sphenoid sinus. You can see here. See here, that's the sphenoid sinus. So the moment you see all these partitions, tuck, you should recognize. I'm now taking off that. Give me J curate. J. Or give me.
Janki, there's a question from Chandigarh by Dr. Handa.
What?
Question from Dr. Handa from Dr. Chandigarh. What could be the most probable cause of CSF leak in this case?
Cause of the CSF leak.
No. In this case, what is the probable cause?
For this
Spontaneous,
case,
right?
In this patient,
since we have not been able to cite an active leak on table, but on the scan,
but you have already seen a pseudomeningocele, right?
No. What could be the reason?
Yeah,
That is the question
idiopathic.
there is.
Idiopathic.
Idiopathic. Sir.
Not all pseudomeningoceles are high pressure, my dear friend.
Yes,
I
that
think
is
he
the
wants
question.
me to say that it's high pressure. No.
That is the question they are
there's
asking.
another question from Kolkata by Dr. Dharmendra Kumar that if there is an asymptomatic suspicious leak in the post-operative period, say after 3 to 6 months, then what diagnostic test would you recommend?
What? I don't understand the question.
What question is that in the post-op period, say around
Of a
6
CSF leak
months,
or FES, sir? What is the post-operation done?
in this case, in the post-operative period, if there is a suspicious leak, which is asymptomatic.
I think the question is about post-operative, after CSF leak closure.
After
If
CSF
there is
leak
suspicion.
Janki, I'll
You
just come in
suspect-
here. If you have a CSF leak repair done, and the patient leaks after 6 months, it's very unlikely that your repair has given way. This is a fresh leak. If your repair is going to fail, you'll get a leak much earlier. It's not after 6 months that your repair will fail. So the fresh leak that occurs after 6 months should be considered as a second fresh leak. You'll have to look for causes for that.
So the fluid will have to be sent for beta.
No, you have confirmed. You said it's a CSF leak, which I assume you have already confirmed that it is beta 2 transferrin. Of course, you will check that it is beta 2 transferrin. But the point I'm trying to make here is that if your repair is going to fail, it would fail immediately post-operatively, not after 6 months.
Yes, true.
And there is a comment by Dr. Zalag from Morocco. His comment is that since we are doing a septal correction to create space for doing the surgery, would it not be more better to take the mucosal incision on the septum on the contralateral side to prevent bleeding and oozing on the site of surgery?
Yeah, but as you saw, even if you take it on this side, it's not bleeding very much. So theoretically, yes, you could take an incision on the other side.
Yeah, the message is he has made this comment for the residents.
Yeah, but very often, we see the deviated portion coming in your way, so you know exactly where to place your incision and how much to remove. So
Correct.
I don't think it really matters so much.
So if you look at the fovea, there's nothing.
Janki, is it possible to see that? I was not in the room when the CT scan was shown. Is it possible to have another look at the CT scan?
Janki, hello.
Yeah, I'm showing you the CD.
Yeah.
Can you see? Can you see, sir?
We can
Not
only
getting the
see your
picture.
name flashing on the screen.
Not getting the picture. City.
The sphenoid sinus just in front, you can find some polypoidal.
We do not have the CT scan picture on it. We have the endoscopy picture on the screen. We don't have the
CT picture.
Sir, Kirtane sir wanted to see the CT scan
Janki,
picture.
external camera. Yeah, CT picture. Yes.
You can see here there's a suspected area.
No,
and
but
you
can we see the? Yeah, no, but there is no leak there. There is no. Can we have a look at the coronal scans 1 minute? The ones on the extreme left. Go. Yeah, just let's have a look at those.
Looks like a cribriform only to me.
Yeah, but it's not very. You've got bone windows.
Other scans. Other scans.
What is the size of the slices cut, sir?
What is the?
What is the
Slice, cut slices. Slices.
This is 3 millimeters. 3 millimeters.
Yeah, I think when you're looking for a CSF, we tend to go much thinner, maybe 0.6.
0.6.
Yes. So
You can see here that was also not very contributed. This is a contrast. CT with contrast.
yeah, so
You have the DICOM?
not very convincing. So I think you just have that medial lamella leak, which you should just go and patch. Looks like it, yeah.
So with your permission, I will like to have some announcement.
Are you getting the this one? The endoscopic picture, please?
Yeah, we have the endoscopic picture now, yeah.
No, this is the
It's
fovea.
quite convincing that there is no leak in the
fovea.
Yeah.
You're able to see the
skull base very clearly.
Clearly, and the lamina also very clear.
Elevator. Now what I'm going to do is to see the area which I suspected before, but I marked that also.
So pseudomeningeal.
Yeah, very clearly seen.
Yes.
Yeah.
So that could be the site.
Now what we can do is, see, that's the olfactory filament here.
Yeah.
Now, just give me the bipolar. I'll just try to elicit a leak now. If you...
Yeah, I think there was a question from Aman, from Dr. Khalid. In one of your previous CSF leak repair operations, you said failure can be because of coblation. So you prefer to use a bipolar cautery.
Yes.
I think he used the coblation only to mark the area, and he's now going to use the bipolar cautery. I hope that answers your question, Dr. Khalid.
Absolutely.
The coblation was used only to mark the area so that he would not miss it out. But now what he's doing is he's using the bipolar cautery. So your observation is absolutely correct that he is using a bipolar cautery.
Sir, what is your take on making this leak very big and...
No, absolutely not.
I learned from you, maybe the latest concept has changed or something like that.
No, I would say just scrape, make the area raw, pack it, and the adhesions for the first time, ENT surgeons, enemies become friends. The adhesions that form in that area are the strength of your repair. Yeah.
You used to say there are two areas in ENT nose where adhesions are friends. Number one is CSF leak, number two is bulgarization.
Absolutely, yeah.
I still have those words ringing in my ears.
You have tinnitus.
So here the idea is to do an onlay repair, not to do anything very funny, not to, you know, these are all
defect
small.
is usually so small, it's barely a millimeter or so. So there's no point in increasing it. I have seen some people actually cut the middle turbinate, put a Hadar flap. I think it's totally unnecessary for this defect.
Absolutely. So this is how I learned from Professor Kirtane sir, and I've been practicing this for a long time without any failure. So I don't see any reason why I should change. Give me fat.
With your permission, I will like to have one or two announcements, sir. Can I do?
Why you want to ask? You should ask Kirtane sir permission, not my permission.
So, very happy to again announce that we are currently having 6,000 plus viewers who are watching this surgery. And one question is asked again in the question answer like platform, how to get the MMC certificate. Actually, yesterday also we have mentioned that in invitation there is one QR code, and you need to scan the code, fill in your information, and then there are 4 credit points. Obviously, as per your attendance, I feel AOI will provide the credit point certificate to you on your mails. So I hope this has answered many queries on the platform. Thank you so much.
Janki?
Yeah.
Dr. Achala, who was doing a fellowship with me at Hinduja, she went back and took out records of previous 17 years. And we phoned up these patients or wrote to them on email, etc. I think in one hospital alone in Hinduja, she could trace 151, 152 patients where we had done this repair with just fat, and believe me, no failures. And this is a 17-year follow-up.
Wow.
Great. So we'll be publishing this, but it was really gratifying to know that this works. Otherwise, I would not keep on doing it year after year. If it failed, nobody would want to keep on doing it again and again.
No, you would have told me, no, don't do like this, at least. You would have told me, I have learned this technique only from you, and I have been doing it and I have not faced failures. But now, if they say you open, make it big and things like that, I feel a little confused.
No. I think I remember being with Professor Plester when he was doing some stapedectomy and he was using a metal piston. And I said, we use Teflon. So he looked at me and says, are you happy with what you're doing? Are you getting good results? So I said, yes. Then he says, don't change just because I do something different. If you are getting good results with what you're doing, just stick to it.
So here, Dr. Kirtane sir used to use a small gel foam. He will keep a gel foam around the fascia.
I use a Surgicel now, which is even better to use now because it sticks to the fascia and it pushes it in very well.
But when I was there, you used to use gel foam.
Gel foam, yes, because that time I had not started using Surgicel and we didn't have glue at that time. Now we have glue as well. At that time, there was no glue.
Tanki, this is a fascia from?
What?
Hello.
This is fascia. I kept Surgicel between
the fascia taken from thigh, sir.
Yeah, fasciolata.
Fasciolata.
Okay. Come on. Finished. Give me a small Surgicel. In my opinion, Haddad is just a overkill for this.
I think when the break in the skull is just about a millimeter or two,
yeah,
I don't think you really have to go for that. Yeah. It's a different thing when you have the fovea leak where it's much bigger.
Yeah.
Then I would definitely want to do the bath plug, get something inside and outside.
Exactly. Elevator. Now you see, the most important thing which I learned is how to use this middle turbinate as a stent. See that? This is the key. Now, this is the key. I've created two raw surfaces there, and that is going to unite, and that is going to give us a beautiful stenting. I keep a little Merocel here, and that's it. So I think this is conveying the minimalistic approach towards cribriform CSF leak as taught by Professor Kirtane sir. And I think we should all, follow time-tested methods of surgical closure. So don't unnecessarily cut the middle turbinate. The middle turbinate is a lovely stent, lovely stent. So here we are. I think I've finished it. Thank you very much. I think, So I think I will not continue because we have done already 5 cases.
Fantastic job. Janki, your stamina is something. This is when you're not well. What would you do when you are feeling all right?
Sir, I am your student.
Why is your theatre light so green? Everything is appearing green to us. Now it's okay.
Yeah. So that's it. I'm really thankful to Professor Kirtane sir for to conceptualize this Elite ENT club, and also I thank all the faculty members like Professor Mohan Kameshwaran sir, Professor Vijayendra sir, Dr. Deepak Haldipur sir, Dr. Nupur Kapoor madam, and of course my teacher, Professor in Padma Shri Milind V. Kirtane sir.
Dr. Sangeeta Varki.
Dr. Sangeeta Varki madam also, and Dr. Vinay Vijendra and Dr. Vijay Nandan also. So really a big thanks for Sun Pharma for this opportunity. I hope we could satisfy all elite audience who were there in more than 100 centers. I heard 6,000 people watched this program, and unbelievable. If we have 500 people in a conference live today, they call it a super hit conference. And if it's 1,000, out of the blue stuff. But imagine on one click, 6,000 people have watched around the world. And today, I think this is the technology we should follow. And I, with Professor John of Miami, he's a neurosurgeon, we used to do these programs well before COVID. And John used to say, I still remember, he used to say, this is the way ahead, Jana. This is the way ahead, Jana. So we used to do a lot of such programs far earlier than COVID, maybe around 10 years before we used to start Facebook Lives and things like that. Hey, he is in charge of neurosurgical TV. We did it for neurosurgeons. And thanks, I remember you, Professor John, wherever you are in Miami, lovely person to move with. And now we are here with, Sun Pharma and Dinesh. I hand over the mic to my teacher, Professor Milandivi Kirtane sir, to give the closing remarks.
Before that, Janki, thank you. Janki,
Thank you, Pandyapan sir.
Yeah, thank
Big
you.
applause for Dr. Janki, guys. Come on. And to the team, Sun Pharma, fabulous organization. I think you people have done a wonderful job.
Thank you so much.
Very selfless. You've given us a free hand to do exactly what we want, and you've managed the backstage things beautifully. Carry on. I think we hope to see even a better audience in the next ENT Club meeting. And Janki, God bless you. I think keep working hard like this. And till the next program, we will meet soon again.
Thank you so much. Sir, can I request Mr. Amit Shukla to have an official vote of thanks, please?
Sir, Nageswara sir, good evening, sir. Janakram, sir. You have shown excellent cases today, and we are very happy here. Here in Government ENT Hospital, in the presence of Dr. Jeevan Pradipkar, HOD, arranged all these things in the seminar hall in Government ENT Hospital, Andhra Medical College, Vishakhapatnam, sir.
Excellent. Thank you so much, Dr. Nageshwara garu.
Thank you, sir. We will look forward, sir. Namaste, sir. Thank you, sir. Thank you.
So, good evening, everyone. I'm Amit Shukla. It was really indeed a great pleasure and privilege to be part of this wonderful academic feast. From the bottom of my heart and on the behalf of Sun Pharma, we extend our gratitude to all the faculty, especially Professor Padam Shri Dr. Milind Kirtane sir, Dr. Janki Ram sir, Dr. Mohan Kameswaran sir, Dr. Vijendran sir, Madam Nupur Nururkar, and Dr. Deepak Haldipur sir for the excellent surgeries and excellent involvement and the extraordinary support what they have given to us. Last not the least, Madam Sangeeta Vardi, who has very beautifully done the surgery of cochlear implant. Special thanks to Dr. Kirtane sir and Dr. Janki Ram sir, because without both of you, sir, it was never ever possible to have this type of wonderful platform where doctors are not only enriching with your experience, but the live surgical cases, they are remembering for a long. I would like to convey my very sincere thanks to all the wonderful audience who were physically present here, and all the audience who have joined virtually, not only from India, but from abroad as well. So thank you very much. At the last, I would like to thank all the panelists who have really done a wonderful job by explaining, by asking the questions, and it was very easy and smooth journey for all the participants. In the last, I would like to thank the medical department and the entire team of Sun Pharma for making this event wonderful and memorable. We at Sun Pharma is always here to facilitate all the academic programs, and we will definitely work to make it even better when it comes to the ENT Club program season 3. So thank you each and everyone for your excellent participation. And again, a very heartfelt thanks to Professor Kirtane sir, and the person who is full of energy. And when I personally usually, whenever I talk on phone to Janki Ram sir, lot of transformation of energy I got from him. So thank you sir, thank you very much. Thanks.
Thank you so much, AOI team also. and the technical team, and hundreds of our Sun Pharma colleagues who have worked without any energy loss during last few days. Thank you so much, all of you, and see you in the next season earlier. Thank you so much.
Thank you very much. God bless
Thank you so
and
much.
bye-bye.
God bless you, sir. Thank you so much, Kirtane sir. God bless you, all of you. Thank you so much. Wonderful audience.